test, check, test, 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 test. Test, 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 check, check, hello, check, check, hello, check, 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 hello, 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 लिंक जा रहा है ना चेक 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 हेलो 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 टेस्ट टेस्ट चेक चेक टेस्ट टेस्ट check check test one test T
हेलो 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 हेलो
हेलो हेलो
Good morning, delegates. We all cordially very good, very
and
good
warm welcome
to you all
in our
city of joy,
city of joy,
Kolkata.
that is city of Kolkata.
We
We
from the Endocrine
from
Society
the
of
Endocrine
Bengal
Society of
cordially
Bengal
invite
all the
all the
and
delegates, all the
and
speakers,
all the speakers, all the faculties,
residents,
all the
who are
residents,
present
all
here
who are present here
to this
to this
auspicious
ceremony
of knowledge and
of
education
knowledge and
Crescendo
education, that is
2024.
Crescendo 2024.
Our scientific station
Our scientific station
are just starting.
starting.
So we
invite
all
everyone
invite
who are
everyone
there,
who are there,
yearning
who
for
are
some
yearning
knowledge,
for some
to kindly
knowledge,
gather here,
to kindly gather
because
here.
we have
Because we
a
have
star-studded
a
performances,
star-studded performances
which are just going to happen now.
going to happen
So,
now.
for
For
the
inauguration
and
for
and
the first
for the
deliberation,
I would like to call upon stage none other than Dr. Belinda George,
Dr.
Madam,
Belinda George,
from
Madam,
St.
from
John's Medical
St.
College,
John's
Bengaluru.
Medical College, Bengaluru.
We know
Madam
that
is
Madam
an
is
esteemed
an academician,
esteemed as well as
a beloved faculty,
and
she is also
the teacher of many of us.
So, Madam,
A warm
madam,
welcome to you.
a warm welcome
Thank
to
you,
you.
ma'am.
Kindly
Thank you,
bless
ma'am.
us,
Kindly
with all
bless
your
us with
knowledges.
all your
Thank you, ma'am.
knowledges. Thank you, ma'am.
Thank you, Dr. Dr. At the outlet, let me also thank the Endocrine Society of Bengal for inviting me here and giving me this opportunity. Can I have the slides, please? So the topic is urine review, PPGL, which is paragangliomas. So if you look at what has happened in the last 1 year in the field of PPGL, it's actually got to a lot newer medical therapies which have been introduced in the PPGL. That will be a large chunk of my and talk. Following that, a few articles I will also share, which has been published in the last 1 year. So I'll wait for the slides to come. Otherwise, it may not be very useful. Okay, maybe I will start. It's up there in the corner. Shall I start? Okay.
We apologize for the technical glitch. We are just going to fix the issue right now.
Okay, great. Thank you very much. Thank you very much. Outline for today's session. We will look at the newer therapeutic options, and couple of other articles. About choice of surgical intervention, a little bit about imaging updates. Today, I think in today's era, no talk is without mention of artificial intelligence. And lastly, some data or some work from our own country. So fears and paragangiomas, essentially neurobreast tumors, considered benign most of the time. If at all they metastasize, they call metastatic, and we don't really call them malignant fears anymore. However, even though the primary tumor is easy to resect with a single lesion, once they metastasize, they're notoriously difficult to treat, and most of the therapeutic options we have only aims to stabilize tumor progression, and really will not cause regression. And some of them can be quite aggressive and can end up with morbidity and mortality. So if you look at the therapeutic options, predominantly it's not curative in all. We also have a branch called theranostics. This is when we give radionuclide agents to treat the tumors. But here mostly it's only used in slow-growing tumors, not rapidly growing tumors, because stabilizing tumor and not really aggressively controlling them. The only option we have is chemotherapy, which includes a regimen. We also have a few other drugs like TKIs and captain. However, PPGLs are a very heterogeneous group of disorders. So we can't use a one-size-fits-all approach. But in the last couple of years, there has been a huge amount of advance with regards to newer therapeutic options. We're all very familiar with the genetic classification. We have cluster 1, cluster 2, and cluster 3. And based on this genetic classification, we also have various therapeutics which are useful, or which are proven to have benefit depending on the genetic phenotype. However, there is also something called immunosignaling, where classification is based on immune cells which are expressed within the tumor. There are different types of classification. I have just shown you one example. There are 5 different immunotypes. And basically the type of immune cells which are predominantly present within the tumor, either it can be macrophages or NK cells or mediated markers. So depending on that, we can direct the kind of immunotherapy that has to be given for each of these tumors. So for us understanding briefly about immune surveillance and editing of which is not just for PPGLs, but so there are three phases of immune regulation of tumors. First phase is when the immune system is calling elimination phase, where there is eradication of tumor cells. So you have tumor cells progressing, but the immune response is able to tackle it and kill all the tumor cells. The second stage is when you reach a phase of equilibrium. There the tumor cells beginning to become a little bit more take over the immune cells. We still have some amount of control, and here there is selective immune pressure, which means immune cells are targeting certain tumor cells which express molecules. The other cells which are not responsive to immunotherapy or not responsive to the immune system will start proliferating. So you will have clonal expansion of cells which are not going to respond to your immune response. So that is when you will end up with third phase or the escape from the immune mechanism. So here the tumor will start progressing, and your immune system is unable to control. So in the first phase, it's basically a balance when the initial phase there's a lot of immune response. The pro-inflammatory cytokines are high, the tumor antigens and chemokines are high. Whereas if you take the last phase, immunosuppressive signals are high. Here you will have inhibitory ligands and immunosuppressive cells and tumor microenvironment favor tumor progression, killing of tumor cells. So in PPGL also, evidence that the same immune escape phenomenon occurs. TME basically refers to tumor microenvironment. Every tumor has a complex ecosystem. It has adjoining stromal cells and also your immune response. So if the tumor has a lot of tumor-infiltrating lymphocytes or TILs, then this is actually a type of tumor that is likely to respond well to immunotherapy. And depending on the presence of the immune cells of the immune cells within the tumor, it can be divided into cold or hot. So cold is basically tumor cells which do not express cells, and they have low mutation burden. Typically PPGLs fall either in the category of somewhere in between called the altered tumor variant, where there is upregulation mediators, inhibitory mediators, and suppressive cells. So the tumor, your immune response is inadequate to control the tumor progression. Whereas when you have hot or inflamed tumors, there is a very robust immune response, and these patients will respond very well to so hot tumors. PPGLs are technically cold or altered tumors. The idea in today's situation is to try and convert a cold tumor into a hot tumor. So if you can see the little graph, you can see that the hot PPGL is pretty good. Whereas in cold PPGL, the survival is poor. So the idea is to try and convert a cold tumor into a hot tumor, by which you make the tumor susceptible to immunomodulated therapies that we have. So when we talk about immunotherapy, the commonest ones use the ligand inhibitors, and there are a host of molecules which are being tried, solid cancers, neuroendocrine tumors, including PPGL. The newest thing is that you just don't treat but you immunotherapy, but you also give supportive therapy, which means you use other agents which increases the immune response within the tumor, hence making it a hot tumor, and hence increasing its responsibility to immunotherapy. This is just a bunch of studies which are all ongoing, which is looking at PPGLs. A lot of them are looking at essentially PD-1 and PD-L1 and L2 inhibitors. The other upcoming therapy and some little data that's available is targeting intratumoral immunotherapy. So right now we only use systemic immunotherapy, where you give it to the patients in a bloodstream. The disadvantage of that is that there's a high off-target toxicity. The intratumoral application works. So this is an example of something called the MBTA, which stands for the molecules which are mentioned there. So once that is infused into the tumor cells, then the tumor cells will cause recruitment of active innate immune cells, and this will cause damage of the tumor cells. It will kill the tumor cells, which will lead to release of tumor antigens, and that will again lead on to a CD4 plus and CD8 T cell inflammatory response, which again enhances the tumor killing. So this is how the intratumoral immunotherapy will work. So coming to PPGL specifically, early studies did not show much benefit because, like I mentioned earlier, these are cold tumors. However, now we have newer approaches which can transform the cold tumors to hot tumors, and this is an area of active research and progression. Now coming to a meta-analysis which looked at choice of surgery in patients with bilateral or unilateral pheochromocytoma. Should we do total versus subtotal adenectomy? So these are all the 10 studies that were involved. And if you look at the steroid dependence post-surgery, I think that's very clear. If you have total adenectomy, you have to use steroids, whereas it will be less in subtotal. This is looking at adrenal crisis. There was not much difference, even though the total required they were steroid dependent and required supplementation. There was no difference, statistically significant difference between occurrence of adrenal crisis. But when you look at recurrence rates, the subtotal adenectomy clearly had higher evidence of recurrence, but there was not much difference between metastatic lesions. So clearly, when we talk about subtotal adrenalectomy, it's important for us to remember that we have to choose the population correctly. It is only useful in mutations which have very low malignancy or very low metastatic potential, like RET and VHL, where you will have bilateral tumors, so you will have to end up doing bilateral adrenalectomy, but they also have very low tumor burden and risk of malignancy. So these are the ideal candidates. Now coming to imaging. So what are the reasons why you do an imaging, and what are the functions of, or what do you expect at the end of an imaging? Of course, it has to locate the tumor. It should also tell you if there's likely to be any other differential diagnosis apart from FEO. We also have to look at multifocality or multiple lesions present, chances of recurrence, any locoregional extension, and any distant metastasis. And all these points should tell us the feasibility of surgical removal, or whether we should push the patient for some sort of selective peptide receptor therapy. So the main imaging modalities we have are ultrasound, CT, MR, and some functional imaging, either SPECT or PET. I'll not go through the details of each, but if you look at the one that is most commonly used as first-line imaging, it's always CT of the adrenals, because it's widely available, it's easily accessible, it's very easy, it's less time-consuming compared to MR. The spatial resolution is better, and it gives you very good information. MR, the only advantage that MR has over CT will be for liver and cardiac lesions, where the soft tissue resolution is better. So disadvantages of a CT will be to exposure to ionizing radiations. We will talk about functional imaging in a bit. So this is how functional imaging works. There are four main molecules which are used in PPGL. One is, of course, the FDG. So how it works is the glucose is trapped by the cell, it's converted to glucose 6-phosphate, and hence it is used as a tracer there. The other one is FDOPA, MIPG, and somatostatin receptor molecules. So all of them work because these receptors are present on the surface of the tumor cells. And they all get trapped within the cell, and that is how we use them in identifying these lesions. So when it comes to norepinephrine transporter and SSTR, these two can also be used for therapy if it's very well expressed in the tumor cells. So now we'll just look at the advantages and disadvantages of each. So when it comes to MIBG, it's largely limited to patients who have sporadic FEOs, single lesion, and here to detect whether there is any role of therapeutic advantage with MIBG. So FDG PET, earlier we used to say metastatic lesions, FDG performs better, but now we know that the only place where FDG performs better is in SDH mutations, PPGLs related to SDH mutations, and that too if you do not have somatostatin receptor imaging available. FDOPA, on the other hand, is actually the imaging of choice for multiple mutations. However, this is really not available so easily. So at the end of the day, practically all of us end up using somatostatin receptor based molecular functional imaging. So most of us will end up doing a DOTA SSA PET CT. And this is usually available easily and much more easily available than DOPA. And most of the time, this is adequate in our clinical practice. So before you image, biochemical confirmation is always necessary. Most of the time, anatomical imaging is recommended first, followed by a functional imaging to see whether it is single lesion or multiple lesions. And then the type of imaging actually will depend on the genotype, phenotype, and availability. So practically, most of us will end up using DOTA TATE imaging. There's something called the immune PET, which is probably the future. Like I mentioned earlier, this is basically using radionuclides attached to immune molecules. Again, it will tell you whether the tumor is expressing immune cells or not, and if it is, then its response to immune therapy will be good. So no talk today will be complete without looking at utility of artificial intelligence. Again, the same holds good for pheochromocytoma and paraganglioma. This is to look at prediction of metastasis. They basically taught the machine and then used it for prediction in a different model. And you can see that these were all the points which helped decide that it would be that metastatic potential is high. Large tumor size, extraadrenal tumor location, previous history of FEO or PPGL, high plasma, methoxytyramine, and low metanephrines. A combination of this had a very good potential to predict chances of metastasis. And the machine learning performed much better than the expert opinion. So going forward, possibly this is going to be a highly accurate, non-invasive approach to predict metastasis in patients with PPGL. So lastly, some data from our own country. This is a meta-analysis put out by Dr. Deep Datta and his team. So they looked at evidence of any bone health in patients with FEO, and they looked at various markers, TBS, BMD, and also bone turnover markers, and they found that TBS was significantly lower, they had higher CTX and BSALP, which means it's a high bone turnover disease, And after surgery, there was a improvement in TBS. So clearly, PPGL is one condition where bone health is slightly compromised, and probably we need to give it a little bit more attention. So that brings me to the end of my talk. So PPGLs are rare but fascinating disease, and because of the heterogeneity, it's really difficult for us to give targeted therapy. The latest advancements in medical management includes modulating the tumor microenvironment and enhancing the effectiveness of immunotherapy. And the last year has also shown some improvement or some advancement in the imaging, and something called immunopet, which can actually predict response to immunotherapy, is also coming up. An ever-increasing presence of AI in clinical medicine is also seen in PPGL, which also had papers published in the last year. Thank you.
Thank you, ma'am, for that superb and fascinating talk. We thank you from our deep of our heart. So we just request ma'am to be on stage for a few minutes so that she can quench some of the thirst of knowledge from the audiences. Any questions from the floor?
Is there any chance of precipitating adrenal crisis while doing the intratumoral therapy?
I think if you're addressing intratumoral therapy is largely for metastatic disease. So I think if you're, most of the time for paragangliomas, there is no risk of adrenal crisis. But if you're addressing a single unilateral FEO, again, risk of adrenal crisis is very less. And you will hardly use intratumoral for bilateral PCC. Most of the time that will end up in surgery. So risk of adrenal crisis precipitating just because of this is less.
I think that that answers the question. So any other questions from the floor? If not, then I have a question, ma'am. Is there any cutoff of plasma methoxytyramine to predict the dopamine secreting FEO? Like we have the cutoff for noradrenaline and noradrenaline secreting tumors, the beta-nephrin levels. So is there any cutoff of methoxytyramines to predict that?
Yes, there are cutoffs, but though I can't recollect the value offhand, there are defined cutoffs for head and neck paragangliomas and also for other PPGLs where dopamine secretion is high. But offhand, I can't tell you the values.
Okay, ma'am. Thank you. Thanks a lot. Thanks a lot, ma'am. And with that, the first part of our discussion regarding endocrine hypertension is completed. And for the second part, that is the another big chunk of endocrine hypertension, that is the primary aldosteronism. For that, I would like to call upon stage Professor H.K. Ganesh, sir. So, sir is a professor and head of the endocrinology department of Mangalore. So, for the discussion of year in endocrinology, that is primary aldosteronism, I would like to call upon stage esteemed Professor Ganesh H.K. sir. Thank you. Sir, the stage is all yours.
Thank you. At the outset, I would like to thank the Endocrine Society of Bengal for inviting me for this prestigious Crescendo conference. For the next 20 minutes, I will be speaking regarding the primary aldosteronism, what has happened in the last 1 year, what are the new advances which have taken place in the last 1 year. So I will be mainly focusing on the newer articles which have come up regarding the diagnosis, biochemical diagnosis, imaging techniques, and something regarding treatment. So this article, I think there is some distortion. Can you correct it? Because the last few lines are not visible there. Yeah, so anyway, So the Journal of Endocrinology, it was published in Journal of Endocrinology 2023. So it showed the multisystemic effects of primary aldosteronism. Even though we knew that aldosterone has got multiple effects, the primary aldosteronism produced a lot of ill effects other than hypertension, other than the end organ damages were much higher with the primary aldosteronism compared to the essential hypertension. So it showed that this article clearly showed that there are multiple effects on the cardiovascular system, renal system, including albuminuria and renal fibrosis, and metabolic issues like impaired glucose tolerance and hypertriglyceridemia and increased LDL, all were seen in primary aldosteronism. So there is one more article published in Frontiers in Endocrinology which showed primary aldosteronism among hospitalized patients with hypertension and diabetes were associated with increased mortality risk, atrial fibrillation, stroke, acute heart failure, and acute renal failure. The incidence of all these complications were much higher in primary aldo compared to essential hypertension. So one more article looked into the temporal trends in the last 2 decades. What has changed in the last 2 decades? It was found that there was decrease in hypokalemia and decrease in aldosterone levels at the diagnosis compared to in the last 2 decades back. And the incidence of bilateral adrenal hyperplasia and incidentally detected patients were much higher in the last few years compared to what has happened 2 decades back. So among patients with primary aldo, patients with bilateral adrenal hyperplasia and incidental detection were much higher compared to 2 decades back. And something into the genetic association. This was a meta-analysis of genome-wide association studies. This was published from Japan. Actually, they found that the genetic predisposition is confirmed, even though we knew. So this study has clearly shown that the WNT2B variants there is strongest association with this gene. There are other genes also you can see here, KCNJ5, WNT2B, and WNT2B variants, they reinforce the implication of this WNT2 and beta-catenin pathway in the pathogenesis of primary aldo. And one review is published based on few patients' data, primary aldosteronism in pregnancy. So we know that it's very difficult to diagnose aldo in primary aldosteronism in pregnancy because the renin levels increase by around 5 to 7-fold and aldosterone increases by up to 10-fold in the second trimester of pregnancy. So the diagnosis becomes very, very challenging. So if there is clear, the diagnosis even now it's not very clear, but if there is significant hypokalemia and very high aldosterone levels and suppressed renin levels are there, we can diagnose. And the treatment wise, very difficult because we can't proceed with the imaging modalities. So the MRI, if warranted, we can go with the MRI, but mineralocorticoid receptor antagonists are preferable. Even surgery is not advisable. If it is absolutely required, we can go ahead in second trimester. Eplerenone is found to be safe and effective in 6 pregnant women. Spironolactone is absolutely contraindicated. Coming to the aldosterone-renin ratio, we know that the plasma renin activity is one of the most cumbersome assay. It's very difficult to do. So that is the reason the whole world is moving towards the direct renin assay nowadays. So now this study published in Clinical and Experimental Hypertension in 2024, they showed that the cutoff is much for cardiovascular disease risk. So the cutoff is much lesser. They showed that in this less than 1 nanogram per deciliter per milli-international per liter. So the risk of cardiovascular disease is much higher if the ARR is above 1. So this is much higher than the recommended, much lower than the recommended cutoff. So ARR more than 1 nanogram per deciliter by milli-international per liter or micro-international per ml. So it is more than 1, there is significant higher risk of CVD. So in this we can see, so if we use the ARR cutoff of 1, the sensitivity is 98%, whereas the specificity is only around 60%. So if we use the Endocrine Society cutoffs, they have given 3 cutoffs depending on the sensitivity, 2.4, 3.7 and 4.9. The cutoffs, the sensitivity falls down. If you use the 4.9 cutoff, the sensitivity falls to 70%, but specificity improves to 92%. So that is the reason, probably, so since it is a screening test, so we are, for a screening test, sensitivity has to be very high. Probably ARR cutoff of 1 nanogram per deciliter per milli-international per liter can be used as a screening test for primary aldo. So then very interesting article published in JCEM. So this is a very practical study because so it's we know how difficult it is to stop antihypertensives for doing ARR. So this study was a retrospective study published from China actually. Consecutive patients referred to hypertension center in Beijing were included in the study. Patients taking any of the antihypertensive like which is known to impair ARR like AC inhibitors, ARBs, beta blockers, dihydropyridine CCBs, diuretics, all were included in the study. First screening test was done prior to washout. So prior to, as soon as the patient comes, so if there is suspicion, multiple antihypertensives, whatever the suspicion, they went ahead with the screening test and then they did the washout. They gave the permissible antihypertensives and after 4 weeks after stopping diuretics or 2 weeks for other antihypertensives, they did the ARR again. So there was significant difference. You can see the right hand side of the table. Primary aldosteronism before washout ARR was 4.51 and after washout it was 8.74. So there was significant difference. So then when they compare with the before washout and after washout data, diagnostic accuracy of ARR, here the aldosterone is in nanogram per deciliter and the direct renin is in micro international unit per ml. So when they use the cutoff of 0.7, so we can see 97% sensitivity and specificity is approximately 60%. They compared with the post washout ARR. And when the ARR was, the cutoff was kept as 0.5, the sensitivity increased but specificity fell down significantly to approximately 50%. So that is the reason they mentioned that ARR determined while hypertensive patients are on medications is a sensitive screening tool for primary aldosteronism and washout of antihypertensive agents can be omitted and for primary aldosteronism diagnosis and primary aldo can be excluded if the ARR is less than 0.7 nanogram per deciliter. So before washout, the patients who are on multiple antihypertensives which can impair the ARR, if the ARR is less than 0.7, then we can conclude that the patient is not having primary aldo. There are some limitations of the study. I have just listed there. It's a retrospective analysis. All patients didn't undergo ARR for second time, and the confirmatory, like after washout, 2.4 was the cutoff used, and AVS was not done. Coming to the next, one more important topic, so ARR on resistant hypertension. So resistant hypertension is a category where we are supposed to do ARR, but the one problem is the resistant hypertension patients as such, they are having dysregulated renin-angiotensin aldosterone axis. So that is the reason the diagnosis becomes all the more difficult. So in this study published in 2023 Frontiers in Endocrinology, so 129 consecutive patients with resistant hypertension were evaluated. Here the plasma aldosterone and plasma renin was measured by RIA. So the units are different. It's not by CLIA, so it was measured by RIA in this study. So ARR cutoff, when it was 41.8, so to get the ADRR, aldosterone direct renin ratio, you can divide by 8.2. So then you get the ARR, this unit to the ADRR. So 41.8 in ADRR, if it comes to around 5. So sensitivity is 100% and specificity is 67%. And in this, if we want specificity, then probably the ARR cutoff will be much higher. But finally, they concluded telling that among normocalemic patients, there was a wide overlap, there was a wide heterogeneity. So in ARR, so the patients with the normocalemic patients, the essential hypertension and aldosteronism, there was significant overlap. So confirmatory testing is required in patients with normocalemia, whereas in patients with hypokalemia, the ARR did better, so there was no wide variability. You can skip confirmatory testing, you can go directly for imaging in patients with hypokalemia, resistant hypertension and ARR positivity. Then one regarding imaging, invasive, the bilateral adrenal venous sampling. This was a study published from KEM group. It was a retrospective analysis. The 15 patients were analyzed. So the lateralization of disease was seen in 2/3 of the patients and bilateral disease was seen in 33%. The concordance with the CT was around only 33%. So they concluded that adrenal venous sampling performed by a single radiologist with the defined protocols has a good success rate, and it has got additional value over CT in lateralization, especially when the CT is showing bilateral disease. Coming to the, we know adrenal venous sampling is difficult, it's not easy to do, and a lot of expertise is required, only few centers can do, not only, even if the few centers, so the cannulation of the right adrenal vein is very difficult, so a lot of procedural difficulties. So if we can bypass adrenal venous sampling, that will be the best. So Nature Medicine published in 2023, so C11 metamidate PET CT versus adrenal vein sampling for a diagnosis of primary aldosteronism. They compared the accuracy of C11 metamidate PET scan. So total 128 patients were included in the study. Surgery was done in 61% and medical management was done in 39%. Out of the 78 patients receiving surgery, 77 achieved one or more primary aldosteronism surgical outcome criterion for success. So the accuracies for metamidate PET CT at predicting biochemical and clinical success were 72% and 65%, so better than adrenal vein sampling. But the problem with the metamidate PET CT, it needs a cyclotron, so it's not possible to do everywhere. And second thing, the metamidate, since it's an adrenoleutic agent, so we need to replace steroids at least 2 to 3 days prior to the metamidate PET CT. This is one of the problems. So that's the reason the pentixafor PET CT came into the picture. Chemokine receptor 4, the transmembrane protein, so that is targeted. So 92.4% of the APA lesions, aldosterone producing adenoma lesions, showed high uptake in PET CT, while 94% of the non-APA lesions exhibited low uptake. So high sensitivity was seen in nodules smaller than 1 centimeter. So they concluded that the gallium-68 pentixafor CT is useful, and it has got high sensitivity, specificity and accuracy, and it's simple, non-invasive and economical. One more article published in JAMA Open, that also found that the pentixafor PET CT and AVS the concordance was approximately 90% compared with 54% between traditional CT and AVS. So they concluded that gallium-68 pentixafor PET CT can be used as a non-invasive procedure bypassing adrenal venous sampling. Coming to primary aldosteronism in CKD, the patients with CKD is one of the area where difficult to treat hypertension we get more often. So in those patients, the diagnosis of primary aldosteronism is very useful. It was found in this study that if we diagnose and manage either medically or surgically, there is significant reduction in the progression of kidney disease as well as improvement in potassium levels. So but the surgical adrenalectomy versus medical management, there was no major change. So the CKD, primary aldosteronism, you can manage medically or surgically, there was no major change. Coming to one more aspect, radiofrequency ablation. This was once again published in Experimental Clinical Endocrinology and Diabetes in 2023. So radiofrequency ablation is a less invasive than laparoscopic surgery. So the people who are not ready to undergo surgery, so for a benign condition with no promise of 100% cure, radiofrequency ablation can be thought of. So and also the significant improvements were seen with the reduction in aldosterone levels. So if we can reduce the aldosterone levels by radiofrequency ablation, that will do a good job. So it will be very useful, especially in patients with high cardiometabolic risk, marked visceral obesity and bilateral disease. So it's a less invasive alternative to adrenalectomy, but whatever the studies are retrospective, small, and only short-term results are there. And now the one study, WAVE study, is ongoing, which is looking into the use of radiofrequency ablation in patients with hyperaldosteronism. Coming to the medical management, the esaxerenone, non-steroidal mRNA, newer mRNA, the study was done in Japan. It was found to be effective in patients with older patients with primary aldosteronism. The dosage ranged from 1.25 to 5 milligram per day. There was improvement in potassium, EGFR was slightly decreased, but no dose reduction was required in patients who are on esaxerenone. One more study published in NEJM, use of aldosterone synthase inhibitor, baxdrostat, for the treatment of resistant hypertension as well as primary aldosteronism. Baxdrostat has got 100:1 selectivity for aldosterone synthase. It has aldosterone synthase has got 93% homology with the 11-beta hydroxylase gene, so, enzyme. So that is the reason the selectivity is a must. Otherwise, the cortisol levels also will go down. So the Baxdrostat showed improvement, significant reduction in blood pressure in resistant hypertension. One more, lorundrostat. Once again, the dose finding study from 12.5 mg to 100 milligram per day they have studied and published in JAMA 2023. So they found that use of lorundrostat 50 to 100 milligram per day was effective in controlling blood pressure compared to placebo. Coming to the last aspect, the guidelines. This is a British and Irish Hypertension Society guideline. So there is one more study published from Korea, Korean Endocrine Society guidelines, whom to be screened. So they are of the opinion that the patients who are on 3 or more antihypertensives not controlled, or 4 or more antihypertensives even though it is controlled, then we have to screen with the aldorenin levels, and others are as like this British Irish Hypertension Society guidelines. So it's simple actually. Adults with hypertension less than 40 years, we are supposed to do ARR. Hypertension with spontaneous or diuretic thiazide-induced hypokalemia, we are supposed to screen. Resistant hypertension, if the patients are requiring 3 or more antihypertensives, one of them being diuretic, we are supposed to screen for ARR. And hypertension associated with adrenal incidentaloma, we are supposed to screen for ARR. So what happens if suppose the screening test is negative? So what to do those patients? So first we are suspecting ARR, aldosteronism, but screening test comes negative. So what happens to them? So it was found that 20% of the patients with the previous negative confirmatory test for primary aldo develop overt primary aldosteronism over time. So and subtyping of them showed a unilateral adenoma in 1/3, showing that it can be curable. So clinical follow-up of patients with a negative confirmatory test is definitely to be done, especially in patients with worsening blood pressure control. We should not leave it at them once, because once the ARR comes negative, so that's the reason we should not stop at that. So if the blood pressure is difficult to control, then we are supposed to screen them again, probably after a year or so. Last, the new concept, syndrome of inappropriately elevated aldosterone levels. So we know that there is a lot of confusion regarding the ARR cutoff, aldosterone renin levels, what to use, what not to use. So every day one new cutoff is coming up. So we know that it's a spectrum, it's not a single cutoff which we can use. So a spectrum of renin independent aldosterone production. So it can be subclinical, which is then normotensives, to full-blown clinical syndrome in resistant hypertension. So this was the article published in Journal of Clinical Hypertension in 2023. So all patients with incident hypertension, so we are supposed to screen with renin levels. If the renin levels come high, then treat with the ACE inhibitors, ARBs, or add CCBs later. If the renin comes low, then you are supposed to do oral salt suppression test. So at least 3 days of 5 grams plus or 5 to 6 grams of oral salt, followed by 24-hour urine aldosterone levels. If the 24-hour urine aldosterone comes less than 5 microgram per 24 hours, then syndrome of inappropriate aldosterone secretion ruled out. So you can give thiazide diuretics or CCBs. And if it is if the 24-hour urine aldosterone excretion comes 6 to 9 microgram per 24 hours, it can be branded as mild SIALD. So we can treat with MRAs. If it comes more than 10, then you have to go ahead with evaluation for primary aldosteronism. More than 10 microgram per 24 hours. So same thing actually. So the spectrum, SALD ruled out, mild to severe SALD, and accordingly we have to evaluate. So concluding my talk, ARR determined on antihypertensive medications, practically very useful. So it's a sensitive screening test for primary aldosteronism. So we can exclude primary aldo if the patients on antihypertensives, if the ARR is less than 0.7 nanogram per deciliter per microintervention per ml. Gallium-68 pentahexafer PET-CT is very sensitive, specific, and so far it has shown high accuracy in diagnosing aldosterone-producing adenoma. Much studies are required in this. Baxdrostat and lorundrostat are promising new molecules which block the aldosterone synthase and useful in resistant hypertension as well as primary aldo. Syndrome of inappropriate aldosterone secretion is a new terminology, emphasizes more aggressive screening with renin levels. Thank you. Ideally, yes. We have to. Potassium has to be normalized before ARR. That otherwise the hypokalemia per se will increase aldosterone levels.
Thank you, sir. So I would like to open the floor for questions.
So, do we need to, especially with regards to the European guidelines, they have included the atrial fibrillation also with hypertension as one of the indications for doing a screening test. With regards to CKD, what would be the optimum level with regards to how would you screen for primary hyperaldosteronism in CKD?
Very difficult. I don't think there is any cutoff or guideline. As such, I think with the direct running, now the guidelines are evolving. Probably another few years to come, probably in CKD also we'll get the cutoff. And AF, atrial fibrillation, even the Korean Endocrine Society and European Society of Hypertension, their guidelines say that all patients with atrial fibrillation are supposed to be screened for ARR.
Any other questions from the floor?
Thank you, sir, for excellently summarizing that year in review for primary aldosteronism. I wanted to ask, in almost all fields of endocrinology, we now talk about precision medicine. So in case of primary aldosteronism, regarding genotyping of primary aldosteronism subtypes, do they still have a value in maybe deciding on diagnostics and ultimately treating those patients based on genotype?
Yeah, I think the studies have shown that there are genetic predisposition, especially probably in patients with the resistant hypertension. We can do the genotyping, and probably some of the subtypes, KCNJ5 mutations are supposed to be very aggressive, and the end organ damages are much earlier, faster. So probably in such patients we have to go on aggressive. I personally don't know much data, or I don't have experience on precision medicine in primary.
Like, would you recommend us going in for genetic testing in all of these patients? Like, we are screening all hypertensives with ARR for primary aldosteronism?
I think once the primary aldosteronism is confirmed, we can do the genetic testing. Only thing is who will financially who will bear this one, because it will cost. So our regular patients won't be able to afford all genetic testing. If they can afford, or if there is a means to do it, that will be the best.
Thank you. Thank you so much, sir.
Thank you, sir. So any other questions? So if there is none, thank you, sir, for your excellent deliberation. So for the next session, that is on the next scientific session, we have Professor Aditi Sinha, who is from the Division of Nephrology of Department of Pediatrics from AIIMS Delhi, and who will be talking on renal tubular acidosis, of which we are sure that many of us have doubts. So, ma'am, kindly enlighten us for that doubt clearing. Thank you, ma'am.
Thank you. At the outset, I'd like to thank the organizers for inviting me here. It's a tough topic to be speaking on to a society of endocrinologists, and I would try my best to address this topic as far as possible. So essentially, you're well aware that renal acid-base homeostasis is chiefly regulated in two zones. One in the proximal tubules, where bicarbonate reabsorption takes place to the major extent. Majority of the bicarbonate that has been excreted at the glomerulus is reclaimed in this zone, as shown by the red arrows, that the proximal tubules are responsible for reclaiming majority of it, and almost 4,800 milliequivalents of bicarbonate are reclaimed here. On the other hand, there is a dietary acid load that is generated every day of 1 milliequivalent per kg per day or so, depending on the animal protein or the protein intake. It could be up to 2 milliequivalents per kg per day, which needs to be removed from the body. And the synthesis and excretion of ammonium in the proximal tubules is helpful in doing this, as also various other ways of excreting acid, chiefly in the form of ammonium. titratable acidity, and free H+, which is a small proportion. So you can see the blue arrows that indicate where these actions are taking place. The ammonium synthesis and excretion from the ammonium synthesis is happening in the proximal tubules. This is first excreted but then reclaimed again into the medullary portions of the loops of Henle, and then again finally it is excreted from the distal parts of the tubule, the cortical collecting ducts. And there is a small amount of phosphate that is being involved, the H2PO4 to HPO4, HPO4 to H2PO4 conversion that results in removal of some part of the H+, and a small amount of the acid load is excreted as free H+. You can very well imagine that the moment the H+ is excreted per se as free H+, the urine pH changes and the concentration gradient becomes unfavorable for more H+ to be secreted. So a majority of H+ is actually buffered through these mechanisms, either as part with bicarbonate or with phosphate that it would be excreted. So the net excretion is in the form of all the bicarbonate that goes out, that is reclaimed, versus the ammonium that goes out and the titratable acidity that goes out into the urine. Overall, H+ secretion is also marked by urine CO2, which is kind of excreted in the collecting tubules that can serve as a marker, and we'll come to see how later. So these are these channels that are involved proximally in the reclamation of bicarbonate. So you can see that the most important channels here, there are 4 on this loop, on this cell, the proximal tubular epithelial cell. You can see how sodium and H+, there is a coupled process of absorption and excretion. H+ is also coming out through another channel, and then the H+ ATP is there. And basically this H+ that is excreted chiefly by the NHE3 is joining with the bicarbonate that is in the lumen filtered from the glomerulus to form carbonic acid. With the action of carbonic anhydrase 4, it is kind of CO2 is formed, which kind of diffuses in, and then the carbonic anhydrase 2 intracellularly helps to again form bicarbonate and H+. H+ goes out of the cell, so cell throws out H+ and reclaims bicarbonate, thus causing acid loss, net acid loss. The NAK ATPase is obviously very integral to this. This cell's ATP it needs to have a lot of ATP to be able to run this mechanism. If ATP is not there, as in ischemia, etc., proximal tubules will stop working. Likewise, this cell called NBCE1, which is the sodium bicarbonate co-transport, is also very important, and that is the only known cause of proximal RTA which occurs isolatedly, that is without Fanconi syndrome. So that is associated with cataracts and sometimes intracranial calcifications. Obviously, everything else in the proximal tubule is very, very coupled. There is sodium-dependent transports happening for amino acids, glucose, phosphate, bicarbonate, and everything is ATP dependent because it is driven by the sodium-potassium ATPase on the basolateral surface. There is also a lot of receptor-mediated endocytosis going on for low molecular weight proteins. All this is dependent on maintaining the voltages in the right manner with sodium moving from the lumen into the interstitium. Distally, what happens? Distally, this is what happens. The intercalated cells, the type A or alpha intercalated cells, are the chief cells that are maintaining this process, along with the principal cells that have certain roles. Now, the type A intercalated cell actually has on its luminal surface 2 channels which are important, the potassium hydrogen antiporter and the H+ ATPase. The H+ ATPase is the chief channel which is removing H+ here, but also somewhat exchanges are happening between potassium and hydrogen here. Again, carbonic anhydrase is in play over here. It is removing H+, it is helping H+ removal into the lumen, but once the H+ comes into the lumen, it must be buffered by ammonia to form ammonium, by HPO4 to form H2PO4, or by bicarbonate to form carbonic acid. Because these are the ways, apart from being excreted as free H+, that can help remove H+ into the lumen. There is also removal of ammonia that you can see. Ammonia uses its independent channels, or also it can mimic H+ and move through those channels. And therefore, ammonia moves out into the lumen, and that is joining with the H+ to form NH4+. Again, this is coupled to sodium-potassium ATPase here, and another very important channel here, which is the anion exchanger. The bicarbonate that is generated intracellularly has to be reclaimed into the interstitium through this channel, and that's pretty important. There are also other channels that are in place. Now, there is a mirror image of this channel that is called the beta intercalated cells that is less expressed in the tubules. However, in periods of alkalosis, when you need to remove bicarbonate, the expression goes up, And there's this pendrin that you can make out. That's the reverse of the channel that you see on the other side. That is the anion exchanger. So, you have these channels which look like each other but are called different names, and they are placed opposite to each other and they serve opposite functions. You also have the principal cell, and a lot of things that are going on in the principal cells are coupled to what's going on in the intercalated cells because the voltages are interlinked. Suppose H plus is not going out, sodium cannot go in because their voltages are interlinked. The drive of sodium through the epithelial sodium channel is what creates a negative lumen potential, which is also a driver of H plus excretion into the tubular lumen by the intercalated cells. Suppose for some reason you don't have distal sodium delivery or you don't have sodium reclamation happening in the principal cells, then the voltage is lost and H plus excretion can't happen even if the channels are very much intact. That is the mechanism of voltage dependent renal tubular acidosis. Ammonia is also very critical to all this. Ammonia is synthesized proximally and secreted distally. We've just seen the mechanism how. And ammonia synthesis is also regulated in some ways. So it is enhanced by acidosis. We very well know that in periods of chronic diarrhea or other metabolic acidosis phenomena, ammonia synthesis should go up if the kidneys are intact. However, if this is a renal mechanism of acidosis, the ammonia synthesis does not step up proportionate to the degree of metabolic acidosis. And that is why in all forms of renal tubular acidosis, it is now understood that ammonia genesis drops. Previously, it was thought that proximal renal tubular acidosis, the ammonia synthesis is intact, but that's not the case. Even there, ammonia genesis is lower. It has been demonstrated very clearly. Hypokalemia is another driver of ammonia genesis, and that's why in this form, when hypokalemia is there for some reasons, ammonia genesis will step up. Most of the cases of homeostasis mechanisms would have hypokalemia with alkalosis going hand in hand. That is also contributed to by this process. On the other hand, hyperkalemia will inhibit ammonia genesis, so hyperkalemia will lead to more acidosis. So what is Fanconi syndrome? It's generalized proximal tubular dysfunction. So you can see how many things are coupled to this, all these channels moving together. And as long as everything functions together, the cell functions. The moment one channel stops, for example, the ATP production is not there, there's some kind of ischemia or something else that stops driving the basolateral movement of sodium and bicarbonate, then, or potassium exchange, then everything stops. So there could be isolated apical defects that are known to be associated with Fanconi syndrome. There could be other transcription factor defects. There could be basolateral transporter defects. There could be simple energy depletion as in a situation of shock, ischemia, nephrotoxic injury. There could be receptor-mediated endocytosis defects as you see in Loewe syndrome. There could be intracellular trafficking defects as you see in cystinosis or you see in Dent syndrome. Anything that goes wrong intracellularly and creates an acidotic milieu or causes proximal tubular dysfunction will lead to impairment of multiple channels and therefore Fanconi syndrome. So overall, even in preterm children, you would have metabolic acidosis for this reason, for example. So overall, we have multiple causes of Fanconi syndrome, renal Fanconi syndrome, and at least in childhood renal tubular acidosis, metabolic diseases predominate as causes, as well as certain membrane transporter defects which are now increasingly recognized to also cause isolated, what are known as Fanconi renotubular syndromes that do not have systemic manifestations compared to those listed on the left, which tend to have systemic disease, and some hint in the examination or findings will give you a clue as to the right diagnosis in that particular child. On the other hand, you could have just receptor-mediated endocytosis that's going wrong, and very small proportion would have no cause in childhood. That's called idiopathic Fanconi syndrome. In adults, of course, it's a different ballgame, and we'll come to that. So there's a full list, and there's actually the list is longer than what you can see here. But suffice to say that there are many genes, and every year you have new genes being discovered. What about distal renal tubular acidosis and what mediates that? So in the first place, we knew about two channels. We knew about the anion exchanger, which is present on the basolateral surface, whereas we also knew about the H plus ATPase on the luminal surface. These were the two most important things, and H plus ATPase, two subunits were known to be causative, B1 subunit and A4 and the A4 subunit. However, now we know that 3 more genes have been discovered. It has been shown that maybe the C2 subunit can also cause RTA, very few reports, but more animal experiments. The FOXI1, a transcription factor, and WDR72, both have been shown to be associated, and all of us are now beginning to recognize these entities. There are clues in the non-renal manifestation that give away diagnosis sometimes. You could have deafness in certain forms because the channels are also expressed in the inner ear. You could have hemolytic anemia in the anion exchange defects because these channels are also present on the RBC membrane. There would be dental defects in WDR72, and foci is also associated with early onset deafness. So this was the genetic classification of distal RTA. Now, since before my birth, perhaps there have been experiments, and those hold true still, that suggest that there are mechanistic types or subtypes of distal RTA. So we know that the classic distal RTA is actually a secretory defect. That is, there is a problem in H plus secretion from the cell into the lumen. That is the classic subtype, and H plus ATPase defects would really simply exemplify that. Also the anion exchanger, because they secondarily affect the H plus ATPase. What about the back leak defect? That is the classic of amphotericin toxicity. The H plus secretion happens, but then because the cells are leaky, it gets reclaimed again distally, and so the whatever was lost has been reclaimed. What about a voltage defect? Voltage defect refers to that form of distal RTA which occurs because the distal sodium-based voltage gradient, which is a lumen negative potential, cannot be maintained because either the distal sodium delivery is poor on a low salt diet, or the distal sodium reabsorption is not happening for one reason or the other. And because sodium is coupled to potassium, and therefore hyperkalemia can also be there in these situations. A subtle defect in distal acidification leads to what is known as a rate-dependent RTA. So in these patients, the acidosis might be more subtle or absent, and only when you kind of stress the system would you be able to figure out that there's a problem. Or there may be uncoupling of different indices. So you might find an ability to lower the urine pH that is appropriate, but your ability to form a U-B CO2 gradient is not there. And overall, this probably could be one of the types of incomplete RTA. So there is no baseline acidosis. And this is a situation that you typically encounter in adulthood, adults with probably stones, who you might have evaluated for hypercalciuria and, stressed their system by inducing acidosis and found that they have an incomplete type of distal RTA. That's the typical setting in which we kind of evaluate and find them. That there's hypercalciuria, stones, and then when you find out, you find a partial kind of a renal tubular acidosis. That is, the acidosis is not there at baseline, but in induced acidosis, their H plus excretion is insufficient. There are other settings in which it occurs, and the ways to induce acidosis would be either an ammonia chloride load or a furosemide fluorocarbon test. But it could also be an anion exchanger heterozygous defect. Half of the channels are functioning probably fine and the half are not. What about type 4 or hyperkalemic RTA? This has been recognized for a very long time that there is an acidification defect that is associated with hyperkalemia vis-a-vis distal RTA which has hypokalemia, and therein this is a problem of either an aldosterone deficiency or a setting wherein aldosterone is not acting on the mineralocorticoid receptor because of its absence or inactivity, or the ENaC, the epithelial sodium channel. And there are a variety of genetic defects as well as acquired entities that could cause it. So I am a pediatrician, I deal more with genetic causes, but you as adult endocrinology practitioners would probably see far more often these entities which are the acquired forms of RTA. In pediatrics, we would one a year or two a year, we'll come across older girls who present to you with weakness which turns out to be hypokalemia, metabolic acidosis being present, and then you uncover, say, Sjogren's syndrome or lupus in them. And that is understood to be because of tubulointerstitial nephritis, which causes an antibody kind of mediated activity at the H plus ATPase, and maybe that is the reason why their distal acidification is impaired because of nephritis happening there. Then there are a whole set of other reasons as well. The destruction of tubular interstitium, such as in hemoglobinopathies, such as sickle cell, any form of tubular interstitial chronic damage because of posterior urethral valves, obstructive uropathy, diabetes, would be other settings in which acquired forms of RTA are seen. So we must remember all these secondary causes when we are dealing with these patients. I'll quickly take you through a case and how we would evaluate a patient who has presented to you wherein you think about renal tubular acidosis. This was an 8-month-old child who was term vaginal delivery, normal birth, low birth weight, exclusively breastfed, apparently feeding well enough, not having any other symptoms of systemic disease like diarrhea, etc., and still not gaining weight and height. And he was passing urine quite too frequently and was perpetually hungry. And herein would be considered these possibilities as a pediatrician. These would be the possibilities that I would entertain, but I would also keep on my mind what is going on with the urine output, measure it by diaper weighing, and figure out that there is a urine output that is of 7 ml per kg per hour. I would suspect a tubular disorder here because herein there is a setting of polyuria. Polyuria for us is defined as more than 6 mils per kg per hour or more than 2 liters per meter square per day. And I would go on to evaluate them. This child on evaluation was found to have subtle problems such as you can make out that there is a metabolic acidosis. The bicarbs are really low. The pH is compensated or low. The sodiums are on the lower side. Potassium is definitely low. And how would you go on to interpret these findings? So the clues that are here are that there is hypokalemia, acidosis, there is tendency to hyponatremia, there is definitely a chloride value that is kind of highish. And how do I interpret this chloride value? I look at what is known as a gamblogram. This is the normal gamblogram of the distribution of electrolytes, anions and cations in the body. This is the normal balance. We look at the chief ones, then we call it then we look at the anion gap. So the chief ones are sodium on one side and bicarb and chloride on the other side. The difference between them showed by the green bar is the anion gap, which is normally just about 8 to 12. Now, this might be conserved or distorted in a setting of acidosis. When it is conserved, it is chiefly in a setting of bicarbonate losses, which are either accompanied by sodium or disproportionately, sodium plus bicarbonate are lost, not so much chloride is lost. Chloride goes up and the anion gap stays preserved. In either of these situations, the whole volume is contracted, the entire numbers are low, but still the anion gap is preserved. That is bicarbonate losses such as diarrhea, ureterostomy, and early stages of chronic renal failure. On the other hand, you might have a situation of an acid gain, an organic acid gain such as in diabetic ketoacidosis or lactic acidosis of any nature or any of these acids which have come up, and therefore bicarb in buffering has been reduced and therefore the anion gap goes up. These are the settings in which high anion gap acidosis would occur. So in our patients, we had a normal anion gap, and therefore I can go forward with evaluating this child for hyperchloremic metabolic acidosis, and these would be the steps in my evaluation. In the interest of time, I'll probably have to go faster than I intended to do, but maybe you can go over this review article that we published in 2020 and go through the steps more carefully at leisure, and I'm sure all of you are thorough with this anyways, day in and day out. So the first step then next after confirming acidosis is to look at the urine anion gap. And urine anion gap assesses what? It assesses your ammonium excretion. Ammonium, the first step that you look at probably, is the urine pH, and that would assess your free H plus losses. Now free H plus losses obviously would depend on how much ammonia is being generated and how much is getting buffered by ammonia as well. You need to take a fasting fresh sample. And obviously, I've spoken to you about how the H plus is excreted in 3 different ways, and therefore free H plus, it represents a very small value, a small amount, maybe 1% of the entire acid excretion from the body normally. So more than 5.3 in the presence of systemic acidosis, a urine pH of more than 5.3, not 5.5 anymore, 5.3 would be considered as abnormal. And this could still happen in a setting of, say, acute or chronic diarrhea because enough sodium is not there to be able to be present distally to allow H plus to come out. In exchange for it, voltage is not maintained. Therefore, do not evaluate in those settings. In a setting of UTI or a urine left standing, where urease producing organisms are going to split urea and form and therefore get the H plus buffered, that's not a setting. So you'll have to worry around your values of urine pH. Don't do it ever on a standing sample, and do be careful of these instances that they are not present. So what next? Better than looking at just the plain urine pH, you would like to now look at what's happening in a different setting. But I'll just come upon 2 ways of assessing urine pH again in a stressed environment. So what happens is that if you have frank metabolic acidosis, you definitely just go ahead and look at the urine pH. But if you don't have frank metabolic acidosis, but you are suspecting, say, an incomplete RTA, then you would stress the tubules, you would provide them an acid load, and then see whether the urine pH drops or does not drop to understand whether the distal acidification mechanism is intact or not intact. And the method to do that would be an ammonium chloride test. Again, this is a very standard method to do it. We prefer this not in children because they would not take so much of ammonium chloride at all. They would just puke it out. So this is maybe more for this audience than for me. We would instead do the fludrocortisone furosemide test. So what we are intending to do is practically the same thing. We want to make sure that there's enough sodium delivered distally that is available to be reclaimed distally in exchange for H plus. And to enhance that process, we give something akin to aldosterone to them, that is fludrocortisone, so that the ENaC activity goes up. The K plus excretion is the maximum, the H plus excretion is the maximum because of the actions of fludrocortisone. Even in that setting, if the urine pH does not drop to below 5.3, certainly the distal acidification mechanisms are not intact, and that is a setting in which you would consider incomplete distal RTA. So pH can be checked in an acidotic environment as such, or in lack of acidosis by doing these 2 tests. But better than pH is probably to look at the ammonium excretion. Now, ammonium excretion is not done routinely. One paper does mention about doing it, but we don't have the wherewithal to do ammonium. So what we do is indirectly estimate ammonium by either the urine anion gap or the urine osmolar gap. Now, urine anion gap is something that has conventionally been used pretty easy, sodium plus potassium minus chloride. It again, because bicarbonate is not such a big chunk, actually everything gets reclaimed, so only these cations and anions are important, and therefore we look at the urine anion gap and we get ahead with it. This should be about half the osmolar gap. This should give you an assessment of the ammonium excretion. The positive urine anion gap indicates low ammonium excretion. So if a child has positive anion gap in a metabolic acidosis setting, I would think ammoniogenesis is inappropriately low, and this is a renal tubular acidosis. Now, this does not help me distinguish proximal from distal, unlike it was done in the past and was always said. What about urine osmolar gap? This first test, the anion gap, is probably not reliable if you have too much bicarbonate in the tubules, because the premise is that the bicarbonate is not there. So therefore, you do urine osmolar gap. Now, in the interest of time, I'll probably quickly go over these other tests, the bicarbonate loading test and the Eumenes beef CO2 gradient. Now, these two are done simultaneously in a patient by loading them up with bicarbonate, either orally or by IV route, and then examining whether enough bicarbonate gets filtered out or not. If proximal secretion, proximal absorption is fine, as in it is not Fanconi, then the percentage loss of bicarbonate will not be too high. Fe bicarb will be normally less than 5%. A value more than 15% indicates to you proximal dysfunction. On the other hand, simultaneously you can look at the CO2 in the urine and the blood and subtract it. The value should be more than 20. If it's not, it indicates that not enough H plus was being secreted distally, and therefore CO2 was not formed distally, and therefore the CO2 value in the urine is low. So you do have to evaluate anybody's suspected proximal RTA for components of Fanconi syndrome, and these would be the different components: the proteinuria, the aminoaciduria, glucosuria. Glucosuria is a very, very good clue to Fanconi syndrome. We also assess phosphate wasting. You would use a Bigelow nomogram. We would use different thresholds in childhood. The Brodell's formula and thresholds would be used. Since a lot of it is a systemic disease, we must do a careful evaluation for different causes. For example, here you can see cystine crystals. You can see a kid with Loeys syndrome wearing those thick spectacles. You can see a cataract in, say, Wilson or galactosemia. The dense bones indicate to you osteoporosis of carbonic anhydrase deficiencies. And in distal RTA, you could have ovelocytosis. What about type 4 RTA? You are probably more familiar with this scenario. Looking at plasma aldosterone and then challenging them with fludrocortisone dosing to figure out the change in the TTKG, the transtubular potassium gradient, would be ways to go for assessing for the type of or the etiology of type 4 RTA. What about what do we see? In our practice in the last 10 years, this is our distribution. We would have about half and half of distal RTA and Fanconi syndrome. And Fanconi syndrome for us has chiefly been cystinosis, dent disease, Fanconi-Bickel syndrome, Loeys, etc. While distal RTA, I'll just come to you to tell you that. So overall, a majority of them can be diagnosed by genetics. So there's a big role now for next-gen sequencing for us in this setting. Differentiating them would go through with these tests. And I think in the interest of time, I should close here rather than take this forward. Thank you. I'll just close here.
Thank you, ma'am, for that astounding deliberation. I do believe that there are overwhelming number of questions from the floor, but for the time constraint, we would like to have one or two questions. So the floor is open for questions.
Thanks for coming and thanks for the talk. Just two quick questions. You are still taking a cutoff of urine minus blood CO2 of more than 20 for DRT and less than 10 for DRT. So what we have seen that majority of our patients who underwent a sodium bicarb loading, the DRT patients had negative urine minus blood CO2 may not be fulfilling that criteria of 10, and those without DRT had positive urine minus blood CO2. So what's your take on that?
I mean, I don't think there are any papers that talk about looking at 0, 10, 20, 40 as thresholds to discriminate between distal and proximal. But I agree that mostly the kids with distal RT would have a negative value rather than any number at all.
And the second point is, majority of DRT patients had some form of nephrocalcinosis or a subclinical form of interstitial disease affecting the NH3 transport.
In adulthood?
Yeah, in adulthood.
Yeah.
So
that's different for us as pediatric practitioners.
So does that defect in ammonia transport interferes with urinary pH, meaning
does.
thereby can they have low urine pH less than 5.3 because of less NH3, less ammonia in the
Will they
discharge?
have less than 5.3 or more than 5.3?
Is there any possibility that they might get a urine pH of less than 5.3 because of defective NH3 transport?
I mean, why would selectively NH3 transport get affected but not the H plus transport in the tubulointerstitial diseases that you talk about? I believe that both will get affected. So it is more often the case that even the hyperkalemic types of DRTA, which is the voltage dependent DRTA, which would occur in many of those settings, would not be able to lower the urine pH.
Okay. Thank you.
Okay.
Thank you. And any more questions? If there is none, then thank you, ma'am.
Thank you.
Thank you for excellent deliberation, and we are grateful to you for this topic. For the next session, I would like to call upon stage Dr. Ipshita Misra, who is from Kotak, IMS and SUM Hospital, Associate Professor, who will be enlightening us with hormonal evaluation in DSD. Ma'am, the stage is all yours.
Thank you. I thank the organizers for the opportunity. Well, in next couple of minutes, I'm going to fit in about this diagnostic pitfalls and problem solvings when we talk about the hormonal evaluations in DSDs. So in 2006, Chicago consensus, they gave a revision of the nomenclature of the DSDs, and as per the karyotype, they subdivided into three major categories: the sex chromosome DSDs, depending upon the degree of aneuploidy, and the 46XY or the 46XX DSD. So 46XY and 46XX DSD, either the defect has to be at the level of the gonads, most likely due to the factors which are involved in the sex determination and differentiation, or something would be defective at the level of androgens, a defective production or action, maybe at the level of adrenals or at the level of the gonads again. Now, DSD is usually suspected at birth when the child presents with a genital ambiguity, which is the most common scenario. But sometimes, if at all a USG has been done antenatally and you have seen a genital ambiguity, then you can follow up that child after birth. Now, the problem is, majority of the single etiology can have a wide spectrum of presentation. Hence, it is very important to know the anatomical and the hormonal mechanisms which are involved in the fetal sex differentiation. Not only that, how the reproductive axis operates after the birth of the baby is also important, because you have a basket of tests and you need to choose which appropriate test you want to use for that particular patient, because the diagnostic approach has to be modified depending upon the age of presentation and the phenotypic presentation. Now, in the era when the genomics are on a rise, there is something known as deep phenotyping, where you have to examine and re-examine your patient. So overall, if you look into how the parameters change, so at the onset of birth, we know that the gonadotrophins and the sex steroids are low in the initial days, and then they rise, and then after the mini-puberty, they fall down, but the sexual dimorphism does exist. Important is the AMH, which increases in mini-puberty and stays high, more so in the male sex, and continues to remain high during the pre-pubertal periods, and later it dips down as the ontogeny of puberty sets in. Similarly, in Min B, initially there is a rise, fall, and as the puberty sets in, there is an increment. Now, this is important because AMH plays a very classical role in evaluation of many diseases when we want to reach the etiology. So to start with, we will go to the newborns. How do they manifest? So most common, as I have already told, it is ambiguous genitalia, or if at all you have found it out antenatally, or if there is a discordant between the genitalia and a fetal chromosomal sex which has been done due to some other reasons. So first thing which we see is whether the gonads are palpable or not. So gonads are palpable, we know that probably it is a 46XY DSD, or we have the ovarian and the testicular components together. Along with that, simultaneously we send a karyotype, which is the basic step. Gonads not palpable, we go in the evaluation of 17-OHP, and if needed, the ACTH stimulated 17-OHP. And we all know that 17-OHP has its limitations of the birth of the child, prematurity, sepsis, etc., etc. So 46XX DSD, 17 OHP on a higher side for the female reference range. Usually taken cutoff is anything more than 2 ng per ml. More than 10 ng per ml, we are still happier because we know that probably these are the classical variants. Testo high. Gonadotropins AMH are not routinely done when we are having a strong suspicion of a CAH. But classical finding CH. Now, if you look into the middle arm, here there is an important role of gonadotrophins and AMH. You have the 17 OHP equal for the female range, testo on a higher side, AMH is equal for the female range, but gonadotrophins elevated, it is probably a aromatase. Gonadotrophins are normal, it's a virilizing tumor or a androgenic exposure. 46XX DST, if both 17 OHP is for the appropriate for female range and testo AMH are on a high side, and you have the gonadotrophins normal with the uterine remnants, probably it's a testicular or a ovotesticular DST. Now, if you get the karyotype 46XY, if you look into the extreme left arm, if the testo is elevated for the male range, AMH is elevated for the male range, and there is lack of any Mullerian remnants, probably it is a target organ defect. So you have a high gonadotrophin, you are suspending androgen insensitivity, or you opt for a stimulation test, a post-beta CGT, DHT, cutoff which is usually taken is 10, and it is a 5-alpha reductase deficiency. If you come to the extreme right, the testo AMH are all low, both the gonadotrophins are high, FSH more, and you have the remnants, it's the dysgenetic. Middle one, if you look into that, testo is low, but AMH is appropriate for the male ranges, which shows that the Sertoli cells are still functioning, and the gonadotrophins are elevated with lack of the presence of uterus. Probably you are dealing with a steroidogenic defect, and you need to choose from the battery of tests whether you need to do a HCT stimulation or a HCG stimulation test to localize to the adrenals or the gonads respectively. Routinely, the standard HCG stimulation test is done, and the protocol is aware, everybody is probably aware with the protocol of that. So, but if you have a suspicion of a gonadal dysgenesis, you may opt for a prolonged HCG stimulation test, and then you want to reach probably the diagnosis. Now, supposedly, you get the karyotypes which are concordant. The testo AMH are appropriate with the gonadotrophin, with the karyotypes, and the gonadotrophins are also appropriate with the karyotypes. Could be a malformative variant of DSDs. And clear-cut, if you get a mosaic pattern or a chimer pattern, then it is the sex chromosome DSDs which you are dealing with. Now, this is important, troubleshooting and choices. It may not be necessarily that always the basal hormones will give us an answer. So we need to use a stimulatory test, either a ACTH or a HCG stimulation. Interestingly, not necessarily the TDHT cutoff which we use as 10 will have a clear-cut differentiation between 5-alpha and the pious. So we need to use, probably in those scenarios, go for a higher investigative modality of gas chromatography to look into ratios of certain urinary steroid metabolites, especially the tetrahydrocortisol to allotetrahydrocortisol ratios, which is having high specificity. Urinary testing per se is not routinely available, not feasible and difficult in the newborns. And sometimes DHT deficiency can occur due to the defects in the backdoor pathway, which is often missed. And if you have a suspicion, if you are not finding an answer, probably you may need to do a steroid metabolome analysis. Now, this is interesting. No genital ambiguity. Boys, 46XX you are getting on the karyotype. No palpable gonads, of course, probably it's the CH on the first line. If palpable gonads are there and you are getting testo and AMH in the male ranges, think of a testicular DST. If completely phenotypic female and you have getting a karyotype of 46XY, if you look into the extreme left, so if the testo AMH are elevated, it could be a target organ defect, and the same protocol. Extreme right, testo AMH not detectable, probably a dysgenetic one. And if the testo is not detectable with AMH, again in the male ranges, with lack of presence of uterus, you may need to think about a steroidogenic defect. Now, supposedly the child has been missed during the newborn period and lands up later on. So if there is ambiguous genitalia or discordance between the external genitalia and karyotype, it is almost a similar protocol which we have spoken earlier. What needs to be kept in mind is here AMH plays a valid role to look into the presence or absence of testicular tissues, and you may need to consider using stimulatory tests. And the other scenario, if that you have a male genitalia with cryptorchidism incidentally found to have a uterus on ultrasonography, here again AMH plays a role to help us to know whether it is which variant of PMDS, supposedly. Now, moving on again the supposedly it is missed and you are coming to the adolescent ages. Boy presents, and we'll take one scenario where there is an adolescent boy with small testis and gynecomastia. Clear-cut karyotypes, if you get of the aneuploidies, it is either KFS. Supposedly 46XY testo, gonadotropins, all elevated. Here you can incorporate inhibin B along and have a suspicion of mice. Otherwise, if you get the clear-cut variants of mosaic chimer patterns, then you are dealing with probably a OTDs. Adolescent girl presenting with a primary amenorrhea, first thing which we should look is presence or absence of a breast tissue. Breast is absent, Karyotype, if it comes as 45XO or variants, we are happy that it's a clear-cut case of Turner's. 46XX, we need to keep in mind a set of disorders, importantly FSH resistance, where the AMH is appropriate for the female ranges, but the E2 is lower, gonadotrophins are on the high side. But the problem arises if the karyotype comes as 46XY. It could be again a dysgenetic variant, or it could be any defect at the level of LHR or 17 alpha 1720 lyase, and the protocol needs to be followed. And again here, AMH plays an important role in looking into the presence or absence of testicular tissues. If the breast is present, then it could be either a Turner variant as per the karyotype. It could be again a 46XX karyotype. But interestingly here, you should look for the presence of, if features of virilization are present, if the testo and AMH are in the male ranges, probably you're dealing with a OTD variant. And 46XY, it's again Chias of 5 alpha. Now we have spoken about cutoffs. Now this was a paper which was published taking 1,000 newborns until mini puberty, and they found that for patients not having DSD, boys had significantly higher concentration of LH. The cutoff of LH to FSH ratio of 0.32 separated boys from girls with an accuracy of 99.8%. AMH and inhibin B were very higher. And the same when they extrapolated to the DSD variants, they found that gonadotrophins and this ratio were appropriate to determine the sex chromosome DSDs. Appropriateness of the ratio was also holding true for Chias, and AMH played a very significant role in knowing the presence or absence of testicular tissues in those who were presenting either with virilization at birth or presenting in as phenotypical females. So overall, if you look into the profiles of set of investigations which we do, it's either the steroid metabolites or certain peptide hormones. Steroid metabolites are routinely watch assays used are the immunoassays, but some people say that should be done by a chromatographic method where multiple steroid metabolites can be assessed simultaneously. You can use the serum, saliva, or urine as the analytes. But importantly, the lab must have their own established reference ranges, and quality control programs must be run. So this was the position paper which was published by the European Union, which almost said the same thing, that immunoassays and currently mass spectroscopic methods both can be used for the diagnosis and management, and quality control with their own individual references ranges are something which needs to be established. Now the same paper gave some data about if there is a troubleshooting in the diagnosis of certain enzymatic variants of 46XX DSD in 21 hydroxylase deficiency, suppose, you have some particular metabolites in the urine such as 17-hydroxypregnanolone, pregnanitriol, which has got higher specificity if you get the normal blood parameters in the gray zone. Similarly, for 11-beta hydroxylase, you have tetrahydro11-DOC. For 3-beta HSD, you have androstenediol. For 46XY DSD, they did not give any data available for the STARS defects, which causes as a spectrum of manifestation in the 46XY DSDs. In 17-alpha hydroxylase 1720 lyase, if the routine steroid metabolites are again in the gray zone, you can opt for looking at the urine parameters of 17-deoxygenated and metabolites. 5-alpha reductase deficiency, there is always a gray zone. It may not be that your TDHT cutoffs would be exactly more than 10. It can shoot up to 20-25 in the early newborn period also. So here you can run a urine analysis of 5-alpha and 5-beta reduced tears and you can get an answer. But for 17-beta HSD3, they said that the ratio of the T by A cutoff of 0.8 holds still true. Peptide hormones, routinely the immunoassays are done, no gold standard is present, and again the age-specific ranges must be established, and now there is the era of genomics, proteomics, etc. So proteomics are coming up to assay the peptide hormones, which are equally at par with the existing mass spectroscopy methods. So again, the European Union published a position paper regarding the analysis of these hormones in DSDs. They said that 5 peptide hormones are important: FSH, LH, AMH, inhibin B, and these needs to be incorporated along with your clinical examination, along with your karyotypes, relevant steroid hormones, and if needed, genetic analysis. Serum or plasma is the preferred matrix for analysis of these peptide hormones. Urine LH in some research settings may be. Sexual dimorphism does exist. So functional tests, we have the stimulatory test which we have discussed. But the problem is in XY DSDs, it is very difficult to reach a etiological diagnostic irrespective of all the hormonal tests, whatever they are available. And the need of a genetic test, it is may be essential, and which helps us to reach the etiological diagnosis. And in the era where we have multitude of genetic tests available, we must identify which genetic test to be used in suspicion of which variant of 46XY DST, especially the Sanger's, WES, and the CGPs which are available. To end, I'll take up this patient, which was very interesting. 20-year-old, raised as a female. She presented with primary amenorrhea, extremely short stature. Her secondary SMR was A1, P2, and B3. And if you look into the external genitalia, symmetrical appearing, 2 distinct openings, non-fusion of labioscrotal folds, no clitoromegaly, no palpable gonads, urethral opening, and 1 blinded vaginal pouch, and karyotype was 46XY. So routine, as for the tests which were run, you can see that gonadotrophins are elevated, low testo, E2 low, but AMH was appropriate for the lab reference range, and this was something which was very difficult, that how come the testo is low and the AMH is stable, because we were very happy thinking it's a complete gonadal dysgenesis. USG could not localize any Mullerian structures. So at this point, the first diagnosis comes as probably it's a gonadal dysgenesis. Chias does come in mind, but again, where are the gonads? Gonads are not palpable. So then again, Chias was a difficult thing, and there were certain other diagnostics which were present at the back of the mind. So just to satisfy, and definitely when we are not able to know what it is, we did an exploratory laparotomy where the gonads were found, and rather they were taken out. And on histopathology, there was for presence of seminiferous tubules which were lined by Sertoli cells, and also the Leydig cell hyperplasia. So now the differentials were shortened down to probably a PGD, probable androgen insensitivity, LH receptor mutation. But how come androgen insensitivity when you have got a testo on a lower side and the gonads are completely not palpable and they are intra-abdominal? The patient was subjected for a genetics testing to get a final answer, and it was indeed androgen insensitivity. But the points against was, as I told, poor breast development. The patient completely denied that any form of estrogen exposure was there, and she had a B3. I did not understand how probably the testo was low and how the gonads were not palpable. When we did a review of literature, probably it could have been something with the SHBG. We did not do that, so that could be one answer. And because the gonads were intra-abdominal and some dysgenesis has occurred, probably the testo was on the low side. So just to sum up, DST may present with clinical and biochemical specificities according to the age at consultation. A detailed anatomical description of the external, internal genitalia after adequate imaging studies and surgical exploration are needed. Reproductive hormone level assessment, karyotyping, give a sufficient information at the primary stage, but if needed, you may need to choose up high-end modalities and sophisticated investigations such as mass spectrometry, cytogenomic microarrays, and the NGS or WES. Thank you so much.
Thank you so much, ma'am, for your kind presentation. And any question from the hall, please? No questions? Okay, ma'am. Thank you, ma'am. And for the next scientific session, we are having... Okay, for the next scientific session, we are inviting Dr. Beatrice Anne ma'am from Hyderabad to enlighten us on CR.
A very good morning to all of you. Firstly, I would like to thank the organizers for the invitation. It's always a pleasure to be in Kolkata because I get to see my teachers, my seniors, and all my friends. So I'm going to be talking about the updates on SIADH. So it may not be the typical flow of presentation saying pathophysiology and diagnosis and treatment. Whatever I have found interesting while I was working up or while I was reading up for this presentation, I've just compiled into a presentation I'm going to discuss with you all. I think you're projecting the wrong slides. Okay, let me go ahead. So, SIADH, primarily we are going to be dealing with hyponatremia. And as you all know, we can first classify it based on the serum osmolality into hypotonic, isotonic, and hypertonic. So, hypotonic is the true. And the pseudo-hypotonic and the hypertonic is what we're going to be talking about. The pseudo-hyponatremia is usually because of increased solutes in blood, like lipid and protein, wherein you have to get the proper or the correct sodium levels by direct assays. And you have the translocational hyponatremia, which is because of the increased effective osmoles like glucose and mannitol. And we also have biochemical classification from both the US as well as the European guidelines. Mild is 130 to 135, moderate about 125 to 129, and severe is less than 125. And there is also a severe hyponatremia, which is also classified by the clinical symptoms. So somebody who has altered sensorium, severe nausea, vomiting, features of increased intracranial tension. So all of them will be classified as severe hyponatremia. And etiology, again, we know hypovolemic, euvolemic, and hypervolemic. And SIADH, we are typically looking at euvolemic. And again, based on the acuity of onset, we'll classify them as acute and chronic, less than 48 hours and more than 48 hours. This is basically based on how long the brain gets to adapt. So that is the biochemical classification or the biochemical basis on which this 48 hours is classified. But there is a new update here. Now we are going for more stringent guidelines, more stringent cutoffs. So less than 24 hours is what is taken as acute hyponatremia. And this is only to prevent ODS or osmotic demyelination syndrome by treatment. So this is the criteria, Schwartz criteria that all of you are aware of. The patient should have normal renal functions and no diuretic, especially thiazide diuretics, and absence of other potential causes of euvolemic hypoosmolality like glucocorticoid insufficiency or severe hypothyroidism, and urinary sodium excretion of more than 30. Again, there have been different studies based on this cutoff. If you take a higher cutoff, so let's say more than 50, you will have a more specific diagnosis, but the sensitivity goes down. Clinical euvolemia, so absence or signs of hypovolemia or hypervolemia, and inappropriate urine concentration, that is urine osmolality of more than 100 in the presence of a low serum osmolality, that is less than 275. So this is the Schwartz criteria for SIADH. Causes of SIADH, as you all know, ADH is synthesized in the magnocellular neurons of the hypothalamus, and it is going to be stored in the posterior pituitary. And based on the osmotic stimuli and stimuli from the baroreceptors, you have secretion of AVP, which is going to act on the V2 receptors, which are present in the basolateral part of the principal cells in the collecting duct. And this is going to cause insertion of the aquaporin 2 channels, which is going to cause increased reabsorption of water. So disorders which affect or which can cause SIADH are central nervous system disorders, which could be anything ranging from trauma to hemorrhage to tumors. And malignancy, especially small cell carcinoma of the lung, which could cause increased secretion of AVP from the neuroendocrine cells of the lung, or related vasoactive peptides, drugs. There's a whole lot of drugs which can cause SIADH or an SIADH-like picture. And there are other transient non-osmotic stimuli, especially pain, stress, vomiting. So all these are non-osmotic stimuli for secretion of AVP, which is especially important in the post-operative setting. And we have, just like we have nephrogenic DI, we also have activating mutation of the V2 receptors or the nephrogenic SIADH. And of course, if we do not find any cause, we label it as idiopathic. But the most important or most common scenario where we see SIADH is post-pituitary surgery. So we know the triphasic response here. So the first is the pituitary stalk injury, axonal shock, where there is a transient phase of DI followed by SIADH, which is because of the axon terminal degeneration, and there's going to be uncontrolled AVP release. And then there is retrograde axonal degeneration, and there can be death of the AVP producing neurons, which can lead to permanent DI. But this triphasic response may always not be there. We can have only an isolated SIADH phase, isolated hyponatremia, which can even be delayed. So this was a paper from CMC Vellore, which had looked at delayed hyponatremia. And by delayed hyponatremia, they meant more than 3 days post-op. Delayed hyponatremia following surgery for pituitary adenomas. They found that majority of these patients had macroadenomas. In their center, they apparently discharge at 72 hours. And these patients go home and they can develop delayed hyponatremia, that is more than 3 days. Usually it happens around 6 to 12 days, and it usually resolves on its own within 5 days. So what are the causes of hyponatremia after surgery? So this SIADH is one cause. I told you about the triphasic response. The other differential, which is again been questioned, this entity itself has been questioned, that is cerebral salt wasting. This is probably because of an increase in the release of brain natriuretic peptide, which causes an increase in the sodium excretion, or it could be because there is an interruption in the sympathetic flow and there is a suppression of the RAS pathway. So that also could be one of the reasons, or any unidentified peptides, we do not know. But the only way to differentiate clinically would be a hypovolemic status, which is seen in a cerebral salt wasting syndrome. But again, it is very difficult in a post-op setting, patient in the ICU, to in fact look at the volume status unless you have a central venous pressure reading. So there it may be a little difficult. So there are a few ways to differentiate between SIADH and CSW according to the recent updates. One is that brain natriuretic peptide, if measured, can be high in cerebral salt wasting. The second thing is fractional excretion of uric acid, which is usually more than 12% in patients with SIADH as well as in cerebral salt wasting when there is hyponatremia. But on correcting the hyponatremia, patients with SIADH will show an improvement in the fractional excretion of uric acid, whereas this is not seen in patients with cerebral salt wasting. And there is a newer peptide called the haptoglobin related peptide without signal peptide. So this is a newer peptide which is also being studied to differentiate SIADH with CSW, and this has not been validated. So currently we will not be using it in clinical practice. And other causes where you can have hyponatremia after pituitary surgery would be adrenocortical insufficiency and hypothyroidism, or overload of hypotonic solutions, or if there's desmopressin, usually in the second phase DI, we need to wait for the polyuria to recur to give the desmopressin dose. An over-enthusiastic administration of desmopressin, so that also can lead to hyponatremia. So a delayed SIAD can follow the early AVBT or occur in isolation. That is, a second phase can occur in isolation, and it can also occur little later because of that is because of the AVP neuronal bodies which have undergone retrograde degeneration. So what are the predictive factors that tell us that this patient is going to develop post-operative hyponatremia? According to this disease, according to this paper from CMC Vellore, those patients who had Cushing's disease, who were females with a lower BMI, younger or older age, that is more than 60 years, if they had preoperative hyponatremia, or if they had underlying cardiac, renal or thyroid disease, if they had preoperative hypopituitarism, and if they had a post-op CSF leak, or if the tumor was large enough to cause optic chiasm compression, or if their sodium fell in the first day after surgery. So these were all predictive factors to show that this patient would develop delayed hyponatremia. So how do you manage? You manage just like how you manage other causes of SIAD. So you're going to give fluid restriction, oral urea if available, tolvaptan for as second line therapy, and administration of 3% hypertonic saline in severely symptomatic cases. Patients with acute hyponatremia of less than 48 hours duration, they are often severely symptomatic if the plasma sodium is going to fall to less than 120. And these are the kind of patient where we need to promptly increase the plasma sodium to reduce cerebral edema. So coming to the next question, what is the role of copeptin in hyponatremia? We have heard about copeptin in diabetes insipidus, but what about hyponatremia? So according to the measurement of copeptin, the value in SIAD is not much. So I'll show you this slide here. So this, they have actually looked at hypernatremia and hyponatremia, and they've seen the utility of copeptin. So copeptin is a more stable peptide compared to AVP, which is going to get lost off in the sample. So then a more stable peptide like copeptin will give us a better assessment of what is the status of the AVP secretion in the body. So here they found that the copeptin levels did not really differentiate much between the causes of SIAD or different causes of hyponatremia. But in one situation, that is when the patient is having a nephrogenic SIAD, in that condition, when it was low, then it had a positive predictive value. Otherwise, it did not have much utility in patients with hyponatremia. But nevertheless, they found, based on the copeptin measurements, they have classified SIADH into different types. So this is again a newer classification. In type A, you see here the graph here, type A is elevated copeptin levels throughout. So this is usually seen in patients who have paraneoplastic SIAD. So uncontrolled ADH release, which is seen in these kind of paraneoplastic syndromes. Type B is a reset osmostat, nothing to be alarmed about, because at lower osmolality, AVP responds appropriately. This is usually seen in elderly people who may have serum sodium levels between 125 and 135 and still they are stable. But when the sodium drops to less than 125, there is an appropriate response from the AVP. Type C is basically does not respond well at all. So even at low osmolality or high osmolality, we do not see much elevation or depression in the AVP values. Type D is very low copeptin levels in the presence of SIAD, and it is probably thought to be because of some other factor other than AVP. Type E is the newer inclusion in this classification, and that is reset barostat. So basically, if you see this E here, it does not respond much to the osmolality, but it responds in a very sensitive manner to the blood pressure. So from the baroreceptors, if it gives a little, if there is a slight volume expansion, there is going to be an exaggerated response. And slight hypovolemia, again, there is going to be an exaggerated response. So this is type E. So these are all based on the copeptin measurements. So coming to the management, I'm going to be talking, first is a fluid restriction. And if it is refractory to fluid restriction, we have second line therapy, that is tolvaptan, urea, SGLT2 inhibitors, and other therapies. So I'm going to be briefly touching upon each of these therapies which are available. Fluid restriction, as you all know, is the most common treatment of hyponatremia, but it corrects only by 1 to 2 milliequivalent per liter per day, even when severe. So even if you're going to restrict to less than 500 ml per day, it is not a very effective measure. And the problem is with the compliance as well, because these patients with SIADH also have increased thirst. So they will not be able to do fluid restriction to such severe levels for a very long time. You all know about the formulae for management of hyponatremia, the Hillier formula to correct for sodium, and the Adrock-Medeas formula to look at how much the sodium will increase given a typical type of fluid. But what is more important are these two. The fractional excretion of uric acid. So when you calculate this, when you have somebody on diuretics, and if you still are suspecting SIAD, so this is a good way of figuring out if this patient still has SIADH. So here the patient's uric acid, fractional excretion of uric acid will be more than 12% in patients with SIADH. And then there is the first ratio, or it's called the first equation, which is nothing but urine sodium plus urine potassium divided by the serum sodium. This again is a measure which will tell you if a particular patient is going to respond to fluid restriction or not. So if the first ratio is less than 0.5, fluid restriction of about 1000 ml per day is recommended. The first ratio is about 0.5 to 1. You give more severe fluid restriction about 500 ml per day. But a first ratio of more than 1, it means that this patient may not respond to fluid restriction, and you should not rely too much on fluid restriction for this patient and go on to second line therapies. So these are the studies available for fluid restriction therapy for chronic SIAD, RCTs available. So here they have concluded that it causes only a modest early rise in the plasma sodium in patients with chronic SIAD with minimal additional rise thereafter, emphasizing the need for second line therapy. There are also other RCTs available which also have similar findings. So how do you know that this patient is going to fail fluid restriction? If the urine osmolality is more than 500, a 24-hour urine volume of less than 1500, and the first ratio more than 1, and if the increase in plasma sodium is less than 2 within the initial 24 to 48 hours of fluid restriction of less than 1 liter per day, then these are patients who may not respond only to fluid restriction and we need to go on to second line therapy. And fluid restriction, as a rule of thumb, should be at least 500 ml less than the estimated 24-hour urine output. So this is very severe symptomatic hyponatremia where you have to increase the sodium levels quickly. So according to the European as well as the US guidelines, you give boluses of 3% saline and then you reassess the patient. You give these bolus up to a maximum of 3 over 10 to 20 minutes and you stop when the patient's symptoms improve because we do not want overcorrection and that may lead to osmotic demyelination syndrome. So these are the US recommendation and the European guidelines for both of these management of hyponatremia. They're almost similar. At a severe symptoms, you give 100 ml. In European guidelines, you give 150 ml. Duration is again 10 minutes, 20 minutes in European. And target sodium rise is again almost similar. Over 4 hours, you want a quick increase here because it is acute and it is severe. 4 to 6 in US and European guidelines about 5 millimoles per liter. And maximum bolus given can be 3 boluses. And if it is mild to moderate symptoms, US recommendations are that you give 0.5 to 2 ml per kg per hour, 3% saline infusion, whereas European guidelines differ. They say give a single bolus of 150 ml. And acute and chronic, you know the cutoffs, you cannot increase it by more than 10. And if the patient is having feature or risk factors for ODS, not increase by more than 8 millimoles in the first 24 hours. So going on to the second line therapies, that is tolvaptan. Tolvaptan is a selective oral vasopressin V2 receptor antagonist which has been studied in different clinical situations and they found that it is effective in the management of euvolemic and hypervolemic hyponatremia. But the problem with tolvaptan is the concerns of overcorrection of plasma sodium. So the baseline plasma sodium, if it is less than 121 and the blood urea nitrogen of less than 10, it is associated with a significantly greater rise in the plasma sodium following tolvaptan. And the use in SIAD in the post-operative pituitary surgery setting is not very well studied. We do have some retrospective studies and case reports and series. And in the SALT-1 and SALT-2 trials, tolvaptan has been shown to be an effective treatment. And patients who were on tolvaptan more than 15 milligram per day, they were more than 2 times as likely to achieve a normal sodium by day 30 compared with the placebo. So this is about after transsphenoidal surgery. This was a retrospective single center analysis. They found that higher correction rates of plasma sodium with tolvaptan than standard treatment. However, overcorrection happened in about 64% of patients treated with tolvaptan. And this was not different when you reduce the dose to 7.5 mg. And in other prospective observational studies also, similar findings were found and 7.5 mg was in fact found to be more effective than fluid restriction. So role of urea. Urea, it induces mild osmotic diuresis and there is an increase in the plasma sodium in patients with SIAD. But the advantage with urea is there is a low risk of overcorrection or serious adverse effects. It's an effective and safe treatment for acute hyponatremia even in neurosurgical patients. Recommended dosing is about 30 to 60 gram daily in 2 divided doses. And a dose of about 7.5 to 90 gram per day results in a mean plasma sodium increase of 2.5 to 5 millimoles over the first 24 hours, which is quite good. And experimental data has also shown that urea is protective against osmotic demyelination. But unfortunately, urea has a bitter taste and it has to be mixed with sweet tasting substances such as orange juice to make it palatable. And there have been studies on oral urea for the treatment of hyponatremia in hospitalized patients. So this was a retrospective review which looked at about 58 patients with hyponatremia, about 81% had SIADH, and they have given 7.5 to 90 grams per day for 4.5 days. And in this cohort, only about 24% were treated only with urea for the hyponatremia. And they found that patients who were treated with urea, they fared better when it came to increase in the sodium and they were better tolerated and it was found to be safe. Loop diuretics we do not use much, because along with the diuresis, there's also going to be loss of sodium and it can worsen the hyponatremia. Empagliflozin, again a very interesting concept here. You have osmotic diuresis, so could be used as one modality of treatment for hyponatremia. It has been studied in about 87 patients for 4 days, where it was found that patients who were given empagliflozin, about 14% of them were diabetic, but patients who were given empagliflozin had a better increase in the serum sodium compared to placebo. This is a newer update. These are apelin analogs which are being tried now or which are being studied now in animals for SIADH. So apelin receptors are present in the hypothalamic magnocellular vasopressinergic neurons. So when you give apelin analog, it's going to reduce the AVP secretion and it's going to promote free water excretion. They're also present in the renal collecting duct. So it's going to reduce the aquaporin expression via crosstalk with the V2 receptor, and it reduces the AVP secretion and it promotes free water excretion. But it's still in animal studies. The future may hold, in the future they may have human studies. So the take-home points: hyponatremia is common in hospitals and is linked to higher morbidity and mortality, and tolvaptan and urea are most effective second-line treatment if fluid restriction fails. And RCTs in real-world settings for moderate to severe hyponatremia are lacking. And SIAD is a frequent cause, often responsive to fluid restriction about half of the cases. So we may have to look at second-line therapies and newer treatment modalities like empagliflozin, and the ones in the pipeline like apelin analogs, they still have a promise in the future. Thank you for patient listening.
Thank you, ma'am. And that was an excellent deliberation, as we all expect from ma'am, we all know. So I know the audience is teeming with questions, but for the time constant, I would like to keep short. So we'll just allow 1 or 2 questions.
Lecture there. Just a couple of questions regarding tolvaptan. How long can we use it uninterrupted? Any idea?
So the US FDA has given a time limit of about 30 days where it can be used because of the risk of hepatotoxicity. So for 30 days you can use. But there is a study of that salt water extension trial where patients have been on it for almost 4 years with no side effects.
And the other quick question is, you spoke of a urine sodium cutoff of 30, pushing it up to 50 would increase the specificity. So the differential here is cerebral salt wasting, because we don't have many differentials of euvolemic hyponatremia. So specificity against what? Against cerebral salt wasting?
Not really against cerebral salt wasting, but probably other causes of euvolemic hyponatremia.
The other rarer ones.
Yes.
Thank you.
Thank you. Thank you, ma'am.
Sir.
A moderate or mild form of chronic liver disease, and we are suspecting the patient is suffering from SIADH. So if we think of tolvaptan, what should be your take on in this message? Because in a case of CLD, problem of tolvaptan is there. So what should be these are the common problems we do face.
Probably not a good idea to use in patients with liver disease, sir.
So is there any category that in childhood category A or B we should be, or in the
I'm not aware of such a category, but then there is according to the US FDA, they say that do not use it in chronic liver disease or any form of liver disease for that matter, because there is a risk of severe hepatic toxicity.
And another question is, as you have already said that loop diuretics is not so much useful, but it is our age-old teaching that if you give loop diuretics, in a particular time it will excrete more fluid than the sodium, and it is our actually intention to treat here in case of SIAD. So if we give oral salt along with fluid restriction and low dose of loop diuretics, I think many patients are better with this treatment modalities. But it is my personal experience, you may differ, but this is the most important treatment modalities.
Yes, there is a study which I didn't elaborate here. It was a study from Thailand which has looked at fluid restriction plus loop diuretics, fluid restriction plus loop diuretics plus oral sodium. And they found that there was no difference, in fact, and the risk of kidney injury and hypokalemia was higher in the patient who were on more intensive treatment. So due to the risk of adverse effects, I think it would not be a great idea to go for furosemide.
Thank you, ma'am. And as usual, it's expected from you, right? So a big thank you for Beatrice, ma'am. So I would like to call upon stage Professor Rama Walia, ma'am, who is an additional professor from the Department of Endocrinology of PGIMR, Chandigarh. And ma'am will be enlightening us on petrosal sinus sampling, its pitfalls. Thank you, ma'am. The stage is all yours.
First of all, I'll say thank you to the organizing committee for delivering me talk on IPSS pearls and pitfalls. So we all know that etiology of Cushing syndrome, 80% of the cases are because of ACTH dependent and 20% are because of ACTH independent. Out of these 80% cases of ACTH dependent, 90% are pituitary in origin. That's why the first modality turns out to be MRI SELA in all the patients with ACTH dependent Cushing syndrome. But we face imaging challenges in Cushing syndrome because we require specific sequencing, which is dynamic SPGR or MP rate sequence. Still, MRI has a sensitivity of 60% and specificity of 85%. There are reports of radiologists reporting it's a suspicious adenoma, and there can be pituitary incidentaloma in general population in 10 to 15% of the cases. And tumors less than 6 millimeter are more likely to be incidentaloma. However, this study was based on general population. In a patient with ACTH-dependent Cushing syndrome, if there is pituitary adenoma, then the chances of it being corticotropinoma are much higher as compared to that in general population. So any lesion in pituitary in a patient with ACTH-dependent Cushing syndrome should be considered as corticotropinoma. Having said this, ectopic ACTH syndrome is also associated with pituitary incidentaloma in 10% of the cases, as was true in our series as well. So we cannot say that if somebody is having some lesion outside pituitary, then it is ectopic. There can be incidentaloma along with. That's why even if we see a pituitary lesion in a patient with ACTH-dependent Cushing syndrome, we need sportive test. What all are these sportive tests? These can be non-invasive dynamic tests, invasive dynamic tests, and imaging such as CT and DOTA-NOC. So Bayes' theorem says that we have pre-test probability, diagnostic test, and post-test probability. So in a patient with ACTH-dependent Cushing syndrome, it to be corticotropinoma, the chances are 90%. So any sportive test to be of useful, its likelihood ratio has to be more than 10 or 15 to increase the sensitivity to more than 95%. And standalone, none of the tests are useful. Slides are not moving from here. May I continue?
Ma'am, please, just hold on. We have facing a technical glitch. Just five seconds, ma'am. Ma'am, sorry for the technical glitch. We are fine to go.
So standalone, none of the tests are useful. These are the three non-invasive tests which are available: CRH stimulation, desmopressin stimulation, and high-dose dexamethasone suppression. However, there is no consensus on how many tests and which tests to be used. So because these cannot be used alone, we come to invasive dynamic tests, which is the area of interest today, IPSS. So if we talk about IPSS for localization of Cushing disease, that is to differentiate it from ectopic Cushing syndrome, it has a sensitivity and specificity of almost 95%. So it is very good to localize the disease. And IPSS to peripheral ACTH ratio more than 2 before stimulation and more than 3 after stimulation is diagnostic. We can use various stimuli like CRH, desmopressin, and vasopressin. As I said, the localization accuracy of IPSS is almost more than 95%. In one of the most widely quoted study, it was 98%. However, if ACTH gradient achieved is less than 400, then the results are less reliable. But lateralization accuracy is only 70%. So we cannot say whether tumor is on the right side or the left side depending upon IPSS. However, if it is left side lateralization and consistent lateralization before and after IPSS, because right side, the venous anomalies are more. So if it is left side lateralization and consistent, then the accuracy is better. But if we do surgery based on these lateralization, the success rate is only 50%, which is equivalent to chance effect. So we cannot base surgeries on the basis of IPSS. Because CRH and desmopressin are not available in India easily, that's why we did a study using lysine vasopressin for IPSS. And localization accuracy, as I have talked, was almost 100%, while lateralization accuracy was better with vasopressin as compared to CRH. Why? There are fallacies in localization. There can be fallacies in localization also. If there is poor cannulation, if there is hypoplastic inferior petrosal sinus, if there is cyclical or mild Cushing, underexpression of CRH or V1b receptors, or ectopically placed pituitary. If it is, it can be false positive in cyclical ectopic Cushing, CRH producing ectopic tumors because it will be leading to pituitary hyperplasia. Patient is on medical treatment, and it will be positive even in pseudo-Cushing states. So it cannot differentiate pseudo-Cushing from Cushing. So if there is a poor cannulation, can we go ahead using prolactin in that case to say whether cannulation is proper or not? So if we find a gradient of ACTH, then it is definitely central lesion. If the gradient is not there, we have to look for prolactin central to peripheral gradient. If it is more than 1.3, it says that the cannulation was proper. And in the presence of proper cannulation, if ACTH gradient is not there, then it is ectopic Cushing syndrome. However, if cannulation is not proper, we may try using ACTH to prolactin corrected ratios. However, these are not reliable. So this is our paper on prolactin adjusted ACTH ratio, and it again says that prolactin is a useful marker for successful catheterization, but not for lateralization. So coming to lateralization accuracy from our study, if we correlate IPSS with TSS, then the correlation was just 75%, while MRI and TSS had a correlation of 80%. So if MRI is showing something and IPSS is pointing towards the other side, then MRI is more reliable as compared to IPSS. Why there is problem with lateralization? Because corticotropes are centrally placed. So IPSS is actually not made for corticotropinoma. There is intercavernous mixing of blood. Centrally placed tumor may drain equally on either side. And tumor may be predominantly on one side, while the draining may be on the opposite side. So coming to a case with florid features of Cushing syndrome and with HTDST non-suppressible, MRI showing no evidence of pituitary adenoma. This patient was subjected to IPSS, and it showed a gradient towards left side. So based on this lateralization, patient was subjected to surgery, and left hemihypophysectomy was done, but histopathology turned out to be normal. Repeat MRI showed a centrally placed lesion, and that's why there was problem with IPSS and had to undergo redo surgery. So lateralization is not reliable if tumor is not seen on MRI. Another case, 40-year-old male with ACTH of 117 and HTDST non-suppressible, MRI is showing a lesion 5 into 4 millimeter on left side. This was a clear-cut lesion, However, again, IPSS was problematic. It showed a gradient towards the opposite side. So IPSS localized to pituitary but lateralized to right side. Patient was operated upon and tumor visualized on the left side concordant with MRI. So lateralization is not reliable even if tumor is seen on MRI. We cannot believe findings of IPSS for lateralization, although for localization it is very good. So everyone wants to do away with IPSS. Why? It is invasive with potential life-threatening complications. Cost is actually more than that of surgery. Availability is poor. Technical expertise is required. Sick patients do not give us time for IPSS, and they are fallacies, and it can be erroneous for lateralization. So coming to this consensus statement, they say if it is ACTH-dependent Cushing syndrome, go for pituitary MRI. If tumor is present and if it is more than 1 centimeter, it is likely to be Cushing disease. If tumor size is less than 6 to 9 millimeter, then it can be ectopic or Cushing disease. You go for IPSS. If there is a central gradient, it is pituitary. If it is peripheral gradient, it is ectopic. However, in the absence of IPSS, you can go for CRH and desmopressin stimulation test plus whole body CT. And if MRI, CT, and these stimulation tests are concordant either for Cushing disease or for ectopic, we can treat the patient accordingly. However, if these are discordant, we need again to subject the patient to IPSS. So we do not have CRH and desmopressin available, so we went ahead using HTDST in place of these stimulation tests. And this is the same protocol where HTDST is used in place of desmopressin stimulation tests. So if HTDST, MRI, and CT are concordant for Cushing disease, that is MRI is showing a lesion, HTDST is suppressible, and CT is normal, then it is Cushing disease. If it is opposite, then it is ectopic Cushing syndrome. So this way, we could avoid IPSS in 60% of the patients. If only 40% needed to be subjected to IPSS. And positive predictive value of this was 98% if we use LIP1 protocol and 100% if LIP2 protocol is used. So another problem is in this consensus, there is a confusion regarding less than 6 to 9 millimeter. So this is again our paper where we showed that the dynamic test hold the same utility if the tumor is less than 6 millimeter and more than 6 millimeter. So same guidelines can be used for both the tumors. There should not be any confusion regarding that. So do we have something else to bypass IPSS? So we developed this molecule, gallium CRH PET CT with MRI fusion. And we know that corticotropinoma have more of CRH gene, CRF1 receptor gene, and corticotropinomas are hyper-responsive to IV CRH stimulation, and we use CRH during IPSS, we use LDDST CRH. So we went ahead to detect these receptors in vivo in pituitary using gallium-68 tagged CRH PET CT. So this molecule was developed at a center and conjugated with DOTA. And DOTA was, this was labeled with gallium-68 and static images were acquired at 45 minutes. And these were superimposed on MRI. This was a paper published with this imaging modality. So if we can see here that in this patient, there was MRI was normal, while CRS PET CT is able to very well visualize a lesion in the pituitary, and this was operated upon and histopathology proven to have corticotropinoma. This was another patient with ectopic Cushing syndrome, where there was a bronchial carcinoid sitting in the thorax leading to ectopic Cushing syndrome, and pituitary there was no uptake in the CRH PET CT, again suggesting that pituitary corticotropes are suppressed. So this helped not only in localizing, lateralizing the disease, is also helpful in localizing the disease as well. This was another case where there was a microadenoma on the right side by IPSS lateralized to left. Again, IPSS was problematic as far as lateralization was concerned, and the tumor was found to be on the side of CRH PET CT. This was a case of Cushing disease who relapsed after 5 years of surgery, and MRI was showing post-operative changes. In this case, CRH PET CT was able to, we can see the bright uptake on the right side, and this was Patient was reoperated and went into remission. This was very interesting case. Here, as usual, MRI showed a suspicious adenoma on the right side. And because we were doing PET CT for all the patients, and PET CT showed diffuse uptake in the pituitary. We thought of the possibility of this being incidentaloma and subjected the patient to Dotanok PET CT, which showed a bright uptake in the bronchial carcinoid, and possibly this was CRH producing, which was leading to pituitary hyperplasia, and this suspicious adenoma was incidentaloma. This bronchial carcinoid was resected and patient went into remission. This was another case where actually, which shows that IPSS we cannot do in sick patients. This was 47-year-old male, came with hypokalemia, ATM cortisol of 3,400, LDDST non-suppressible, ACTH of 178. However, HGDST was suppressible. So had a cellular supracellular mass. So a radiologist kept a possibility of hypophysitis or adenoma extending along the stalk. Patient also had some infiltrates on X-ray chest. So CT was done, which showed that there were bronchiectatic changes with cavitatory lesions and areas of breakdown. So query tuberculosis, query fungus. CT abdomen revealed bilateral enlarged glands with heterogeneous enhancement and hypodense areas. So reported as adrenalitis or bilateral adrenal tumors. So we had two possibilities. Either it was granulomatous hypophysitis secondary to tuberculosis or fungal infection with some ectopic tumor sitting somewhere outside the pituitary, or was it macrocorticotropinoma? Patient was too sick to undergo IPSS. So we subjected the patient to functional PET CT, and there was uptake corresponding to the lesion on MRI. So this was actually macrocorticotropinoma, which was troubling the patient. However, the patient was too sick and fragile, so patient had to be subjected to TBA. Later on, this patient underwent TSS, and this tumor was proven to be ACTH immunostain positive corticotropinoma. So this was macrocorticotropinoma extending along the stalk. So, however, because of this imaging modality, we started getting patients who were on medical treatment and previously treated. So in those cases, because there is upregulation of the surrounding corticotrophs, so CRS PET CT was showing diffuse uptake, as we can see in the first image, because of the upregulation of the surrounding corticotrophs. So we went ahead and developed another molecule, which is gallium M-desmo PET CT, which is desmopressin modified to conjugate with DOTA. So we can see that on CRH there was diffuse uptake. However, there is a small lesion seen on left side in this patient, there is a small lesion seen on the left side in this patient, which was later resected. M-desmo PET CT does not show any uptake in normal pituitary. In patient with non-functioning pituitary adenoma also, there is no uptake, it's very specific. Even in patient with somatotropinoma also, there was no uptake. However, there was some uptake in patients who had stress-induced hypothalamic pituitary adrenal axis activation. Patient was very sick, and in such patients, we wanted to see what happens. So we took ethical clearance and went ahead with this imaging, and there was diffuse uptake. So this was a case with ectopic Cushing syndrome. As we know, this molecule is desmopressin. So vasopressin receptors are well expressed sometimes on functional ectopic tumors as well. So this was a patient with metastatic NET leading to ectopic ACTH syndrome. In this case, there was no uptake in the pituitary, suggesting that central corticotrophs are well suppressed. However, we can see bright uptake in the metastasis to thoracic wall. So which shows that this ectopic tumor was actually expressing vasopressin receptors. So localizing the source of ACTH production is a daunting task. non-invasive dynamic tests are complementary to imaging. Vasopressin can be used as an alternative to HCRH for IPSS. IPSS is useful for localization but not for lateralization. And CRH and MDESM PET-CT represent novel, non-invasive, integrated, functional, and anatomical imaging in patients with ACTH-dependent Cushing syndrome.
Thank you, ma'am. And as usual, it's an excellent deliberation. I know there are many questions from the hall, but for time constant, we will keep limited to a few. So any questions from the floor?
Thank you, ma'am. It's a very nice deliberation. In the second case, the macro corticotropinoma, I think the bilateral adrenal is also enlarged. It is possibly due to ACTH. But I think this is a, somehow patient is immune suppressed, and because of that there is a fungal infection or tuberculosis which is involving bilateral adrenal. That was tuberculosis? Yes, fine. So it is that actually we are initially thinking of that it is ACTH developed, but the imaging was more suggestive of granulomatous disease. Disseminated tuberculosis, right. And this is the... Okay.
Nice talk. In a situation where there is a discordance between your imaging localization and IPSS lateralization, does adding a phenography help? Petrocell sign as phenography to look for anomalous image. Thank you.
Thank you, ma'am. And any other questions? So if there are none, thank you, ma'am. And we are enlightened by your excellent deliberation. And we are going to start bone clinic, for which we have excellent stalwarts with us. So first of all, I would like to call upon stage Lakshmi Nagendra madam, who comes from the Center Clinic of Mysore, who is a consultant endocrinologist and associate professor of the JS Department of Endocrinology. We will ask ma'am to enlighten us regarding the osteoporosis treatment, its success or failure. Madam, the stage is all yours. Thank you, ma'am.
Thank you, Dr. P.S., for that kind introduction, and thank you to the team of Crescendo for the opportunity to speak again on a very interesting topic. So ours is a very young department, and very happy to have the stalwarts of osteoporosis here in this room while I speak on this topic. So today we will be speaking about defining success or failure in osteoporosis treatment. So this is quite a controversial area, a gray area, I would say, where we don't have things written in stone. There are ifs and buts even till today, but let's look at the evidence that we have till today. So when you speak about what is osteoporosis success, treatment success, it seems obvious that, if there are no bones broken, it seems that, our treatment is a success. But if there are fractures, it seems that the treatment is a failure. So it seems simple at the first thought, but as I read more and more about this, it is not so simple. Let me tell you why. So we have Mrs. A, a 70-year-old lady. She has a history of low backache following a slip and fall from standing height. She attained menopause at 43 years. She does not have any other comorbidities, and she's not on any medications. So this was the X-ray done elsewhere, and this is showing a compression fracture, as you can see. Her investigations were largely normal. HbA1c was suggestive of pre-diabetes. So this was her bone mineral density, very low. You can see the T-score of minus 3.7 in the femur neck. Again, BMD at the spine was also low. And the vertebral fracture assessment was done to showed a severe compression of T12 vertebra. So again, her FRAC scores were high, 19% for major osteoporotic fracture and 9.4% for hip fracture. So this patient was started on once yearly zoledronic acid because of many issues. She chose zoledronic acid mainly because of the ease of administration and also the cost. 2 years later, she came back and her BMD had improved statistically. So it showed a plus 6% at the hip and plus 6% at the lumbar spine compared to her baseline bone mineral density. So does this mean that this treatment was success? So I thought so, that treatment is successful here, right? So we have BMD gains at hip and spine. So she was told to continue on her present treatment. But what happened later is 3 months later, she had another slip and fall in the kitchen and sustained another hip fracture. Now, does this mean that our treatment has failed? So to answer this question, let us go through a few definitions. How do we define success or failure? So can we define success or failure by incident fractures? If somebody who's on osteoporosis therapy and have a fracture while on therapy, can we call it as a failure of treatment? Now, when you look at the data, this is the data from the Horizon trial. So here you can see that patients were given zoledronic acid versus placebo. So zoledronic acid reduced the incidence of fracture, but there were still some fractures, as you can see. So the incidence of fractures was not zero. It reduced the incidence of fractures. And there were also fractures in the placebo group as well. So can a single fracture say that your treatment is failing or succeeding? It cannot, because there is reduction in the risk of fractures, but it is not a complete zero. And also when we look at a second fracture, so once a patient has a fracture, the risk of subsequent fracture is 2.7 times higher within the first year of the fracture. And 67% of these fractures occur in the first year, and 50% or more occur within 6 months of the initial fracture. So somebody has a fracture today, and you're treating this patient, you're starting the treatment for osteoporosis. This patient still has a very high risk for fracture in the next 6 months. By baseline itself, regardless of treatment or not, this patient has a very high risk of fracture. Now your treatment might reduce this risk of fracture, but we have to remember that the first 6 months or even 1 year, the patient has a baseline very high risk of fracture. So when we look at definition of treatment failure by defining incident fracture, the occurrence of a second fragility factor should be used to infer that the treatment has failed and not the presence of a single fracture alone. So if somebody is on treatment and has 2 fractures while on treatment, that would constitute treatment failure. Can we define treatment failure or success by bone mineral density? Now, we know that osteoporosis is characterized by progressive loss of bone, and BMD is a predictor of fracture risk. So it seems like common sense that if there is an increase in bone mineral density, it represents a favorable response to treatment, and if there is a decrease in bone mineral density, it represents a treatment failure. Seems like common sense, but there's more to it. So bone loss or gain are most often modest compared to the errors occurred in measurement of BMD. So when you are doing the bone mineral density, the errors occurred can be equal to this bone gain or loss that you measure after treatment. For example, the rate of loss of bone mineral density at the femoral neck in untreated women with postmenopausal osteoporosis is 1 to 2% per year. So somebody who's untreated is already losing bone at 1 to 2% per year. This has to be kept in mind. So we do something known as coefficient of variation to standardize the measurements between technicians, between 2 different scans. So this CV is approximately 2% at the lumbar spine and 1.6% at the hip. This brings us to something known as least significant change. So you multiply this by 2.77 or you multiply this by 2.33 if it's a one-way test, and this gives us estimates of least significant change, which is about 4.7% at the lumbar spine and 3.7% at the femoral neck. So as a rule of thumb, you say that your BMD change should be more than 5% at least at the lumbar spine, or a change should be more than 4% at least at the femoral neck to constitute a significant change in BMD. For example, our patient had 6% gains, so that becomes significant. So suppose she had 2% gains, that does not become significant. So ideally, this is calculated at each center. The least significant change is calculated from the values at each center, but if it is not available, 5% and 4% can be used as a rule of thumb, and if the BMD gains or loss are more than this, then they can be taken as significant treatment success or failure. What about bone turnover markers? Can we use bone turnover markers in defining treatment success or failure? Again, earlier, this was from 2012. This was a working group from the National Osteoporosis Foundation. So this said that you need a CV of, you need a least significant change of about 28% for both P1NP and CTX to be called as a significant change. Like how we say there is a least significant change for bone mineral density, there should be a least significant change for bone turnover markers as well. But recent data say that least significant change estimates are about 56% for serum CTX and 38% for serum P1NP to say that they are significantly different from what they were at baseline and to use them to define treatment success or failure. So for anti-resorptives, a decrease in CTX and P1P less than the least significant change at 95% confidence interval is considered as an indicator of failure to respond to treatment. And for anabolics, an increase in P1NP that is less than the least significant change at 95% confidence interval is considered as an indicator of failure to respond. So how do you actually assess clinically the response to treatment? So you say the patient has responded to your treatment. It may be treatment success or failure, but response is different. Response is if there is a stable or significant increase of BMD with appropriate changes of bone turnover markers, you say that there is some response to your treatment. Now, what constitutes success? So there is something known as treat to target in osteoporosis now. So if you start a patient with T-score of less than minus 2.5, there should be a BMD increase of at least 0.5 units. And when the T-score is more than minus 2.5, the T-score should be at least 1 unit increase with treatment, and there should be no recent fractures to call this as treatment success. And what is treatment failure? If you have 2 or more incident fractures while on treatment, that constitutes treatment failure. But if you have 1 fracture and a significant decrease in BMD or a lack of appropriate change in bone turnover markers, that can also be termed as treatment failure. But the presence of only 1 fracture cannot be termed as treatment failure as of now. So what do we do when treatment fails? You have to rule out secondary osteoporosis. More often than not, there can be secondary causes of osteoporosis which can be causing your treatment to fail. You should also ensure adherence to the treatment. And how do we ensure adherence? So patient preferences is very important in the treatment of osteoporosis. So we recently did this review of stated preferences of at-risk patients for the treatment of osteoporosis, and we found that efficacy was deemed the most important attribute, followed by cost. This is, of course, mostly from the Caucasian data, and we are now planning a discrete choice experiment in our country to look at what actually the patient's preferences are and how do we incorporate them to improve the efficacy of osteoporosis treatment. So when treatment fails, you replace a weaker anti-resorptive agent with one that is more potent. For example, if you're giving raloxifene, you can switch to alendronate. Or you can replace an oral medication with an injectable one. For example, if the patient is on alendronate, you can switch to zoledronic acid or denosumab. Or you can replace a potent anti-resorptive agent with an anabolic therapy. For example, you can switch from zoledronic acid to teriparatide. Now coming back to our patient had response to therapy but still failed. She had another fracture. So what would be the best treatment option for her? Probably the best treatment option for her would be to switch from the anti-resorptive treatment, that is she's on yearly zoledronic acid, to an anabolic therapy. And we know that if you give anti-resorptive first followed by an anabolic, the BMD gain is actually lesser. So this patient is going to benefit less from this. But there is still some benefit. Rather than continuing with zoledronic acid, you can switch to anabolic therapy. In retrospect, if she was affordable, maybe starting an anabolic therapy upfront would have been the best option in this patient, and maybe that would have prevented her second fracture. And what to do when treatment succeeds? So if the patient has been on long-term bisphosphonates, at least 5 years for oral and 3 annual doses of zoledronic acid, you can consider bisphosphonate holiday. So I was just talking to Thomas Polsa, you can do the bone turnover markers and see if they are still suppressed. You can put this patient on a drug holiday. And even when you're giving the yearly zoledronic acid, sir was telling me this is a very interesting concept. Rather than giving it yearly, you can actually look at the bone turnover markers and see if they're still suppressed at 1 year. You can repeat them at 6 months and give the zoledronic acid later to prolong the duration of treatment. So holidays can be given based on monitoring of bone turnover markers, or bisphosphonates could be continued with a lower dose or longer dosing interval than previously. So if the patient has been on denosumab, we have data for up to 10 years for denosumab now. So we don't have data beyond 10 years, but we have data for up to 10 years, can be continued for up to 10 years. And if the patient is completing a course of anabolic therapy, it is essential to transition the patient to an anti-resorptive medication. So you cannot stop the anabolic therapy. There will be rebound fractures. You have to transition the patient to an for example, if the patient is on teriparatide for 2 to 3 years, then you change over to zoledronic acid. And if the patient is on a mild anti-resorptive agent, you can continue the same medication if the treatment is succeeding. What about combination therapy? So as of now, the latest guidelines which came out in 2022 say that combination therapy in which you add an anabolic agent and anti-resorptive therapy may be appropriate in a setting of very high risk, such as multiple vertebral fractures. So somebody who's had multiple vertebral fractures has a very high risk for fracture, and you can consider combination therapy. As of now, we have data that there is definite benefit on BMD. So we do see bone mineral density gains with combination therapy, but we do not know the effect on fractures, incident fractures. As of now, we don't have data that it is actually reducing the incidence of fractures. So what combination therapies work? At spine, bisphosphonate plus PTH is equal to PTH. So there's no benefit over PTH alone. But if you combine denosumab plus PTH, it is better than using either denosumab or PTH at the spine. And at the hip, using bisphosphonate plus PTH or using just bisphosphonate alone is better than using PTH, but using denosumab plus PTH is better than using denosumab or PTH at this hip. So denosumab plus PTH is a win-win combination for BMD gains both at the spine and hip, but the cost is the only concerning factor. So just to summarize, treatment success has been described as achievement of a target T-score and the absence of a recent fracture with the strategy of treat to target for osteoporosis. The occurrence of fracture while being treated for osteoporosis is undesirable, but it does not necessarily represent treatment failure. So treatment failure should be taken, we have to take into consideration a lot of other factors like, gain in BMD, also response to bone turnover markers with the presence of a fracture to define treatment failure and osteoporosis. Thank you one and all for your patient listening. If there are any questions, I'd be happy to take.
Thank you, ma'am. And excellent deliberation on osteoporosis. Hope the audience has been enlightened with this. So any questions from the floor?
Excellent talk. One thing just I want to ask, like whatever you have suggested that doing a bone turnover marker to delay the gap between that IV bisphosphonate, should we, is it for the first 3 annual dose or during that when you are considering drug holiday?
So this idea is from Thomas Paulser, so would you?
There are a group of patients, you give 1 dose of zoledronic acid, like this September year. This patient is supposed to receive the next dose next September. So there is a subgroup based on Reed and Mark Bold. They also done published in JCL. If the bone turnover marker is suppressed, like just say CTX, beta cross lab is less than 200, then and there is BMD increment is there, though 1 year is not a good for zoledronic acid, and there is no fracture, we can space it out to even after 1 dose. And they have spaced out for 3-4 years also. This is in subgroup, one group of patients, even with 1 dose.
So that means, sir, if in subpopulation of patients
Yes.
where the response is very good, with these 3 annual dose, rather we can cover it up to 5 years, like if it 1.5 like. Thank you.
Thank you. Any other questions?
Lakshmi, your patient, the second fracture the patient had was a femur fracture rather than a second spine fracture. Now, you were telling us that maybe putting this patient on teriparatide at the beginning would have been better. So do you think teriparatide would have been able to prevent the second fracture, which was a femur fracture? That's number one. Number two, when you talk of a femur fracture in a patient who is on zoledronate or any anti-disruptive for that matter, you should also tell us about whether this is an atypical femoral fracture.
Correct, sir. So sorry, I did not mention the atypical femur fracture. So that should also be considered, of course, as this thing. But what I meant to show in this patient was presence of a second fracture while on treatment, just to illustrate for the purpose of the topic. So I believe that starting a combination of PTH and zoledronic acid upfront may have prevented the hip fracture in this patient rather than starting PTH alone. I think if she were to be affordable, starting a combination would have been better for her. You're right, sir. Rather than starting just PTH alone, starting PTH alone may not have prevented this second fracture. And again, she is again at a baseline risk of high fractures. If we see the Endocrine Society guidelines for the treatment of fractures, where we say treat to target and categorize patients based on their risk, she actually comes in the high to very high risk, and maybe combination therapy would have been best for her upfront.
So, excellent talk. I just had a question regarding a patient. So, she is a 32-year-old lady, and she came to us with a diagnosis of optic neuritis. She was on high-dose methylprednisolone for 2 cycles of 3 days each, and with intermittent oral steroids. So, she was pregnant when she was diagnosed with optic neuritis, and around 7 to 8 months pregnant. So after that, when she came to us, she had already delivered postpartum 1 to 2 months. So at that time, she was complaining. She said that she had a back pain, and it had started around 8 months of pregnancy. So it was quite severe, and we did the MRI, and we had found there was a wedge collapse fracture at the D12 vertebra. So she had history of vitamin D insufficiency at the beginning, and she was intermittently on calcium supplementation during the pregnancy period, but not very regularly. So she had to be put on steroids in later period also. So at this moment, we kept a diagnosis of pregnancy lactation-induced osteoporosis, because other metabolic profile and other things were normal. Vitamin D was normal, PTH was just borderline 65, and calcium was normal. Thyroid hormone, she was getting supplementation, which was keeping her, during the pregnancy, it had to be escalated by a small dose, but it was okay. So currently, Z-score was, BMD was done, Z-score was around -5, -4.5 to -6 was the spine Z-score. And at the femur, it was around -2.5 to 3.
Her cumulative dose of steroids?
It was not much. It was only 6 grams total, and with couple of intermittent oral steroids. So keeping
no family history of fractures?
No such history. Previous, no history of fractures except this one, which was...
I don't know, for lactation-induced osteoporosis, it seems atypical. I mean, this seems very severe to be labeled as lactation-induced osteoporosis. Maybe she has an underlying cause. I think in such young individuals, when we didn't have a diagnosis, genetic testing actually reveals many genetic variants which are responsible for osteoporosis, and I think genetic testing would bring about a diagnosis in her.
So should we put her on teriparatide in this case, because she's having severe osteoporosis with fracture?
I believe combination therapy would be best for her if the Z-scores are -6. She's post 2.5 months. I think she has a single fracture, single vertebral fracture. So So she definitely requires anabolic therapy upfront, but if combination therapy she is able to afford, then that also would be a good option for her. So what any other comments, sir?
In a patient like this, I think, as you rightly pointed out, OI, milder variant, milder mutations, very likely. Now we see more commonly as we do more and more genetics, that is more common. And regarding a combination therapy upfront, from the beginning, do we have enough fracture prevention data yet? Whatever we have is a cumulative, the bone density increase, that's there. But still,
as I pointed out, we don't have fracture data, sir. But if you look at the relative reduction in risk for fractures of all the agents that we see, they are in proportion to the BMD gain or loss. So we can only hypothesize that they should, but we don't have data as of now.
With time, we should have data,
yes.
right? So,
just a word of caution, in a patient like this, pregnant, then lactating, don't make a mistake of missing out on osteomalacia and do a DEXA on osteomalacia. So, coexistent. So, as I say, so coexistent underlying osteomalacia as a secondary factor.
Thank you, sir. That was an excellent discussion that we must say that which has enlightened us. But as you know, every great thing has come to an end. So we'll leave the discussion later. So thank you, ma'am. And I would like to call upon stage Professor Thomas Paulser, who needs no introduction, who is a professor and head of Department of Endocrinology of CMC Fellow. Sir will be enlightening us on discontinuation of denosumab and what next to do. Thank you, sir. The stage is yours, sir.
Good afternoon. So there is a small correction. I'm not the head anymore. Dr. Asha is the head of endocrinology. So thank you, the organizing committee, for this invitation and warm welcome you have given to us. Thank you so much. And we do interact with people from West Bengal there also, but really wonderful. So next 15 minutes or 17 minutes, I'd just like to go through a little bit of literature and some cases, at least one case, when you do denosumab discontinuation, what is the fracture risk and subsequent management. We know that denosumab is available for past over 10 years. Now, I was thinking its minimum cost is 10,000, but Dr. Lakshmi was saying it's available even for 5,000 rupees. We space it out as a subcutaneous injection every 6 months. And the important part of osteoporosis management is optimal calcium and vitamin D nutrition, physical activity, and fall prevention. The problem with denosumab is that it doesn't stay in the bone compared to bisphosphonate. Bisphosphonate stays in the bone. That is the reason for the discussion in the previous talk. So its effects goes off. Renal safe, but when you are using in CKD stage 3+, we have to be aware of potential hypocalcemia. Of course, denosumab in our setting, even in Indian setting, we have used, other than for osteoporosis, we have used for other conditions where there is a malignancy-induced hypercalcemia or parathyroid-induced hypercalcemia, Paget's disease, fibrous dysplasia, many other diseases, which we also used in our Indian setting, and we found the results are very useful. So this is the first trial which we would have studied in our student days, that about 8,000 patients, freedom trial, and they are looking at new vertebral fractures, and they are also looking at other non-vertebral fractures and hip fracture. As expected, the vertebral fractures as well as hip fracture and total fracture incidence came down at the end of 3 years. Now, the efficacy of denosumab has been proven for fracture prevention in other small trials also. Now came as Dr. Lakshmi pointed out, that we have got a data up to 10 years, and so we have a 10 years data. Unlike bisphosphonate,
the BMD keeps on increasing. The more the duration of denosumab, the more the BMD. And unlike there is a definite cutoff for bisphosphonate, after which it is fracture prevention, but the fracture prevention rate, incidence, doesn't decrease further. Whereas here it is in denosumab, BMD goes up and fracture risk also comes down when we increase the duration. Now, this is what the guidelines, American guidelines, that it is good for vertebral fractures, non-vertebral fractures, and hip fracture. But there was a concern as early as 15 years ago. The moment we stopped denosumab, the BMD started coming down, where it was not so with bisphosphonate alendronate. Now, this is the first from Swiss group. Of course, everybody would have read this paper, very, very controversial at the point of 2013-14, that is Lamy group. They noted 3 people on denosumab stopped, had vertebral fractures. So they themselves wrote, they are running the metabolic bone disease clinic, they have used other agents, they have not come across this kind of fractures. So is it true? So is it fracture risk really increased after denosumab discontinuation? If we stop denosumab, what should be the alternative? So then the same group published 9 cases. Here, if you see that some of them received as low doses as 2, that is 2 doses of denosumab, 6 monthly interval. The stop, the rebound fracture occurred. And the fractures as high as 7 to 8 vertebral fractures, mainly vertebral fractures. So they formed a hypothesis. All these fractures are spontaneous, were spontaneous, and they occurred very early, and they were not on any other osteoporosis medication. Is it rebound bone turnover which is causing this fracture? So that was a hypothesis at that point of time. So there was a criticism. There is a group, like, you can see Dr. Badera's name, Dr. Rao's name. This has been a discussion in 2015-16. Is the NDT like a rebound fracture is there? So they wrote whether this is a real NDT. So the authors also responded. So there were so many questions were asked by this letter to editor. No X-rays are available. Vertebral biopsy image is uninformative. Bone turnover markers were done after fracture. All this. So the authors also tried to answer as diplomatically as possible. Then came 24 patients, same group. Here they found that most of the fracture after stopping denosumab, many fractures are occurring at T12 level. And the more the duration of the denosumab, that is, somebody has received more than 5 doses of denosumab, the more the risk of, if you stop it, the more the risk of fractures. And this is from a UK group. If we stop denosumab today, the effect, the risk for fracture goes up as early as 3 months. That is after 12 weeks. For example, now is September. If we stop denosumab today, by January, the risk is quite high. So this led to Cosman group to do a post-hoc analysis, multiple vertebral fractures after denosumab discontinuation. Here also they found more the duration of the denosumab, more the fractures, and they occurred very early. So they took the cutoff of 3 years. So this led on to looking at what is the pathogenesis. We know that denosumab acts on rank, which is an osteoclast activating agent. So the moment we stop denosumab, bone resorption goes up, CTX goes up, rank expression also goes up. That was the, though the number was very small, 5 to 10 subjects. Now, whether it is American Association or European, they say at this point of time, if, as Dr. Lakshmi put it on a slide, like if you stop denosumab, we have to give some other agent. So we have to translate, it's another anti-resorptive agent. So this is the nutshell what we do in our place. Somebody is stopping denosumab. The height is the simple measurement on us, where because vertebral fracture height will come down. And X-ray of the spine every 6 months. Of course, DEXA we cannot do, we can do once in 12 to 18 months. Bone turnover marker every 3 months we can do. She has told there are two bone turnover markers, which is very, very useful. CTX, or otherwise known as beta crosslab, which is a bone resorption marker. P1NP is a bone formation marker. We have our own cutoff. Now, how this bone turnover marker is useful? This is a lady, 64-year lady, postmenopausal, on thyroxine for hypothyroidism, calcium and cholecalciferol. You can see the DEXA scan. She has a T-score of less than or equal to minus 2.5. So she has osteoporosis. And you can see the beta crosslab. I don't know whether you are able to see from there, 902. So this is little high resorption. So this patient, we are going to start anti-resorptive. This patient preferred oral bisphosphonate. You can see, I took a snapshot. You can see at the end of 3 months, 902 beta crosslab has become 321. That is more than 50%. We know patient is taking medicines correctly and it is working. So that's the advantage of using this beta crosslab, otherwise known as CTX, to see the efficacy. Similar thing, bone anabolic marker P1NP when we are using teriparatide. Now, very simple way of looking at, if somebody has received denosumab 4 to 5 doses only, then the rebound fracture risk is little less. You can transition with oral bisphosphonate or IV bisphosphonate every year, 1 to 2 years. But somebody has received more than 6 doses, that is a current consensus, then if a patient has got a high risk for fracture, continue denosumab for 10 years, or patient is not willing, then you start zoldronic acid. Here the catch, when we are giving zoldronic acid after denosumab, who has received more doses of denosumab, the zoldronic acid has to be repeated every 6 months for first 2 to 3 doses. Here it is very important to do bone turnover marker if it is available. When the bone turnover marker is more than 300 picogram, then we can, every 6 months we can space it out. There is a recent JCM article in September also. Now, this is a case of a 44-year-old lady, premenopausal, severe backache. She is from Kerala. She lost 10 centimeter height over 10 years. That's the reason. She was treated in one of the Kerala centers with IV zoldronic acid, 3 doses. And she had pain, back pain. And also she was given oral bisphosphonate, but she was not feeling comfortable. That's the reason she came to Vellore. This we published some time back, and we have got a follow-up. So you can see she had a height 160 to 150 height. And multiple spine fractures. We did OA genetics, LRP, all were negative, no significant family history, regularly menstruating. And what we did was we started on teriparatide. Once we started on teriparatide, we followed up with the bone turnover marker and BMD at 1 year. So at the 1 year, she lost further 2 centimeter, 150 to 148. So we are wondering, we are giving an anabolic agent and still nothing is happening. So there is no other secondary cause. She was not on any bone losing agent. So here we added denosumab and teriparatide was continued. Denosumab 60 milligram we started, and she had completed teriparatide of 1 year, and we have just added. When you look at the BMD, after that it started remaining stable. There was no BMD loss. Quite complex is the bone turnover marker. What has happened at the end of 1 year, when we give teriparatide, bone formation went up, bone resorption also very high. So whatever she was gaining, she was losing through the resorption. It was a very high turnover state. So we blocked it by giving denosumab. So after that, she has, like, this is 2017, now 7 years. This is what, now I saw this patient last week. She has you can see, initially she has received zoldronic acid, then teriparatide with the denosumab, then denosumab. She said, enough of denosumab, she said. So we have transitioned to zoldronic acid. The dose was given in April, and that time our CTX was 600. So we are going to give a next dose, by October, after looking at the CTX. Now, denosumab is a potent anti-resorptive treatment up to 10 years. Stopping denosumab, good evidence for rebound vertebral fractures. More the duration of denosumab, more the risk. If somebody has got more dose of denosumab, zoldronic acid has to be spaced out every 6 months, 2 to 3 doses. And all the other, giving teriparatide, selective estrogen receptor modulator, all are not very great. And radiology, DEXA BMD, BTM, above all, clinically height measurement is very important. Thank you so much.
Thank you, sir. So that was an excellent eye-opener for us. And we believe that actually solves the enigma of denosumab discontinuation. So the floor is open for questions, if there is any. Before anyone, sir, I have a question. Sir, after stopping, when you contemplate the stoppage of denosumab, how many months after should we give a anti-resorptive agents like zoledronate or something? Should we give immediately or after 6 months?
No, you can wait, because just before that effects weans off, we space it around 5 to 6 months after the last dose.
Okay, sir. So, any other questions?
So thank you, sir. So if anyone want to continue denosumab more than 10 years, if the cost is not a problem, and if he or she is understand about the gravity of the problem, if you discontinue denosumab, there may be chance of fracture.
Yeah.
So what could be the message from our end?
So at this point of time, there is a unwritten consensus. Hope Professor Satyanath also agrees that even after 10 years we can continue, because this follow-up is now for 15 years they are going to do. So hopefully it should continue to work.
Sir, in case of denosumab and teriparatide combination, how is the turnover increasing? Because denosumab is suppose.
No, see, basically when you give teriparatide, you should have bone formation going high. Bone resorption will catch up after some time, not immediately. That's what we call it as anabolic window. You're gaining bone. Here, what has happened is bone formation is going high, resorption is also catching up. So that window is narrow. So whatever we are gaining, we are losing. So the moment you give anti-resorptive denosumab, your teriparatide is already on. So anabolic effect is there, and you are coming down on anti-resorption. So the window is becoming wide. I don't know whether I am able to convince you. Is it clear? Or?
Sir, actually, you told that the patient was having both teriparatide and denosumab
At that time.
At the
One year, at the end of 1 year.
So at that time, how can the turnover marker go high? That is.
Sir, what she is actually trying to ask that when the patient was on denosumab, the anti-resorptive markers were supposed to come down.
No. After starting, initially at 1 year, patient was not. We have started. That time, the resorption was very high. Then only we started, not at the baseline. Then we blocked with denosumab. Then that anabolic window came up. Is it
Yes.
clear? Thank you. Thank you so much.
Just one more question. If we are following up teriparatide with denosumab, is there any definite window that we should start denosumab within this after stopping teriparatide?
Sure. So teriparatide, usually the effect is there only for almost the last dose. Then we say about 12 to 16 weeks we should have started. But many people, not to forget, the moment they stop teriparatide, they give a dose of denosumab or zoldronic acid, so that no patient is not lost.
Sir, if someone chooses to use bone turnover marker in case where they are unable to continue denosumab for cost and other reasons, and we want to give bisphosphonate, so at what frequency? 6 months is one of the rule of the thumb, but otherwise, if someone wants to do a bone turnover marker cross-lap to see when to initiate, so what would be the frequency of checking of this cross-lap?
So what we are doing is, after denosumab discontinuation, we are doing, because we don't charge much, we charge only 300 rupees to 400 rupees. It's easy in that sense, and poor patients we can write it off, though the denosumab they have to pay. So we are doing every 3 months. If a patient cannot, patient is from West Bengal, every 6 months.
Okay. Thank you, sir.
Thank you, sir. Sir, it's very expensive here, sir.
Thank you. Thank you.
Thank you, sir. So with this, we come to an end of our session 1, the pre-lunch session, and we declare that the lunch is now open. We can have a lunch. We can have lunch at the at your convenience. There are 2 sessions, one for faculty and for delegates. And to remind everyone that the registration counter is open, and we need to do registration, and after that, the lunch is open for us.
बज रहा है. Check test 1 2 2 2 2 2. अच्छा वाला में दे, टेप वाला कैसा डाल दी. ये तो नॉइस है. चेक टेस्ट. हल्का आ रहा है ना. रुक जा. Check. Hey. Noise गया. Check test. Check. Hey. 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 Check. Check. Hello. Test. Test. अब आ जाएगा. Check 1 2. Hey. Check. Check test 1. Check. Hey. Check test. Check. Check. Hello. Check. Test. उसमें भी तो आ रहा है. इसमें भी आ रहा है. Check this. test. सुनना, लेफ्ट में लगा हुआ है तो राइट में लगा के देख तो सुदान कौन सा जाएगा तो check he test. लेफ्ट में है ना तो राइट में दे दो चेकर कंसोल में ही है जैसे सुनना लेफ्ट में है तो राइट में देके देखना तो देना कुछ नहीं होगा check hey एक्सलर टू फोन नहीं है दोस्त नहीं सीढ़ी के पास में क्या लोग स्मोक जोन चेक उसका वॉल्यूम कटा हुआ है ना चेक बज रहा है सुंदर को फोन कर तो Check, test, 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 test. चला गया चेक चेक संदा बोला था ना कि मेरे पास नॉइस आ रहा है चेक 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 टेस्ट टेस्ट चेक 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 hey hey check check hello test test check 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 मैं वही तो चेक कर रहा हूँ एक स्लॉट चेंज किए check test 1 2 2 check 1 2 3 4 5 6 7 8 9 0 check check test 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 test
check hello hello check
check check hello hello check Sudan Sudan क्या बोल रहे सनुदा कॉल पे बात कर रहा है चेक हे 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 इधर आ इधर आ चेक हे 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 इसका लेवल कम आ रहा है इसका लेवल ज़्यादा आ रहा है देख चेक टेस्ट टेस्ट 1 टी टी ये देख कहाँ तक जा रहा है चेक 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 बी तक जा रहा है ये देख चेक 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 तो दोनों का सेम जाएगा ना कम बेसी क्यों जाएगा चेक हे इसको चेक बोलने से ये बी तक जा रहा है देख चेक टेस्ट 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 आवाज़ तो मेरा कम हो जा रहा है चेक हे चेक टेस्ट टेस्ट मैंने इसको मालूम दे चेक 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 हेलो हेलो सेम हो गया चेक चेक नॉइस तो आ गया check check test test 1 T T T T check 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 test 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 1 T T T
Check, 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 check. Check, check, check.
we had a sumptuous lunch, and without further dozing off, we are going to start our next scientific session, and which will be on the mainly based on the female reproductive systems. The first one is on Turner syndrome. The second one is on polycystic ovarian syndrome. So without further delay, we will just start off our next session. Please stay with us. So, thank you for staying with us. Regarding our next session, that is the adolescent clinic, we have two pretty interesting topics, that is Turner syndrome and polycystic ovarian syndrome. And we have stalwarts amongst us to talk on them. So, first one to talk on Turner syndrome is Professor Sandeep Mathur, who is the professor and head of Department of Endocrinology of SMS Jaipur. Sir, kindly enlighten us with the words on Turner syndrome. We know that your genetics has been your favorite subject.
Thank you very much for the opportunity to speak on a subject of my interest, and he rightly states genetics my area of interest. So, you see, astute clinical observation. It is in 1939, H.S. Turner observed there were girls with, syndrome in infantilism, congenital Birmingham nap, and cubitus valgus. He described 6 girls with a clinical phenotype. And it was forced observation in cell culture. While looking at the karyotype, this phenotype was associated with missing of one X chromosome. Here the story of Turner syndrome, Turner's phenotype, is a chromosomal disorder, a genetic disorder started. And still our definition of Turner syndrome is a chromosomal disorder that affects phenotypic female who have one intact X chromosome and complete or partial absence of second X chromosome, sex chromosome, in association in one or more clinical manifestations. Definition, 2 pillars are there. One is a group of clinical manifestations. They happens together, but they are not together in every patient. There is a permutation combinations and a karyotype defect. That is the simple definition of Turner syndrome. Still, all guidelines say it. But we look into Turner syndrome, its clinical phenotype. This is the list on the right side, half of the list, half will be in the next slide. There is a long list of clinical manifestations involving several organs and wide range of severity and inter-individual variation in their manifestation. So what I want to focus, there is a long list, wide inter-individual variation, and almost involving every system. Also, they differ in their age of manifestation. Some of them are disease in itself. Manifestation of a disease itself is a disease. Hypothyroidism, celiac disease, diabetes mellitus, otitis media, and all they themselves are disease. So many diseases are together. Some of the clinical manifestations of Turner syndrome are complex traits. Problem a definition by definition, this is a syndrome of X chromosome. But one of the manifestations is type 2 diabetes mellitus, which is omnogenic, complex genetic trait. Because susceptibility of type 2 diabetes, though I have now publications, they are challenging this concept, but of that everybody say it's a omnogenic. If you open even your Wikipedia, basic genetic diabetes, they say it's an omnogenic disease. That means susceptibility is situated in all the chromosomes. And overall genome contribution at least partly to the phenotype through expression of relevant cells. Now, there are whom should we diagnose, whom should we suspect. So there was a Cincinnati 2016 meeting, international meeting. They suggested some criteria, only one clinical feature or at least two of the following features. They say these are the patients who should be screened for. Because manifestation is everywhere in the body, so whom should we screen? They have given a set of criteria. These are the people you should suspect Turner syndrome. But still the clinical practice, the gold standard diagnosis test for diagnosis of Turner syndrome is conventional karyotype demonstrating complete or partial loss of one or two X chromosome in girls showing specific phenotype called Turner syndrome phenotype. Now, there are two unresolved questions. What is the molecular basis of all clinical manifestation of Turner syndrome? There are so many diseases coming from one chromosome, that is X chromosome. Only limited information available on genome karyotype, genotype, karyotype, and phenotype correlation Turner syndrome on the basis of mapping of all traits on X chromosome. We believe X chromosome defect, 4 short, 1 X chromosome missing, and these are manifestations. We think all manifestations are mapped to one single chromosome, that is X chromosome. Second is, what is the diagnosis in girls showing Turner syndrome phenotype but have normal conventional karyotype? You see, in our own database, our own karyotype are available in 27 patients in one study, though it's older data. Now we have more and more patients. 55.6% cases displayed X chromosome abnormality and 44.4 cases had normal karyotype. So they come to our practice, we suspect Turner syndrome, they have Turner syndrome phenotype, karyotype normal, then what is the diagnosis? There is no diagnosis for this group of patients. And they are there from Ford's observation in 1959. Anyway, we have some answer to that question. Now, what is the molecular basis of Turner syndrome? You know, I was told long back, you can see only those things you know about. You know, as molecular technologies are getting refiner and more high resolution, investigation of Turner syndrome are going in that direction, because all disease this is happening. This is the culture of medical science. The concept of Turner syndrome originated from a clinically identifiable syndrome with abnormal karyotype, but advances in the field of genomic and molecular medicine have revealed a different picture of this syndrome. That I want to focus here. That clinical phenotype, karyotype, chromosomal microarray, we pioneered in this field in the world literature, then whole exome sequencing, then functional genomics, multi-omics, and system biological approaches. So we are now in the era of system biological approach to look for the Turner phenotype. Genotype-phenotype correlation in Turner syndrome. Since the beginning, chromosomal theory of Turner syndrome, several studies attempted to map the clinical features on a specific chromosomal region on X chromosome. You see, it is not simple one X chromosome is absent. But I want to focus here. On surface, one can presume that phenotypic difference between male and female and clinical manifestation of Turner and Klinefelter syndrome could be due to difference in the copy number of one of the genes on all the genes present on X chromosome and consequent dose effect of these genes. That means one gene is having some role in diabetes. It is diabetes susceptibility gene, one like to insulin secretion or action. That's why it is causing diabetes. One gene that is some autoimmune process that is mapped to this region and that one. So it looks like that. Okay, these are the genes, these are the phenotype, these genes are located in X chromosome, and now we Human Genome Project, we have all stories clear. But if there are two genes, there will be double effect, one gene, one effect, 1.5 gene, 1.5 chromosome, so it will be different. But in nature, one of the X chromosome undergoes inactivation. A female has two X chromosomes, one undergo inactivation, that is silent, that is not expressed in the protein. This X chromosomal inactivation, people try to figure out where inactivation starts, and different permutation combination of karyotype they find. So actually XQ13 was the region, they suspect there could be some gene that causes inactivation of one of the X chromosomes. And one of the markers that defined this region was XIST gene, and it is expressed from inactive but not from active X chromosome. So inactivation of the Lion hypothesis, all this is from, now I define XIST gene. But some of the genes escape inactivation. And this is, though it is Turner, this is normal female, gene expression of X chromosome is not actually normal female double of Turner. It is basically some genes are escaping activation, so they are expressed. So their expression is double, but majority of them expression is single dose, not double dose. And on top of that, there is effect of aneuploidy, that means loss of partial or complete one of the X chromosome. That is an additional effect on that. So this figure shows this phenomena that gray color is basically one chromosomal region is lost, its expression is 0. Some are having actually high expression, double expression, they are shown in the purple and blue color in the right side picture. They are pseudo-autosomal region because they have a double copy of X chromosome gene expression. Second thing, from where your X and Y chromosome has come. If you look into evolution, it is around, I think, 100 to 240 to 320 million years ago. X and Y were basically autosomes. And those autosomes, when they differentiated in evolutionary process, there were 4 states of it. I will not go into aspect of that. And there are certain regions which are homologous between them, X, Y regions. And there are around 18 genes initially, now there are around 14 genes in that region. They are homologous in X and Y. And very important thing, several of these genes are actually regulator of other genes. Because problem is not the gene, its expression and its protein formation and its phenotype. Some of the genes on this region, XY region, are regulatory in region. They regulate the expression of other gene like ubiquitination, chromatin modification, splicing, translation, transcription. So this showed that X chromosome, Y chromosome, which is XY region, has certain regulatory genes. So if we sum up this picture, there are 2 pseudo-autosomal region in X1 and 2 where the gene have double copy in a normal woman. Otherwise, rest of genes are inactivated in the second chromosome. And there is XY homologous region. And these are the genes of interest in clinical manifestation of Turner syndrome. It is not the all gene present on X chromosome. That is one thing I want to highlight here. Now, chromosomal basis of clinical manifestation of Turner syndrome, there are several different patterns of chromosomal defects. For example, if your classical 46X, mosaic, isochromosome, ring chromosome, and their permutation combination, different deletion. And some, definitely there is evidence, mosaic have less severe degree of clinical manifestations. Similarly, your cardiovascular involvement, they are different in isochromosome and mosaic as compared to your mosaic. They are more close to your classical. X-ring has more of your diabetes and metabolic manifestation. Similarly, autoimmune disease are more common in with your ring chromosome. There is some trend towards gene dose effect and some pattern of clinical manifestation, not individual point-to-point manifestation. Chromosomal basis of clinical manifestation Turner syndrome, or are all the clinical manifestation Turner syndrome due to loss of one copy of gene situated in X chromosome, region showing aneuploidy? Answer is, there is some emerging trend that skeletal manifestation for cardiovascular TIMP1, TIMP3, this is autosomal gene, skeletal manifestation SOX, similarly renal manifestation CLTRN, and there are so many genes. So there is a trend, but SOX is the only gene, it's double copy, it expresses, causes normal stature. If it is single copy, it will lead to skeletal manifestation Turner syndrome like a short stature, mad lung deformity, cubitus valgus, increased sitting height. On the other hand, TIMP gene, it is involved in the basically metalloproteinase and involved in the aortic development. It has some impact on occurrence of disease, its copy number on X chromosome. But what happens, there is one more actually autosomal paralog, TIMP3. This is the autosomal gene. When both are affected, this leads to severe cardiovascular manifestation. So this finding show it is an autosome that has some impact on clinical manifest Turner syndrome in addition to X chromosome defect. I already mentioned there are actually some regulatory genes which affect the expression of other genes. Similarly, parental origin of your X chromosome, whether maternal or paternal, it has some impact on the brain development. Similarly, there are some emerging trend, functional genomic network, CSF2RA, RPS4X, KDM6A, KDM5C, and NLGN4X, ZFX, USP9X. There are certain traits, their expression and their network has some impact on the clinical manifestation of Turner syndrome. So what I want to say, simply on the basis saying, single or double dose of one gene in an individual can explain only one clinical manifestation, that is your skeletal manifestation, short stature, Madelung deformity, cubitus beltus. But most of the manifestation cannot be explained on the basis of single dose effect of a gene. So can genomic technique help in explaining molecular basis of Turner syndrome? You know, there are so many genomics of Turner syndrome. There are some studies available. You know about the human genome and its expression, and there are gene sequence, genome, transcription, transcriptome, its splicing profile, spliceosome, then proteome and metabolome. These are the things. And gene expression regulates so many molecules. Transport regulatory region sequence, transcription factors, microRNA, non-coding RNA. These are all factors, and methylation profile others. This is basic science, and there, documentation in a cell in a laboratory. We have different techniques. Genomic means gene sequence, transcriptome means gene expression profiling of mRNA, protein means protein viral cell, epigenomes means regulatory molecules or methylation and changes, and citronomics. There are so many omics technologies are there. So coming to genomic of Turner syndrome, first thing people tried, actually we always go for suspect Turner syndrome, we go for karyotype analysis. But people tried your whole exome sequencing, we are doing for genetic disorders, and the degree of mosaic can be calculated with whole exome sequencing. So our problem is when you do 30 karyotype, 50 karyotype, we still believe mosaic there or not. A good technique is whole exome sequencing. Secondly, Y chromosome and isochromosome can also detected by your exome sequencing, and present an accurate method of diagnosing Turner syndrome using whole exome sequencing, including cases with low level of mosaic, isochromosome, cryptic chromosome. So it's a basically better type of your chromosomal analysis. Similarly, this experiment will look for gene expression profiling. Which genes are expressed in a patient cell, leukocyte from Turner syndrome, as well as your Klinefelter syndrome and normal. So 1 copy, 2 copy, and 3 copy of X chromosome in cell, and they compare the transcription profiling, and they find some 18 genes were actually discriminating these transcription profiling. Very simple hypothesis, a very good result. And majority of these genes were basically related to gene function control. That means regulation of gene expression, hypermethylation, chromatin remodeling, translational, hypermethylation, and alternative splicing regulation. So the genes which different, their function is different in these 3 doses of X chromosome, they are basically regulatory in region. So they conclude these are basically the genes which are responsible for Turner syndrome and X chromosome. They are basically more of regulatory in region. And they say that this is also altered expression of the gene that leads to manifestation of Turner syndrome. Then there came a study, they look for transcription profiling and methylation profiling Turner syndrome. They find, yes, autosomes were also showing altered expression. I am coming to the main point. Autosomal expression was also different in Turner syndrome, and they were present throughout the whole genome. There were hypermethylation also there. The genes are altered expression and they are present all the autosomes. And several of these networks of those genes could be playing a role in the manifestation of Turner syndrome. There was some emerging trend, it is in silico analysis. Similarly, Turner syndrome gene expression profiling revealed pathways which are more related to your skeletal development. There are 2 studies in this direction. Similarly, X chromosome also has microRNAs, which are regulatory molecules, and there is a very good trend, they affect most of the cellular functions, and it is possible these microRNAs play a role in the manifestation of Turner syndrome. Now coming to last part, second unresolved issue, What is the diagnosis in girls showing Turner syndrome phenotype but have normal conventional karyotype? In this way, what we did in our own lab, we developed chromosomal microarray, fine map chromosomal analysis. And we had 47 patients with same Cincinnati criteria. We screened the patient. This is our pipeline. We did clinical phenotyping and chromosomal microarray. What we find in this study very important, the copy number variants polymorphs were more frequent on autosome than X chromosome. So patient with Turner syndrome phenotype, a fine mapping of karyotype analysis, more defects were seen in autosome. So Ford's experiment X chromosome, we find more on fine map, actually high resolution technique, more on the autosome than your X chromosome. And the appraisal of detected CNV on chromosome X and 14 across the common Turner syndrome phenotype revealed that patient with short stature and hearing loss had CNV on chromosome 14. That means a patient with Turner phenotype, short stature and all these things, and hearing defect, more common CNV defect on chromosome 14, but ovarian failure more in chromosome X. Similarly, we had a two group of patient, X chromosome CNV present and without X chromosome involvement. Patient with Turner syndrome phenotype, CNV defects on chromosome 14, no defect on X chromosome, and there was basically all manifestations were there, but skeletal defects are more in chromosome 14. Similarly, when we compared with normal abnormal karyotype, we find abnormal karyotype X chromosome, always there was a defect on X chromosome. But many girls with normal karyotype had no CNV defect on X chromosome and they had CNV defect on chromosome 14. So chromosome 14 defects were more common. And lastly, we developed functional interactome of the genes that were present on chromosome 14. And we developed the transgene network of Turner syndrome related all the genes on X chromosome, and there was a 67% overlap. So we came with an hypothesis of Turner spectrum disorder because in literature there are reports of chromosome 14 defect with short stature and skeletal defects. Similarly, we look our own database of idiopathic short stature, majority of girls had defects on chromosome 14. So skeletal manifested Turner syndrome, possibly deeply influenced by a chromosome 14 defects. So therefore, we propose this purpose was published in JCM in 2022, and Dr. Umesh sitting here, he is one of the author in this paper along with Nancy and other my group. So we propose here the classical X chromosome and chromosome 14 defect manifest clinically through common molecular network, and they represent a spectrum of chromosomal defects referred to as Turner spectrum disorder. I am explaining again. A patient with Turner syndrome phenotype, classical your conventional karyotype, you have chromosome X defect, it is classical Turner. But a patient with Turner syndrome phenotype and even X chromosome defect, they all have chromosome 14 CNV defects. This is more common than your X defect, and clinically they manifest like Turner syndrome. So the Turner syndrome, classical definition, X chromosome defect and clinical manifestation, but X chromosome defect in there, they have actually chromosome 14 defect. So this is a spectrum of disorder, and we coined the term Turner spectrum for them. So I am summarizing here, integrative view, the molecular basis of clinical manifestation of Turner syndrome. Basically, there is some influence of gene dose on X chromosome, but gene dose effect is not directly on the protein they synthesize, but there is the effect on regulatome, regulation of autosomal genes. So classical definition of Turner syndrome is not correct. It is basically at gene function level, there is a defect at gene expression including whole genome. That's why we have manifestation like diabetes and all those things happen in Turner syndrome, because function of the whole genome is affected. Similarly, gene dose on X chromosome and effect on transcriptome and methylome is very varying, very variable. And that is the reason for wide variation clinical manifestation Turner syndrome. And lastly, your autosomes, particularly chromosome 14 defects, has a major impact on our manifestation Turner syndrome, particularly your skeletal manifestation. And thank you very much for patience hearing.
Thank you, sir. Indeed, we could understand that there are still a lot to learn from Turner syndrome. Thank you, sir, for enriching us with that knowledge. So, are there any questions from the floor? So if there is none, then thank you, sir. Probably people are too overwhelmed to comment. So again, thank you, sir, for your excellent deliberation. And for the next set of talk, I call upon stage none other than our own Professor Rana Bhattacharya, sir, from Medical College, Kolkata, to enlighten us on PCOS, and we are eager to learn from sir.
A very good afternoon. Actually, I am a last moment replacement of Professor Ashraf Ghani, who was unable to attend due to some personal reasons. So I had to fill in his shoes, which is an extremely difficult task, as you can imagine. However, I will briefly discuss a very pertinent part, which is a very common disorder. In fact, it's the third most common endocrine disorder after diabetes and hypothyroidism, that is PCOS. And a particular aspect of PCOS, the age group, that is adolescents, where there are many confusions existing among all of us, including clinicians and gynecologists. So to clarify, let's start with one of our patients, a 13-year-old girl, had menarche 1 year back, referred by a gynecologist for irregular menses. She had multiple nodulocystic acne and few terminal hairs over chin. And thyroid function and prolactin both were normal, and USG report, the ultrasonologist has given a report as PCOS. So does she really have PCOS? Let's see. So how to diagnose PCOS in a adolescent girl? Now, even in adults, there are many confusions when we talk about the diagnostic criteria. There are many, like AES, which is the NIH, and the most commonly used and the most liberal, that is the Rotterdam criteria. Now, for most of the literature and for clinical practice, we do use Rotterdam criteria, where any of the following is usually sufficient to diagnose PCOS, that is clinical and or biochemical hyperandrogenemia, presence of oligoanovulation, and the polycystic changes in ovaries. And as I have said, the other criteria are stricter. But this criteria is not meant for adolescents. This is for adults only. Okay? So there are many pitfalls in diagnosing PCOS in adults by any one of these criteria. Let's see what are those. In adolescents, the anovulatory cycles are very frequent because, you know, at the initial period of reproductive life and near the end, that is in the perimenopausal phase, there is some unpredictable ovulation, and there is usually oligovulation and many anovulatory bleed. So that makes normally the menstrual pattern bit irregular. So when do we suspect PCOS? Depending on the uterine bleeding pattern. Number one, if there is primary amenorrhea. What does it mean? That when there is a lack of menarche by 15 years of age, or after the thelarchy, the onset of breast development, if menarche is delayed beyond 3 years of that. If there is secondary amenorrhea, that is more than 3 months without menstrual period initially after starting of menses. Oligomenorrhea. Now again, the definition of oligomenorrhea depends on the reproductive age. The first year after menarche, the average cycle length normally is around 90 years. That's the upper limit. So if it is beyond that or less than 4 periods per year, then we consider it's having oligomenorrhea. For postmenarcheal year 2, the normal cycle length shortens a bit. So cycle length more than 60 days should be considered as oligomenorrhea. From the postmenarcheal year 3 to 5, it becomes even shorter, almost normal, like 45 days. And after that, it's usually 35 days. So beyond that, we call it as oligomenorrhea. And excessive anovulatory bleed can also be there in some patients. So if there is excessive bleed and which is irregular, that can also suggest PCOS, although oligomenorrhea is much, much more common manifestation. Now, regarding the hyperandrogenism, again there are some pitfalls. Mild hirsutism and acne, even acne vulgaris, is quite common in normal adolescents. So unlike adults where the inflammatory acne is one of the suggestive feature of hyperandrogenism, this is a normal feature in adolescent age. And alopecia, which is an additional criteria, different types of alopecia that we see in adult patients with hyperandrogenism, those are usually absent in adolescents. So that's also not very useful for diagnosis. So we should take at least moderate to severe hirsutism as a criteria for adolescents. So modified Ferryman and Galloway score of more than 15 should be the criteria. And if there is extensive acne, which is unresponsive to topical treatment, typically numbering more than 10, either in face or chest or shoulders or back. So that is the criteria in adolescents, okay? So it's much stricter than adults. So that should be considered as a feature of hyperandrogenism when you consider acne as a diagnostic clue. When we measure testosterone, again there is a problem that sometimes during the period of anovulation, the testosterone level may rise because of the thecal volume. And the exact cutoff, although we use the adult cutoff, but it's a bit difficult because there is no clear-cut cutoff in adolescent population, but we have to do with adult cutoff as of now. Regarding ultrasound, again, we tell our patients, anxious mothers and anxious parents that ultrasonographically diagnosed cysts doesn't mean PCOS, and that is particularly true for adolescents where the presence of typical peripheral cyst pattern is extremely common in normal girls. Okay, so this is not at all a criteria. If we go by ovarian volume, there is some suggestion that you can take 12 millimeter of volume in any ovaries instead of 10 millimeter that is there in adults. You can use 12 millimeter as a cutoff, okay? But again, that's not very well validated. So if we summarize, the recent international consensus diagnostic criteria for PCOS in adolescent age group says that there should be a combination of two factors. Number one, abnormal menstrual pattern as evidenced by ovulatory dysfunction. And this is defined as a combination of the bleeding that is abnormal for age or gynecological age, as I've said, the postmenarche year 1, 2, 3 and beyond. And the symptoms should persist for 1 to 2 years. Now there are some pitfalls here because many of us, if their features are very suggestive, then we may not wait for 1 to 2 years. We may have to start treatment early. That depends on our individual patient profile. Secondly, they must have either clinical or biochemical evidence of hyperandrogenism. The features that I have described, that at least moderate to severe hirsutism, the acne which are large, which are greater in number, more than 10, which are refractory to treatment. Okay? So these are the criteria. Along with that, we use serum testosterone criteria, which is there for adults. We use the same criteria. And the surrogate clinical markers are also important. Like we should look for obesity, which is in adolescence is defined typically by BMI of more than or equal to 95th centile. Please remember, unlike adults where the obesity is classified by BMI of more than or equal to 25, here in adolescents that criteria is not sufficient. So we need a age-specific BMI criteria. Indian Association of Pediatrics have their own graph, own chart. You can consult that for this diagnosis. Presence of acanthosis nigricans is a very important clue. It suggests insulin resistance and therefore may suggest PCOS. So what do we do in the intervening 1 to 2 year period, which is the requirement, minimum requirement for international criteria that I have discussed. So we can term that condition as the person is at risk for PCOS. And if needed, if the features are very severe, even before 1 to 2 years, we can start treatment there. As always, as in adults, we must remember that PCOS is a diagnosis of exclusion. This is a very, very important factor which is often missed. Okay? So other causes of anovulation or hyperandrogenism, depending on the presentation, is extremely important because there is a long list of relatively rare but definitely important differentials, like non-classical congenital adrenal hyperplasia. We do see these patients. Idiopathic hirsutism, usually the menses are regular. Hypothyroidism, they usually do not present with hyperandrogenism, but more with ovulatory dysfunction. Hyperprolactinemia, again, mainly ovulatory dysfunction. Some patients can have hyperandrogenic features. Cushing syndrome typically can have underlying diagnostic clue, and androgen secreting tumors of ovaries and adrenals are very important. But we must not forget some situation like use of certain drugs which can lead to the features of hyperandrogenism like hirsutism. There are some drugs like valproate which can actually increase the serum testosterone level as well. We need to remember those. The classic form of the most common form of non-classic congenital adrenal hyperplasia, that is 21-alpha hydroxylase deficiency. Beyond that, we can have rare forms of NCCH that we also need to remember in some patient. And glucocorticoid resistance and congenital syndromes of extreme insulin resistance are also important, but again, all these are very rare. We suspect these cases depending on various underlying associated features, like presence of hypertension in cases of glucocorticoid resistance and so on and so forth. But for all patients, it's prudent to exclude at least hyperprolactinemia and hypothyroidism because these are the very easily available tests and we can easily exclude these two common disorders. For selected patients, if we have a clue for Cushing, we can do a post-overnight dexamethasone cortisol. If the hirsutism is significant and rapid progression is there, DHEAS is a must, otherwise we may miss adrenal tumors. 17-hydroxyprogesterone in the follicular phase, we do it when the hirsutism is relatively early onset along with starting of menses and there is a family history. Now in many patients of NCCH, as per our experience, there is no family history whatsoever. So to us, family history is relatively less important, although in textbook it's given as a very prominent feature. If family history is there, of course you should suspect, but even without family history, if there is early onset hirsutism, and particularly if there is no obesity, that doesn't mean that in an obese patient NCCH doesn't occur, because a patient with NCCH is also more prone to metabolic syndrome, but a patient who is a lean and having features of PCO, our suspicion would be even stronger, that we must exclude non-classic congenital adrenal hyperplasia by testing for 17-OHP. Now, the tests which can confirm or support, like testosterone, total testosterone is the test we should do. Ideally, the free testosterone sounds better because it avoids many fallacies, but the problem is that with our current assays, the immunoassays, the concentration of free testosterone is so low that we cannot reliably measure the free testosterone level. So for us, we measure total testosterone, and if we find it's normal and still if you have a very strong suspicion of hyperandrogenemia, you can measure SHBG, sex hormone binding globulin, and then we calculate free testosterone index, or as an alternative we can use total testosterone divided by SHBG, and the whole thing is multiplied by 100. The unit that we use is typical millimole per liter. Okay, you can convert whatever your lab gives you to millimole per liter, and then you do the ratio, multiply it by 100, and the cutoff is typically more than 6.1. It suggests hyperandrogenemia. Other supportive tests like LH-FSH ratio of more than 2, it supports the diagnosis. It's not a mandatory, but it often helps, particularly again in a patients with suspected lean PCO. Okay. Again, we should not forget metabolic risk assessment. We saw a patient, I have a patient, a twin, where the both of the sisters, they are under a gynecologic follow-up for 2 years. The metabolic parameters were never tested, came to me at the age of 16 years. Both are having diabetes with a presenting A1C of 9.5. So please remember, one should exclude diabetes by doing, or at least dysglycemia, by doing 75 gram OGTT, okay? Lipid profile is another must. And liver enzymes nowadays you should test, although this is not there in the textbook, but this is not unusual to find abnormal liver function test, particularly elevated SGOT, SGPT in a patient with PCO. So metabolic profile you should not forget, because a large part of PCOS is actually metabolic. So this is a very important thing to remember for physicians. Now, once you diagnose PCOS in an adolescent, now let's proceed about treatment, how to treat those patients, okay? Now, what are the treatment aims that we should know first? Because there is no single treatment for PCOS. The treatment depends on the underlying presenting feature, okay? So, if the hyperandrogenic symptoms are there, we should ameliorate that. Underlying metabolic abnormalities like dysglycemia and dyslipidemia, we should treat those accordingly. Prevention of endometrial hyperplasia and carcinoma is very important. Prolonged duration of unopposed estrogen action on endometrium is pro-carcinogenic. So this is a very important thing to remember. So how to manage? The lifestyle change, particularly in obese children, adolescents, is very important. So loss of about 5 to 10% of body weight leads to normal menstruation in many patients. So 80% patients with obese PCOS, okay? And even in adolescents, nowadays, before starting any therapy, we should exclude pregnancy, particularly with a prolonged anovulation, particularly when you are contemplating COCP therapy, okay? And why do we use combined pills? Please remember, the combined pills is not for everyone. We have to know clearly why we are using this combined contraceptive pill in an adolescent. Number one, when there is a need for menstrual control, when the bleed is really irregular and that is the priority for the patient, and if you think the contraception is also necessary, then this COCP is a very good option. Number two, for hirsutism, COCP is the first line therapy, okay? Usually, traditionally, we are taught that a higher level of estrogen containing pills, that is estradiol of 30 or 35 milligram, is effective or minimal requirement. But recent study says that 20 microgram of estradiol containing pills may also be useful in hirsutism, particularly in mild to moderate hirsutism. In adolescents, when should we start COCP? Please remember, when the TANA stage is more than equal to 4, not before that. Now, usually we get a COCP patient, patients with PCO when their breast is already beyond TANA stage 4. So this is not a very important criteria for most of our patients. Now, what kind of progestin we need to use? Please remember a rule of thumb. The less androgenic a progestin is, higher is the thrombotic risk, okay? But in adolescent, the thrombotic risk is usually rare, which usually occurs beyond 30, 35 years and all. But if that particular child has a family history of thromboembolic disorder, then less androgenic progestins should be avoided, okay? So drospirenone is a drug which is anti-androgenic. It has natriuretic effect, so fluid retention is less, which can be a complication of some patient on COCP. Desogestrel or norgestimate containing pills, so those are minimally androgenic, and levonorgestrel and norethindrone, which are very commonly used, particularly with the cheaper combined pills, those are more androgenic. However, please remember, in a patient with PCOS, the environment is already hyperandrogenemic. So if we use even these cheaper pills, which we often use in our OPD patients, poor patients, those are also quite effective in hirsutism. Progesterone only we use when we want to see whether the cyclical regularity is establishing or not, and this is just for the endometrial protection. We use it every 2 to 3 months. If there is amenorrhea, we should use this progesterone course for 10 days. GnRH agonist is rarely used in adolescents. Okay? In severe hirsutism, we may consider it, but it should always be used with add-back estrogen plus cyclic progesterone because of the maintenance of secondary sexual character and bone health. Regarding anti-androgens, spironolactone is most commonly used. 50 to 400 milligram is the dose that we use. Side effects are extremely rare in girls, okay? But still, it's recommended that you should check the blood pressure and potassium 2 weeks after starting therapy, and then according to your patient profile. But again, I reiterate the side effect. These side effects are extremely, extremely rare in girls. And of course, if we use this drug alone, always advise about the contraception, because this drug is teratogenic, particularly with the male fetus. Okay, it can lead to feminization of male genitalia. Cyproterone acetate is progesteronic. 2 milligram is used with combined pill, and 50 to 100 milligram is a very good anti-androgen drug, but unfortunately we do not have this in isolation, so we can't use this practically. Finasteride again is a weak drug, but it's well tolerated. We may consider in some patients. Flutamide we don't have. Metformin may be useful, particularly if the child has IGT or IFG, that is pre-diabetes. Otherwise, it's not that helpful. It's not at all useful for hirsutism. Inositol, again I won't go into detail due to lack of time, but overall, there may be a role of inositol in children where you are thinking about metformin and patient is intolerant there. But otherwise, for vast majority of patients, inositol is really not required. We must not forget the psychological issues associated with PCOS, like depression and anxiety. We must monitor for that and treat accordingly. This is again a very often missed complication, just like metabolic features. So our patient, cycle length is beyond 90 days. She was obese with acanthosis, total testosterone was high, 17-hydroxyprogesterone was normal, and there was mild dysglycemia. So we diagnosed this patient as PCOS. We advised lifestyle changes with a weight loss, the menses regularized, acne reduced, and subsequently the child was followed up. Now, to summarize, PCOS is a heterogeneous disorder. It's a diagnosis of exclusion, as I have said, and in adolescence, the many features overlap with normal adolescence, so we have to know how to diagnose PCOS in adolescence, okay? And the management is based on phenotype. There is no single management for PCOS. So you must address the patient's concern, what is your concern, and then you decide about a particular modality of management. Metabolic components must be addressed. Thank you for your patient caring.
Thank you, sir. So, sir, as usual, it's nothing to say, but sir, any questions from the hall?
Yes,
it was quite comprehensive diagnosis and treatment of PCOS. And true, we need to differentiate it from non-classic CAH, but from the therapeutic viewpoint, in an adolescent, what is the necessity of differentiating between the two, particularly if pregnancy issues are not there? Is there any difference from the treatment viewpoint?
Actually, from that point of time is not different, but again, in the adolescents, they will contemplate pregnancy later on. So we must have diagnosis in the very beginning. This is very important. Otherwise, if we misdiagnose NCCH for PCOS, she will never be diagnosed later on. So that's the opportunity there. We should suspect and diagnose then and there.
That's what I said.
Thank you, sir. So any other questions?
Yes.
3 questions. Is
Yes.
spironolactone safe below 18 years? Second one is, when we are starting COC in an adolescent, how long we can safely continue that? Is there any studies?
Right.
Cumulative?
So,
how many
taking
years
your
of-
second question first, how long can you continue COCP? I don't think there is any study, but practically speaking, if we consider COCP and if you think that the disease is not in reversible stage, like either she hasn't lost weight or she has a lean PCO to begin with, then you can continue it indefinitely until she is contemplating pregnancy. This is the practical thing that we follow. Regarding spironolactone we do use in adolescents, and I'm not sure about FDA approval, but again, these are older drugs and we do use in many patients and those are considered safe. But please remember, in most of the individuals for hirsutism, spironolactone is a second line. We at least wait for 6 months with combined OCP. Possible exception is very severe hirsutism, where we may start with this combination. But in most of the situation, we try 6 weeks of COCP to see the response of hirsutism, and then we can add spironolactone.
And for US criteria in adolescent, is there any cutoff like gynecologic age 8 years post-menarche, then we can take the ultrasound criteria?
Yes, yes. So to define this cutoff, which is saying that overartery volume is 12 millimeter, so when we consider as 10 millimeter, that is typically defined as 8 years of gynecologic age, that is 8 years post-menarche. Absolutely.
Any other?
Usually this PCOS patient, they most of the time complain of amenorrhea, and drospirenol and other drugs, when we administer that one, cycle of 6 months or 3 months, they menstruate, and when we stop that one, there is again history of amenorrhea. So how long, related to this question, previous question also, how long it can be used, and when there is in USG report, there is, previously the report was PCOS, polycystic, and afterwards the report is normal. Still the patient is complaining of that recurrent amenorrhea. Then what would be the line of treatment, and how long this cyprotenone and drospirenol can be used?
Very good question. I mean, a very practical question. I see some confusion among gynecologists and physicians regarding this. Absolutely true. The thing is that, as I've said, in adolescents, we do not rely on USG criteria at all. We do USG to see, number one, the endometrial thickness. If she is amenorrheic for a prolonged period, if it is more than 12 millimeter, then there is a risk for endometrial carcinoma. That's number one. That is the reason primarily why you do USG. Number two, sometimes we use the USG criteria of ovarian volume of more than 12 cc. Please do not look at the cysts. That is number two. Number three, as you are telling about the presence of oligomenorrhea, now here we have to decide which therapy to use. See, if there is no hirsutism, and if the patient is obese, and if you want to follow up this patient, whether she is having improvement in menstrual pattern with loss of weight, then what can you do? You can prescribe intermittent progesterone and ask the patient to have a lifestyle change. You can well monitor whether the menses are becoming regular or not. There is no need to add COCP. Number four, regarding the cyproterone combination, see, these costly preparations are really not necessary unless the child is having hirsutism. And that too, even in hirsutism, the simple pills, they work better. But of course, you can use those drugs. If there is no contraindication of using drospirenol containing or cyproterone containing pills. But as I have said, if the child is not obese, then you should continue this for indefinite period till she is contemplating pregnancy. There is no role of 3 months, 6 months course unless you have a strong belief that there is a reversibility. For check the reversibility, you can stop and then see. Otherwise, there is no such course of COCP.
Thank you, sir. So I believe with time constant, although there are many questions there, so we believe we have to close this session. So going to ask the next session, we have...
Thank you.
Thank you, sir. So thank you, sir, for your excellent deliberation. So going towards the next session, that is the year-in review part 2, to discuss with us the concept of acromegaly and what is the new in this research, we call up on stage Ms. Sukriti Jaina from Kalinga, Bhubaneswar, who will be enlightening us with the concepts in acromegaly.
This one? A very good afternoon, respected seniors, faculties, and all delegates. At the outset, I would like to thank the entire team of Crescendo
for giving me this opportunity to be a part of this academic extravaganza. So today, not to waste any more time, I will be talking about acromegaly year in review. So acromegaly, I feel it is one of the most interesting diseases in medicine, to be more specific, endocrinology. And all of us are quite intrigued by its presentation, how it presents, why it presents the way it does so, and so on and so forth. However, in the past few years, the attention has been on development of newer drugs for management of acromegaly, as well as a shift towards a more personalized medicine or a precision medicine targeted therapy of acromegaly. So with that, I'll start my presentation. So to start with the basics, acromegaly is a chronic disorder characterized by growth hormone hypersecretion that stimulates the production of IGF-1 that in part mediates the somatic and metabolic effects of growth hormone. It is a multisystemic disease. It is characterized by somatic overgrowth, multiple comorbidities, premature mortality, and of course physical disfigurement. Now, etiology in more than 99% of cases, it is a growth hormone secreting pituitary adenoma, and in less than 1%, it may be an ectopic growth hormone from pancreatic tumors or lymphoma, or it can be an ectopic growth hormone releasing hormone secretion, which can be from some neuroendocrine tumors and or some hypothalamic tumors. So clinical features, obviously the physical changes which take almost a decade to be recognized, prominence of the brow, prognathism, macroglossia, etc. Metabolic and endocrine complications like impaired glucose tolerance, frank diabetes mellitus, etc. GI complications, reproductive complications, local effect of the enlarged tumor, cardiovascular complications, respiratory complications, skeletal complications. So it is, as I said, a multisystemic disease. So if we see the timeline of the major discoveries in acromegaly research, I'll just be focusing on a few highlights. So the first treatment, medical treatment, was dopamine agonist, which was used in 1936, and almost 60 years later you got the regulatory approval of long-acting octreotide, and regulatory approval for pegvisomant was in 2003. 2007 we got the lanreotide acetate approval. 2014 was for pasireotide. Within this time period, around 2010 to 2014, a lot of studies came up about resistance to SRL, somatostatin receptor ligands, and that's how the concept of personalized medicine, how it started during that time. So if we still continue the timeline, we got the clinical instruments for assessing the comorbidities and activity of the disease, SAGIT tool and ACRODAT in 2016-2017. The phase 2 trial of a growth hormone receptor antisense oligonucleotide, which started in 2018. 2020, oral octreotide was FDA approved. 2022, paltusotine was given orphan drug designation by FDA for acromegaly patients. So coming to the most recent guidelines on the acromegaly consensus on criteria of acromegaly diagnosis and remission. So this is a table which is comparing the different criteria for diagnosis and therapeutic efficacy over the years. So we'll focus on the Endocrine Society guidelines, which were in 2014. And here, for diagnosis, we need a IGF-1 elevated for age and a confirmatory OGTT showing a growth hormone if growth hormone is not suppressed in more than 1 microgram per liter. And for therapeutic efficacy, they said IGF-1 normalized for age and random growth hormone less than 1 microgram per liter. So if you consider the most recent guidelines, the 14th acromegaly consensus, the diagnosis is by IGF-1 more than 1.3 times the upper limit of normal for age and along with characteristic clinical signs of the disease. In case of equivocal results, you may repeat the IGF-1. OGTT might be additionally useful, however, it is not mandatory for diagnosis. And for therapeutic efficacy, only IGF-1 normalized for age. So just to repeat it again, for diagnosis of acromegaly, a patient with typical clinical signs and symptoms, IGF-1 more than 1.3 times the upper limit of normal, it confirms the diagnosis. Random growth hormone may be measured, it may inform prognosis, but it has no role in diagnosis. For patients with equivocal results, IGF-1 measurements can be repeated using the same validated assay. OGTT might be additionally useful. So OGTT, if it is performed, 75 gram glucose administered after fasting, and the nadir is assessed after 30, 60, 90 and 120 minutes. BMI based cutoffs can be considered with BMI less than 25 kg per meter square, cutoff less than 0.4 microgram per liter, and BMI more than 25 kg per meter square, cutoff less than 0.2 microgram per liter. So the clinical and imaging and pathology assessments as per consensus 2024, there has not been much change. So careful history and physical examination as in any clinical disease, contrast enhanced pituitary MRI, reporting should take into consideration the NOS grading for the MRI invasiveness into the surrounding structures. Equivocal diagnosis of acromegaly with pituitary microadenomas, they should be referred to an experienced neuroradiologist. Pathology reporting should include immunohistochemistry, and transcription factors can be used to define the adenoma lineage. So this is the treatment algorithm, what we already know. This was in Nature's in 2018 by Melmed et al. So if there's inadequate growth hormone or IGF-1 control with first generation SRLs, so we go, if the biochemical response is not there and tumor concern is present, paclitaxel should be given. If biochemical response is not there with impaired glucose metabolism, pegvisomant, there is tumor concern as well as biochemically uncontrolled, first generation SRLs with pegvisomant. If now the patient is well controlled, we'll monitor the IGF-1 levels. If not, then go for a stereotactic radiosurgery or surgical intervention. So in the current medical management basket, we have parenteral somatostatin receptor ligands, oral octreotide, growth hormone receptor antagonist pegvisomant, and the oldest drug, cabergoline. So these are the currently approved medical therapies for acromegaly. What I want to highlight here is to see the biochemical efficacies of the same. If you consider octreotide and lanreotide, the biochemical efficacy is around 30 to 40%, and tumor shrinkage, it is around 60 to 65% for both. For paclitaxel, the efficacy is slightly higher. It is 54%. Tumor shrinkage is much higher, 80%. And for pegvisomant, 70% biochemical efficacy. Obviously, no effect on tumor mass because it is a peripherally acting drug. Now, novel medical therapies include a combination of paclitaxel pegvisomant, which has a biochemical efficacy of the highest, 73.8%. Oral octreotide also has a higher biochemical efficacy, 58.2%. There are some drugs, antisense oligonucleotides, which are still in trial. Now, coming to the most recent review of treatments of acromegaly which are in development, which was published in the Endocrine Society in 2024. So, I'm taking some snippets from this paper. So, it is mentioned about paltusotine, which we already know. It is a once daily oral non-peptide selective agonist of somatostatin receptor type 2. It has a 4,000 times selectivity of SST2 compared to any of the other receptor subtypes. And we have Acrobat Edge, Acrobat Evolve, Acrobat Advance, and all of these they concluded that once daily oral paltusotine was effective in maintaining the IGF-1 values in patients with acromegaly who switched from injectable SRLs. And it was well tolerated with a safety profile consistent with other SRLs. So a new formulation of octreotide, the subcutaneous depot, which is still in trial, the Acrinova 1 trial. So it has a fluid crystal depot technology, and it has a nanotechnology which increases the plasma exposure 500% as compared to octreotide LAR. And the advantage of this drug is it has pre-filled syringes and pre-filled pens, so patient can self-administer. Now, drugs blocking growth hormone receptor, they are still, this is in phase 1 trial, it is AZP3813, and this is a site 1 binding helix, and both of these drugs have not been tried in humans yet. They are still in the pre-phases now. So coming back to the consensus on criteria of acromegaly diagnosis and remission, the 14th consensus, the outcome goals as per the 2024 updates are maintaining the IGF-1 level in the mid to upper half of the age-related reference range. It could be considered as in clinically controlled patients to avoid induction of growth hormone deficiency. And biochemical remission is the primary assessment of treatment outcome. However, it is not the only goal of treatment. It should always be interpreted within the clinical context of acromegaly signs and symptoms. So for post-operative remission, there are no definitive studies on the optimal assessment of post-operative remission, nor the timing of its evaluation. IGF-1, it should be measured at 12 weeks after surgery to determine the post-operative biochemical remission. Early random growth hormone on day 1 to 14 and a comparison with preoperative GH can inform the degree of adenoma removal and subsequent long-term remission, but it is not given as a mandatory testing in this guideline. OGTT, again, it is not given as a mandatory testing. It focuses on IGF-1 at 12 weeks. So, determinants of SRL responsiveness. Why is this important? As I said, the biochemical efficacy of these SRLs, which we are using as a first line, is around 30 to 40%. So what are the factors that actually determine the responsiveness of SRLs? So in a nutshell, Histopathology, densely granulated growth hormone pituitary adenomas have a better SRL response. High expression of SSTR2, it positively correlates with the SRL expression. Again, molecular markers like E-cadherin ZAC1, they have a positive correlation, and negatively correlated with response are Ki67, SSTR5, and AIP mutation. So here comes the role of personalized medicine. Currently, the decision to administer one of the three major classes of agents is not based on any clinical biological rationale. Moreover, it is important to recognize that current treatment algorithms, it is based on a trial and error approach with additional treatment options provided when the disease is not controlled. So it is important to develop a treatment algorithm based on the prognostic and predictive value of specific biomarkers, and this has the potential to be more efficacious as well as more efficient in the long run. So this study, the personalized medicine in acromegaly, AcroFast study, which was published in 2024 in Endocrine Society guidelines. So just the context is same. Medical treatment of acromegaly was a trial and error approach, and effectiveness of SRLs as a first line is around 50%, and subsequent drugs are indicated as per clinical judgment. So what they did is they took two arms, one arm of acromegaly patients, some were treatment surgery naive, some were post-surgery. Standard treatment as per the protocol that I showed previously, starting with first generation SRLs. If response is not there, then adding the other drug as per the clinical scenario. And second arm was a personalized treatment arm. And how they decided this personalized treatment was they did a short acute octreotide test. One second. A short acute octreotide test. They did MRI for tumor size, extracellular invasiveness, and T2 signal intensity. And for if it was a post-op patient with tumor samples, they did a E-cadherin. So the short octreotide test, what they did was 100 milligram of octreotide subcutaneous, and after 2 hours growth hormone was done. If it was suppressed to less than 2.7, the subject was said to be a responder. If it was more than 2.7, however, the change in growth hormone from baseline is more than 50% decrease, partial responder, and if decrease was less than 50% from baseline, it was a non-responder. So in the standard treatment, first generation SRLs were given. For the personalized treatment, in case of full response, first generation SRLs. In case of non-responsive but no tumor concern, as in MRI non-invasiveness or E-cadherin positive, pegvisomab. In intermediate response or non-responsive with MRI invasion, combination of first generation SRLs with pegvisomab. So the results are quite clear here. At the end of the study, in the green shows the control disease. In personalized treatment arm, 78% patients were biochemically in control, and in the standard arm, 53% patients were biochemically controlled. So the results indicate a superior and a faster hormonal control and consequent improved symptomatic relief in the personalized treatment arm. And this AcroFast trial, it represents a pioneering effort to redefine the therapeutic management of acromegaly through personalized medical treatment. Similarly, this was a review article for predictors of biochemical response to somatostatin receptor ligands in acromegaly. This was also published in 2024. So they also took certain factors like clinical factors, lab factors, imaging, and certain molecular markers. And they made this algorithm in this review that you can perform an acute octreotide test, check for the T2 MRI signal. Their cutoffs were 1.4 and 4.3. If there is a suppression of growth hormone and hypointense T2, that means densely granulated tumor, first generation SRLs should be considered. Intermediate phenotype, then combination of SRLs with other option. And if just like non-responders in AcroFast, if growth hormone is not suppressed and hyperintense T2, then other options should be considered. They also use certain artificial intelligence methods and took these histological and molecular characterizations. And similarly, if densely granulated, E-cadherin positive, SSTR positive, 2 positive, then SRL monotherapy. Intermediate phenotype, then pasireotide and other options. Sparsely granulated, E-cadherin negative, SSTR2 negative. So resistance to FGR, first generation SRLs is predicted, and other options should be considered. And so this was a study in European Journal of Endocrinology, the REMA study, which was a registry of pituitary adenoma subjects. What they did was correlated the clinical, hormonal, and molecular data with the invasiveness in acromegaly. So overall, the highlights of this study are, this study identified the crucial biomarkers associated with size and invasiveness of growth hormone secreting tumors, providing a comprehensive understanding of their molecular characteristics, They found that younger age, visual abnormalities, higher growth hormone, and lower expression of these markers, PRL, POMC, etc., were associated with tumor invasiveness. So again, these findings offer significant advances in risk stratification to improve the diagnostic and therapeutic interventions in growth hormone secreting pituitary adenomas. So coming to my last slide, what's new in acromegaly? Apart from the newest 14th acromegaly consensus for diagnosis and management of acromegaly, now there has been this has been started since a decade, talking about somatostatin receptor ligand resistance and who are the patients that respond to SRS better. The studies have been ongoing. However, the momentum, it has gained momentum now recently, and the focus shift on understanding of the role of novel molecular and clinical biomarkers in predicting the responsiveness to medical treatment and helping clinicians in personalization of the follow-up and treatment of resistant somatotroph adenomas. So targeted therapy is now an important step forward in management of acromegaly patients. Thank you very much for your patient hearing.
Thanks for this excellent talk, ma'am. So now the hall is open for audience questions. If anyone having any questions in the audience? Okay, if there is no question, then thank you, ma'am.
Thank you. That means everybody has understood or nobody has understood me.
Now for the next session on osteoporosis, I would like to call upon stage Professor KVS Harikumar sir, who needs no introduction. So sir will enlighten us with updates on osteoporosis. Thank you, sir.
Good afternoon, everybody. Thanks to ESB team for the invite. Can we have the slides? Yeah. So, some of you who have attended this hall in the pre-lunch session would have heard something about osteoporosis, possibly some extension of it. In the next 15 minutes, I will be speaking about year in review osteoporosis. So, some of the clinical questions what we daily face in osteoporosis, have we found any answers in the last year, is what my focus will be. If some answers are not there, I will say what the literature says accordingly. So, questions concerning about the diagnosis, management, some recent advances because newer drugs what are being developed, all those issues. Definition thankfully has not changed. Systemic skeletal disease characterized by low bone mass, deterioration of bone, increased propensity to fractures. These three components are essential for defining osteoporosis, so it remained the same. DEXA-based diagnosis also remains the same. There is not much change here. You do T-score for your management issues. You identify Z-score to diagnostic issues. So please keep both these things in mind whenever you are evaluating a patient with the low bone mass. One important factor which is, slides are not moving from here. Slides moving here but not there. Yeah, thank you. So leave it, thank you. Yeah, T-score and Z-score did not change much. So again, the definitions remain the same. Important one point about peak bone mass is you should identify that whatever you are losing is from the bank what you have deposited till about 30 to 35 years of age. So it is important to highlight the bone health, especially in the adolescents and younger age group, because the more you build up, the more your bank balance to lose at a later date. The peak bone mass is slightly delayed as far as the accrual in the males, slight decade, but more or less between 30 to 35. And because of increased surface area, the males have a higher weak bone mass. That is why the fracture rates are a bit late in the males than when compared with the females. Second, we don't, as a male, we don't have a definite event as a menopause where there is a rapid fall in the bone after menopause, unlike the females. Epidemiology, 30% of postmenopausal have osteoporosis. Important factor, 20% mortality if somebody suffers from a hip fracture. And India, everything is young, so it is, you have some specific risk factors. A decade earlier, low calcium diet, high phytates, all those things prevent the absorption. So you have by and large multiple risk factors which are responsible for increase in the bone loss in Indian subset. So now comes the questions what we are looking at. Current approach to osteoporosis and when to repeat screening even on management or even if somebody has found to be a normal bone density. If you can see here, possibly, I'm sure nobody can see it, doesn't matter. But issue is beyond 70 years, as far as the guidelines are concerned for males, and 65 years, you are supposed to do the screening. And depending on whether you are a high risk or you are a moderate risk, you can choose the options available, what you are going to use. Between 50 to 70, you can use the fracs and depending on other risk factors. Okay. So what are the approved drugs you have? You have by and large the drugs which are the anabolic agents, anti-resorptive agents. The anabolic agents approved are the teriparatide, abaloparatide, which is the PTH-RP analog, and you have the sclerostin inhibitor, that is a romosozumab. And you have the anti-resorptives, which are the bisphosphonates. You have the rank ligand inhibitor, which we commonly use, the denosumab, and maybe hormone replacement therapy in a particular subset of patients who have got symptoms of menopause and still have bone loss. That is a segment which you can use, or if somebody has contraindicated. On to the right, you can see the different dosages of the approved drugs and the duration of action. The longest duration of action approved is with the denosumab. You can use it safely without any drug holiday for almost a decade. Even now, beyond that also can be used, but at least a decade. Whereas for bisphosphonates and other, we do consider giving a drug holiday after 3 to 5 years of usage. For anabolic agent of teriparatide, it's only a 2 years of approved. The shortest is actually the romosozumab, where you have approval only for 1 year, but it is the most potent as far as the efficacy is concerned. Now, conventional guidelines do say that you are supposed to screen at 65. Are we missing out somebody if we are not screening early? So, what are the indications or when to screen early? I have given the reference articles in the beneath, and any woman with or men with prior history of fragility fracture or a positive family history, any underlying chronic inflammatory disorder or a metabolic disorder, lot of genetic reasons, and any, if you have calculated the fracs even without a BMD, if the fracs is suggestive of a low bone mass, you can subject them for a DEXA. And important thing, ISBMR guidelines published a couple of years back did bring down this cutoff by 5 years, 60 for females and 65 for males. So you have a Indian guidelines which say that you can screen them early. Any new diagnostic test for osteoporosis, because DEXA is the gold standard, there is no doubt about it, but city-based practice, DEXA is widely available, still reasonably expensive. There are some AI models which are being developed, where conventionally the naked eye, when you look at X-ray, we don't consider X-ray as suggestive of osteoporosis because you require to lose almost close to 50% to it to manifest. So now AI models have been developed where the external noise surrounding that X-ray or the bone image has been removed, and the algorithm will predict whether this particular bone has got a higher risk of fracture or not. So you have some advancement in this area which is going to give you, I would say, more easily available across the board. You can just click a X-ray and upload to a particular site and they'll give you a probability of a fracture. So something like this is going to come where the osteoporosis screening becomes more easy. The second important thing, we don't do any nuclear imaging at all as far as osteoporosis is concerned, because we consider that that is more of a functional element. Here it is not functional. But you have what is known as the fluoride FDG PET, which is likely to pick up the osteoblastic activity. So it is almost parallelly whenever you start an anabolic agent, before even your bone turnover markers change, you can actually have a FDG PET which will give you the clue that the bone is actually getting formed. So the fluoride actually exchanges for the hydroxyl group of hydroxyapatite and it gets incorporated. And if you do a PET CT, you will get to know that which are the bones which are actively getting formed, and that is where you can derive some scores or some data or some idea that the bone is actually getting formed. So some of the newer advances. Another important thing, when you started therapy and what about if patients are not improving, your BMD is not changing much, or can we use, because now that we have multiple options, we do get this from the diabetes spectrum, that can we use combination therapies or sequential therapies. So these are the guidelines which was published last year, the Asia Pacific guidelines, which have addressed some of the concerns. The only important thing what I would say is, on to your right if you see, somebody who is having new fractures despite using anti-resorptives, that is the only subset where actually a combination therapy has been recommended. Conventionally in osteoporosis, we don't recommend any combination therapy. We do only a sequential therapy. But if somebody is using anti-resorptives and still BMD is worsening or developing a new fracture, you can use. And depending on, suppose somebody develops a osteonecrosis, somebody develops a atypical fracture of femur, so you can have various subset of considerations as to what drug to use. The most potent ones are romosozumab and teriparatide. Those are the best as far as if you have very severe osteoporosis. So important to understand. So some of the data did suggest that you can use combination therapy, and whenever you use a denosumab, you have to follow it up with a anti-resorptive or anabolic so that there is no ongoing or rebound loss after stopping the therapy. New molecules for osteoporosis. This slide is only relevant for postgraduates if there are any. You have the Wnt pathway, you have the Notch pathway, you have the BMP pathway, and you have the Hedgehog pathway. And these are the different molecules which are being studied. So there are different spectrum other than, I mean, we have reached to a sclerostin, we have reached to DKK, we have reached to some of them in the phase 3 trials, but some of them will come in years to come as the newer molecules in osteoporosis. How to approach osteoporosis in men? Well, most of the times, I'm sure in the clinical practice also, the husband would say that this is a problem of my wife. But if you do a BMD of both, actually the husbands would get the BMD worse than their wives actually. That is the problem, but it is generally not considered as a disease in males, but they do have the significant problem. Most of the guidelines do not offer anything separate or specific for male versus female, including the diagnostic criteria, including the cutoffs, everything, except for a 5-year cushion is given extra so that because the males lose more, that's all. But there are no separate gender-specific recommendations. One important word about osteoporosis during pregnancy and lactation. Here, the mechanism is slightly different. Some of the times, it is predominantly described during the lactation, not during the pregnancy. If a lady, a lactating mother, complains of severe back pain, unusual to the profile or other things, always consider getting a DEXA, because they do have a significant amount of vertebral fractures alone, which are only picked up by the DEXA or a X-ray if it is very significant. So they have fragility fractures, and you can use teriparatide, bisphosphonate or denosumab. Evaluation and mechanisms are multiple different. During pregnancy, it is more of absorptive hypercalciuria, whereas in the lactation period, it is more of PTH-RP mediated skeletal demineralization, which is going to cause a bone loss. Now, how to approach osteosarcopenia? It is not the bone alone what matters. It is the muscle also what matters. So both of them are interlinked, because the moment you exercise the tendon and to the bone, that is where your actually stimulus happens. So it is important to exercise, view them in a continuum. So you have 3 different important parameters which address all these 2 things together: vitamin D, testosterone and growth hormone. They have effect on bone, they have effect on muscle, which will improve the strength. And some of the newer studies have come. Irisin is one of the things which goes up when we exercise, which has lot of positive metabolic benefits. Irisin has some direct effects on the osteoblasts also, which will help in improving the bone formation and reducing the bone mass. So you have a important actions as far as the exercise and sarcopenia concerned. Follow-up after therapy, you have frequency, what to do clinically, you should look at new fractures. Biochemically, you should look at vitamin D and you should do calcium whenever you are using teriparatide. Bone marrow, bone mineral density, you should do every 1 to 2 years. Bone turnover markers, depending on what you are using, maybe every 3 months. And drug holiday only in a low-risk patients, what you should look at. So to conclude, osteoporosis is a silent killer, definitely a major problem which is not much addressed or looked at. Beware about the peak bone mass because prevention is better than cure. Adopt healthy lifestyle measures. Screen for osteoporosis when indicated using the available measures. And always look at T and Z scores in the report. Don't look at only one and jump on to conclusions. And choose the correct therapeutic option, be it anabolic or anti-resorptive, depending on the patient profile and how severity is the bone loss. And this is one place where you require interdisciplinary management because fractures don't come to endocrinologists. They come to your orthopedic colleagues. So you should have a good liaison with the orthopedic team so that he fixes the fracture at that point of time, but the follow-up happens with you so that you prevent a further happening of any other fracture. I finished here. Any questions or comments, I shall be happy to take.
Thanks. Thanks, sir, for your excellent deliberation. Now, if there is any question from audience. No questions? Okay, sir, thank you.
Thank you.
Now we are moving on to our next session, updates on hungry bone syndrome from our own auditor sir, who is professional HOD from Ramakrishna Mission Seva Pratishthan and VIMS Kolkata.
So good afternoon, everybody. At the outset, I'd like to thank organizing committee for giving me this opportunity. So this is a syndrome which we do commonly discuss, though it is not so much frequent, but it is a syndrome which we do see in our day-to-day clinical practice. So there are nothing extra steps or extra invention in these days, but there are some recent concept came. So we will recapitulate some previous understanding, and we also look after for other any recent message are coming or not. So before going to the main topic, let's discuss two cases. The first one is a 40-year-old female presented with a progressive fatigability along with anorexia, polyuria, polydipsia, and a history of recurrent nephrolithiasis. Also, she had a history of fragility fracture. So the total calcium was 13.7 and PTH was sky high, 1240 picogram per ml. And CT scan revealed a parathyroid adenoma. So a case with a primary hyperparathyroid and managed with IV fluid followed by calcitonin. And after 48 hours, the calcium was going down, but again calcium was elevated. So if you see, initially the calcium was high. Any pointer? এটা কি এটাই নাকি? হ্যাঁ ঠিক আছে, okay, fine, fine. So if we see this case, initially the patient presented with severe hypercalcemia. After resuscitation, the calcium is going down. Then again, calcium is going up. At that time, we have planned for parathyroid surgery. And after parathyroid surgery, you will see there's a dip in the calcium level. But this hypocalcemia persists approximately 1 week to 10 days, and then the calcium level was stable. And it is a case from our own institution, a patient who presented with hypercalcemia. Similarly, like previous cases, the total calcium was high, very high. PTH was 193, and there is a right inferior parathyroid adenoma. The patient was initially resuscitated with IV fluid, calcitonin, sinacalcet, along with IV zoledronate. And if you see this post-op calcium record, and then patient was put on for surgery. And after surgery, you will see the calcium level was 7.5 and PTG 7.73. So this is very good. In the day 2, the calcium was 8. Day 3, calcium 7.6. Day 5, still it is low. And day 7, calcium is 8.1. So from these two cases, what we do see, a patient who is suffering from primary hyperparathyroid, after surgery, there is a dip in calcium level, and we do want this low calcium. But what is our experience that this low calcium will be recovered within 3 to 4 days, or maybe 4 to 5 days. But in both of these cases, the hypocalcemia was persisted, and it persisted above 4 to 5 days and maybe 1 week, and sometimes it may be for months. So what are the differential diagnoses for the postgraduate trainees particularly? Usually we do know that after parathyroid surgery, if a single adenoma has been resected, because of hypercalcemia, other parathyroid gland was suppressed. So there is a transient hypoparathyroid. So this is the first differential diagnosis. Second and third may be because of the jeopardization of the local vasculature and accidental removal of the parathyroid gland. That could be the differential diagnosis. But last but not the least is the hungry bone syndrome. So if any patient after post-surgery of hyperparathyroid, or sometimes after toxic goiter, Graves' disease, I will discuss later on, presented with hypocalcemia, these are the 4 common differential diagnoses. One is the transient hypopara, second is the local vascular jeopardization, third is the total parathyroidectomy, and last but most important one is the hungry bone syndrome. So there is no clear-cut consensus or definition regarding the hungry bone syndrome, but we, as I have already discussed, we do see a state of persistent hypocalcemia after this parathyroidectomy or thyroidectomy. But recently, there are some data. Along with that, we can say that hungry bone syndrome has been, the patient has been suffering from hungry bone syndrome if there is a persistently low calcium greater than or equal to 4 days with a serum calcium less than 8.4 milligram per deciliter. So any patient with a low calcium less than 8.4 and persisted for 4 days or above, we can say that the patient is suffering from hungry bone syndrome. But what is the difference between the hungry bone syndrome with the other case scenarios, other differential diagnosis? The most important is in case of hungry bone syndrome, or in these cases, the PTH level will be low. In case of post-surgical parathyroidectomy, or in case of transient hypopara, the PTH will be low, phosphorus level will be high, and the magnesium will be normal. But in case of hungry bone syndrome, because all ions has been taken up by the bones, we will see the low calcium, side by side low phosphate, side by side low magnesium, and the PTH level is usually normal. So this is a paper where we do see a patient after surgery, the calcium level is going down, but then it is the low calcium is persisted. And it persisted for 4 to 5 days or 6 days. So we can say that the patient is suffering from hungry bone syndrome. Usually in case of transient hypopara, the calcium level will be stable within 3 to 4 days. But if it is persisted greater than 4 days, usually we are dealing with the hungry bone syndrome. There are no definite data in our hand, but still date, there is a study, a big study was done, and they said that approximately 13% of patients, particularly in case of primary hyperpara, after surgery, we do see 13% of cases of hungry bone syndrome. But in case of ESRD, in case of end-stage renal disease, where the patient is suffering from CKD MBD, there the percentage is little bit high. It is approximately 20%. So now coming to the pathogenesis, why there is a hungry bone syndrome. So let's discuss a little bit about the physiology. We know that there is two phenomena is going hand by hand. One is the osteoblastic phenomenon, one is the osteoclastic mechanism. So the main bone resorption occurs by the osteoclast, and osteoclast is originated from the myeloid cells. And usually it originated from pre-osteoclast, and pre-osteoclast is originated from the myeloid cell by some transcription factor. And this from the pre-osteoclast to mature osteoclast, and mature osteoclast to active osteoclast, it is occurred by a important hormone. It is called the rank ligand. And this rank ligand is activated by the parathyroid hormone. So if there is a condition where increased PTH level, and there are some other causes also, sometimes active vitamin D, some cytokines, they also increase rank ligand. So if there is increased rank ligand, there is a transformation from the pre-osteoclast to mature osteoclast, and then mature osteoclast to active osteoclast. And there is a negative factor, it is called the OPG. This is osteoproteogene, which actually inhibits the rank ligand. So if you see this picture, you will see from osteoclast is activated when the rank ligand is act on the rank. Then there is a mature osteoclast and activated osteoclast. But this OPG actually binds this rank ligand, so this phenomenon will not be there. So OPG actually inhibits the rank ligand to rank, this connection. So if there is a state where there is a less OPG and there is a state where there is increased rank ligand, then we will see osteoclastogenesis. So just a recapitulation, in a patient, in a normal patient, if there is a low serum calcium, that will be sensed by calcium sensing receptor in the parathyroid. Then parathyroid hormone secretion will be there, and side by side bone resorption and bone formation will be there. So small or sporadic exposure to PTH lead to net bone formation. This is a very important concept. If you give a patient with a small dose of PTH sporadically, there will be bone formation. But if there is a steady PTH exposure, steady increased level of PTH exposure, then you will see there is an increased activation of the rank ligand, and side by side there is a decreased level of OPG. So in one hand there is osteoclastogenesis, and on the other hand osteoblastogenesis is also decreased osteoblastogenesis. So in a nutshell we can say that predominance of bone resorption in hyperparathyroidism. And there are some studies that showed that prior to parathyroidectomy, if you have a sample and check for osteocalcin, which is a bone formation marker, and if you check a bone resorption marker like tartarone-resistant acid phosphatase, you will see the bone resorption marker will be much high. So whenever you will cut down this parathyroid, there is an abrupt decrease in PTH release. So there is the upset in the equilibrium, and you will show more osteoblastic phenomenon. So initially there is more osteoclastic, now it is more osteoblastic phenomenon. And because it is more osteoblastic phenomenon, all calcium, magnesium and phosphate will be taken up by the bone. So you will see a patient who presented with hypocalcemia, hypophosphatemia, hypomagnesemia. So what happened in case of CKD MBD? Initially, this is in case of secondary hyperpara. In case of CKD, a patient presented with increased phosphate and increased PTH. So what is the mechanism? We know that a patient who presented with CKD MBD, there is a less phosphate excretion, there is a decreased kidney mass. So because there is a decreased kidney mass, there is a decreased calcitriol. Because there is a decreased calcitriol, there is a low calcium, and side by side, because there is a low excretion of the phosphate, so high phosphate stimulates parathyroid gland. High phosphate also decrease calcium level. The low calcium also stimulate parathyroid gland. And side by side, because there is a low calcitriol, there is a low calcium. But nowadays, and all these phenomena going to the, that will be reflected by increased PTH hormone. And there is a secondary hyperparathyroid. But nowadays, we came to know that this is not a very simple thing. Actually, what happened, the low calcitriol, these are the late phenomena. What happened, in case of CKD, they usually presented with osteoporosis very early stage, and osteomalacia definitely in the very early stage. Why? Because the recent evidences showed that we know that there is osteoblastic mechanism and osteoclastic mechanism, as I have already discussed, and the most important cascade is the WNT pathway. So what happened, this WNT pathway will be activated, and side by side there is an anti-WNT, because of increased WNT phenomenon, there is some WNT inhibitors are also secreted from the kidney. And these, like DKK1, and sclerostins, there are the WNT inhibitors, or the DKK1, WNT inhibitors, sclerostin, they all inhibit osteoblast. So a patient without having any hyperparathyroid also, they may prone to fracture. So, but what happened in the other side, there is an increased FGF23, which is secreted from the kidney, and it also decreases the calcitriol level. But in a nutshell, we can say that there are multiple mechanisms are there. In a one word, we can say that in CKD-MBD, there is hyperparathyroidism, and because of hyperparathyroidism, there is osteoarthritis fibrosis cystica, or there is a decreased bone mass, and finally, sometimes a patient, to treat a patient, we have to go for parathyroidectomy. So there are some other causes of hungry bone syndrome, and very interesting causes of hungry bone syndrome. One is commonly known that Graves' disease, they could present with hungry bone syndrome, because we know that in Graves' disease, there are increased bone turnover, and where there is a increased bone turnover, whenever you will pull out this thyroid gland, then there will be increased osteoblastic phenomenon. Also, there is a simultaneously during surgery, there is increased release of calcitonin, and we know that if their calcitonin level is increased, there is a decreased osteoclastic and increased osteoblastic phenomenon, and simultaneously parathyroid may be hampered, parathyroid gland may be resected. So there are some factors in case of Graves, particularly female patients, large goiter, increased T3, T4 level, they are the common predisposing factor for hungry bone syndrome in case of Graves' disease. Now, there are some other important mechanisms are there. The hungry bone syndrome, we may see hungry bone syndrome after giving cinacalcet. We do give cinacalcet, particularly a patient who are posted for surgery, parathyroid surgery. But now there is a medical problem maybe. And after giving cinacalcet, what happened? If you see this picture, there is a gross change in the calcium and phosphate both. So cinacalcet could be, whenever you will give cinacalcet, not only you will check calcium, but you have to check phosphate sometimes. That patient may complain of refractory hypocalcemia. There are important cause of hungry bone syndrome is the tumor-induced osteomalacia. We all know that in tumor-induced osteomalacia, there is increased FGF23, and this is a phosphaturic hormone, and because it is a phosphaturic hormone, there is a less phosphate. So a patient who underwent a surgery for tumor-induced osteomalacia, where we expect increased phosphate level, like in these cases, the phosphate level was very low, initially phosphate level was very high, then again there is a rapid decline in the calcium and phosphate level. So tumor-induced osteomalacia also very important cause here. And we know that the osteoblastic metastasis in case of prostate cancer, sometimes in gastric carcinoma, they may presented with hungry bone syndrome. And this is a patient where the calcium was low, phosphate was also low in a case of prostate carcinoma. So why there is a Hungry bone syndrome in case of prostate carcinoma. Why in case of prostate carcinoma with osteoblastic metastasis? So these tumor cells actually they actually produces inactive TGF-beta. Also they produce PTHRP, and also they produce some other bone morphogenic proteins. And all these proteins, this TGF-beta, bone morphogenic protein, and IGF-1, PTHRP, they all actually increase osteoblastic they stimulate osteoblastic pathway. So, and this initially the inactive TGF-beta is stimulated, is secreted from the tumor cells, and that is transformed to active TGF-beta with the help of PSA. So, if the PSA level is very high, in a case of metastasis, we are expecting that the patient may turn over into hungry bone syndrome anytime. Simultaneously, PTHRP could be secreted from the tumor cells. And that this PTHRP, we know that they can increase the osteoblastic pathway, but PSA have a negative effect on the PTHRP. So in the one hand, PSA has a positive effect on the TGF-beta. On the other hand, it has a negative effect on the PTHRP. So this is before radium therapy, and after radium therapy, you will see the calcium level is going up. So any patient, so take home message from here that any patient with prostate carcinoma, with osteoblastic metastasis, you have to look for hungry bone syndrome. And what happened in the initial days, in case of initial days prostate carcinoma, who is being treated with estrogen, they also showed hungry bone syndrome. Why? Because we know that estrogen actually aggravates this osteoblastic pathway. So what are the clinical manifestations? These are very, very common hypocalcemic manifestations, hypophosphatemia, and hypomagnesemia, and very important, in case of end-stage renal disease, after surgery, you will see there is a hyperkalemia. So this is a very important phenomenon occurring. A patient who underwent parathyroidectomy, in case of CKD, ESRD, they not only show low calcium, low phosphate, low magnesium, they may show hyperkalemia also. So these are the risk factors, particularly a patient where the PTH level is very high, where there is increased alkaline phosphatase, where there is increased BMI and increased creatinine level, they are more prone to hungry bone syndrome. And definitely there is a bone changes, osteitis, fibrosis cystica. If you see a patient with primary hyperparathyroid with these bone changes, there is a chance of hungry bone syndrome. Management, just simple calcium correction. I am not going to the details about the calcium correction. Oral preparation of calcium, magnesium correction, vitamin D. These are the very common thing. I will not discuss here. But how to prevent this hungry bone syndrome? For prevention, we can give preoperative calcitriol. There are some reports of preoperative calcitriol, preoperative calcium, and along with sometimes bisphosphonate may be useful steps. But there are no such randomized trial that we can say if you give, there will be a benefit. But nowadays, few centers, they practice that even if the calcium level is very high, give calcium, give calcitriol, and give bisphosphonate before surgery, at least 3 to 4 days back. Then you will see there is a less chance of hungry bone syndrome. So what is the take-home message here? The hallmark of hungry bone syndrome is profound and persistent hypocalcemia. This is the most important, profound and persistent. And that persists beyond 4 days. The syndrome can require significant amount of calcium supplementation, and it could be up to 1 year with calcium and calcitriol. And there are some small retrospective study, pre-op calcitriol, vitamin D or bisphosphonate may help to reduce the hungry bone syndrome. So thank you for patient hearing.
Thank you, sir, for this excellent talk. Now, if there is any questions from audience. No questions from audience, sir.
Sure.
Thank you, sir. Now, moving on to our next topic on hypophosphatemia metabolic bone diseases. I would like to call upon stage Professor Pratosh Gangadhar, sir, from Kozhikode, Kerala.
Good afternoon. Shall I start? At the outset, I'd like to thank Endocrine Society, Bankar, for inviting me for this session. And I will be talking with hypophosphatemic metabolic bone disease. And this is the update session, so I will be focusing the updates of that particular topic. So the outline will be, I will be just going through the phosphorus metabolism overview, what are the recent updates happened on this, and just brief approach to hypophosphatemia, and I will be just discussing the differences between the presentation of pediatric and adult hypophosphatic MPD, and recent experiences on evaluation of adult onset hypophosphatemia, and when to do the somatostatin scintigraphy versus genetics. There is a slight dilemma in that set of patient. And finally, I will be just briefing up with Burosoma, whether it is a hope or what are the challenges. So if you look at the approach to rickets, we all know there is always a question like calcipenic or phosphopenic. And basic difference is that calcipenic means it deals with a vitamin D deficiency as well as calcium deficiency related issue. And the predominant player here is generally this one, yeah. Predominant player is PTH, and which lead to renal phosphate wasting that increases the 1-alpha hydroxylation of vitamin D, and it mobilizes bone. And finally, it leads to all the manifestation of rickets. But I'm not talking about calcipenic rickets. I'm more dealing with the phosphopenic rickets. So basically, phosphopenic rickets means there is decreased phosphate absorption from the kidney as well as the gut. And it could be due to increased FGF23. And you can see that it leads to increased phosphorus loss from the kidney. We'll discuss that. And it leads to hypophosphatemia. And what actually hypophosphatemia does? Basically, the 85% of the inorganic phosphorus is in the hydroxyapatite. So it actually leads to failure of hypertrophic chondrocytes to apoptose, disorganization of the growth plate happens, delayed mineralization of the growth plate and osteoid. So this is the reason why the bone lead to decreased chondrocyte differentiation, and it leads to osteomalacia. And the interesting mechanism of action of HGF23 versus PTH, there is an oppositing effect on vitamin D metabolism of this hormone, as we know. The PTH, I already mentioned, it increases the 1-alpha hydroxylase, while FGF23 suppresses the 1-alpha hydroxylase. So it will be a clue, so that if you measure one active vitamin D, it will be low in FGF23 mediated disorders, while the other way around. And now, the recent updates, you can see that this is the regulation of the secretion of FGF23 from the osteocyte. What you can see is this is an important step, like iron deficiency. Iron deficiency is an important trigger because it actually stabilizes the hypoxemia inducible factor. So this is a trigger for FGF23 secretion. So iron deficiency actually leads to increase in the FGF23 generation. And this is one peculiar thing that you expect in a rare cause of hypophosphatemic autosomal dominant hypophosphatemic rickets, where actually iron deficiency leads to manifestation of hypophosphatemia. This is one disease where you can get remissions in autosomal dominant hypophosphatemia. It's very rare, where you can see iron deficiency precipitating, and after treating iron deficiency will cure hypophosphatemic rickets in autosomal dominant hypophosphatemic rickets. So another important point is iron infusion paradoxically causes hypophosphatemia. Iron deficiency increases FGF23 generation, but iron infusion like FCM, ferric carboxymaltose, known to cause hypophosphatemia. It usually starts transiently. I do have a recent patient where phosphorus level dropped to 1.5 after FCM of 500 milligram injection, and it lasted up to 2 to 3 months, and it recovered. And what really does FCM does is the post-restoration FGF23 is going into the inactive forms. This particular conversion into inactive form is actually inhibited by FCM. So this is not the mechanism by iron deficiency stimulate FGF23 secretion. FCM acts through a different mechanism. FCM actually acts in this area, where this conversion happens. It's a post-translation modification. So another important step, this is a beautiful diagram. This can explain a lot of controversies in this phosphorus sensing. So important phosphorus sensing area in osteocyte is FGFR1 receptor. So this sensing is the key mechanism for XLH, X-linked hypophosphatemic rickets, and we don't know really much about how hypophosphatemia occurs, how FGF23 increases in hypophosphatemic rickets in FEX inactivation. This is still an area of research, and you can see that GAL-NT3 is needed for preventing the degradation of intact FGF23, which is the active form. So there are other players like dentin matrix protein 1, DMP1, and FARM20C. These are associated with some genetic autosomal recessive hypophosphatemic rickets. We'll discuss that. So FGF23, you can see that FGF23 receptor alpha klotho is the core receptor that acts on the kidney. And in kidney, it inhibits the sodium phosphorus co-transporter. This is the ATP-driven channel. 2A is the dominant channel and 2C. So it leads to increased urine phosphorus excretion. So serum phosphorus drops, and also it inhibits 125 hydroxy dehydroxylation. So it will also inhibit the intestinal phosphorus, increase the intestinal phosphorus, decrease the intestinal phosphorus absorption. Now this is the key mechanism, FG1 receptor involved in the sensing of phosphorus availability. So this is the only thing you can find if you search what is the key reason. So there is an enhanced FGF receptor signaling in the XLH model hip mice. So abnormal sensing of phosphorus is the mechanism of pathogenesis of XLH. So FEX, DMP1, ENPP1, and FAM20. FEX is the mutation for XLH, X-linked hypophosphatemic rickets. DMP1 is the mutation for autosomal recessive hypophosphatemic rickets type 1. ENPP1 for autosomal recessive rickets type 2, and FARM20C is RHI. These are negative regulators of FGF23. When these are mutated or deficient, you will get increased FGF23. And this is only the new regulator of phosphorus degradation in the kidney. This is called a transmembrane TMM174. So I will just skip that with that physiology. Now coming to the approach, so if you look at the low phosphorus level, the most important parameters is the urine levels of phosphate, whether it is low or high. We measure it by TMP, GFR, urine 24-hour phosphorus excretion, or fraction excretion of phosphorus. There are different methods. And if you measure serum levels, and if FGF23 is high, then we are discussing the whatever things I already mentioned, XLH, and the autosomal recessive dominant hypophosphatemic rickets, and acute forms like tumor-induced osteomalacia. That are the fairly common diseases we encounter. But if FGF23 is low or normal, then you have to think about the diseases like hereditary hypophosphatemic rickets with hypercalciuria. This is not uncommon. You may encounter it. Unless you look for this, you may miss this. So the clues are, one is they have high 125 hydroxy vitamin D. Unlike the FGF23 mediated disorders, they will have a low active vitamin D. They have a high calcitriol, and their urine calcium creatinine ratio will be very high. So this is an important clue, and this is often misdiagnosis, and the treatment differs because you only need to give phosphorus, not calcitriol, in hereditary hypophosphatemic rickets with hypercalciuria. And other things are absorption related thing and redistribution related thing. Only condition that last hypophosphatemia of significant duration, this intracellular shift, is hungry bone. Severe hungry bone can last up to 6 months, where you can may need high phosphorus supplements in such scenario. And this is just an algorithm. I'm not going to the depth of this algorithm. I already discussed this algorithm. But you can use 24-hour urine phosphorus. If it is more than 100, you can consider it a high phosphorus excretion, and also fraction excretion of phosphorus. If it is more than 5%, you can consider it high phosphorus. Not only TMP, GFR, and other algorithms, you can use simple way as well. So now coming to the disorders, this again I discussed, so I'm skipping this, only mentioning because the most common disorder you might encounter in a pediatric age group is X-linked hypophosphatemic rickets, and most common disorder in an adult population you may encounter is the tumor-induced osteomalacia. Now a transient hypophosphatemia is very common with FCM use, I already mentioned. So this I already discussed, so I skip that slide as well. So if you look at the XLH is caused by inactivating mutation of X, and this all we know, but the common presentation that happens in pediatrics is rickets, deformities, craniosynostosis, hearing impairment, dental malformation, short stature. But in one important point you should look for in these children is that after the age of 3 years, they can develop dental issues. So a spontaneous formation of periapical gingival abscess or fistula around a visibly healthy tooth with no evidence of dental caries or trauma is a typical dental malformation. So this is the classical appearance in imaging as well as clinical appearance. So you have to take care of the dental aspect. Even your treatment may not actually reverse this unless this person get a good dental care. So this is because of hypomineralization dentin, and it leads to cracks, and so this is the mechanism by which that happens in X-linked hypostomy rickets. You can go into a very good book that's freely available, like Update on X-linked hypostomy. Now coming to adults, it leads to a lot of issues, mainly ossification of posterior longitudinal ligament. That's one important thing you should not miss. It's a clue for genetic rickets in your adult patient. Enthesitis and periarticular calcification, tendoachilles calcification, osteoarthritis, fractures, bone pain, very common as we know. Secondary hyperparathyroidism on treatment, tertiary hyperparathyroidism and nephrocalcinosis. Hypertension with LVH is a less recognized entity, and hearing impairment due to predominantly temporal bone issues, and that leads to sensory neuronal hearing loss can happen. So these are the complications in an adult patient with hypohidrotic rickets you encounter. Now, commonest cause of acute hypohidrotic metabolic bone disease is tumor-induced osteomalacia. So it is most rewarding thing, because if you localized and excise it, this can lead to significant benefits to our patient, and they will be extremely happy. And this is the algorithm published by Chong and et al. This is a landmark article on TAO in endocrine cancer. You can see that this is the algorithm. If you find the signs and symptoms in an adult patient presenting with hypostotic ricket, low phosphorus, low active vitamin D, increased FGF23, you need to exclude familial forms. This is an important thing in adult patient, when to exclude genetic issues, because if you are not excluding genetics, then, or you are not suspecting genetics, there will not be a family history in many of your patients with adult onset hereditary hypostotic rickets. So obviously the tumor localization with gallium dotanoc PET or genetics, that is the important dilemma you might encounter. That's the one dilemma I encounter frequently now, whether to go genetics or to go for imaging first. Because now genetics is much cheaper than imaging. So this is the one question you need to think. Then once you localize with imaging, you can go for anatomical characteristication of the tumor. If you have dilemma, you can go for sampling, then localize and surgically excise the lesion. Now, I'll just run through some interesting cases. This is a male patient who had a left hip fracture, and he has classical adult onset high FGF23 mediated oncogenic osteomalacia, and his gallium scans showed a pleural based lesion, and it was actually the orthopedic surgeon was planning to operate this patient, but actually thoracic surgeon, who was not quite sure about what he is excising, will cure this patient, actually cured the fracture, and he had complete healing of the lesion, and it was a pleural based TAO that thoracic surgeon cured a fracture. So interestingly, my orthopedic surgeon was unhappy, but he actually able to cure one of his patients. He had a very superficial lesion. You can see that this is the gallium positive lesion that was present in the dorsum of the foot. So he easily removed that, and patient cured of the tumor-induced osteomalacia. And this is another case, interesting, again, the orthopedic surgeon who actually localized the lesion. And interestingly, it was a palpable lesion, phosphaturic mesenchymal tumor, that is present here between the both thigh, inner thigh on the right side. So it's a superficial lesion. Again, orthopedic surgeon was happy because he was able to cure 2 cases of adult onset tumor-induced osteomalacia. This is a challenging case where the patient had 2 lesions on Galen-Dottorock PET. So Galen-Dottorock PET showed two double lesions. Then how to go about? The large lesions definitely on the foot. And here, actually, we did a USG-guided selective venous sampling. This was one of my first patients, 2015. Actually, you can see that the draining vein, proximal veins only, we did 3 samples because it's very expensive test. So you can see that the right lower limb where the large lesion was there in the foot was the culprit. The FGF23 levels was very high, 805. In comparison to other areas, it was on the lower side. So this patient underwent excision. This was a small lesion causing hypostotic osteomalacia in that patient, and he was cured. So selective venous sampling, sometimes you can do a limited sampling, especially if you have very high constraints on that. Now, financial constraints, you can consider limited sampling. Now coming to another patient, she's a 22-year-old girl. She is again born into non-consanguineous marriage, no history in siblings. She had initial evaluation showed vitamin D deficiency and secondary hyperparathyroidism, but you can see that follow-up evaluation showed in spite of correcting vitamin D deficiency, her hypocytemia is persisting, and she was having low phosphorus 1.25 with a low TRP and low TMP-GFR and a high FGF23, that is 272.3. And she was evaluated for genetic also hypostemic osteomalacia here. Her age is only 18. And she underwent a clinical exome sequence. This was done from another center to rule out XLH or other kind of hypostatic osteomalacia. This is a clinical image. You can see that there is something in the spine. That is a clue for her future diagnosis. I will come to that. And there is insufficiency fracture in the pubic, inferior and superior pubic ramus, and the fibula, you can see there is a bilateral insufficiency fracture. And she actually went to an orthopedician. He did a gallium scan for this patient, and it was negative. Meanwhile, she was waiting for the genetic analysis. She was underwent a gallium scan, but probably that was not needed in this patient. And her clinical exome sequencing revealed a heterozygous ENPP1 mutation. This is probably, I'm not very sure it's reported elsewhere from India. It's a very rare type of hypocytemic rickets, and the important point is that it's otherwise called autosomal recessive hypocytemic rickets type 2, which is enzyme. This gene actually encodes an enzyme ectonucleotide pyrophosphatase phosphatase 1, which generates pyrophosphatase by degrading ATP. So in infancy, it is associated with severe form, generalized arterial calcification of infancy, and it leads to a fatal disorder. And bisphosphonate is considered to be an important treatment for this disease. And here you can see that this patient has actually ossification of posterior longitudinal ligament. So this is the one clue of hereditary hypocytic osteomalacia. This kind of calcification can happen. Although in the previous literature, if you look, spinal calcification in hypocytic osteomalacia in adults often suggests presumptive diagnosis of XLH. That may not be true. You can find these kind of findings in other forms of hypocytic osteomalacia as well. So we need to consider other genetic causes of hypocytic osteomalacia in such scenario. Now, adults with ENPP mutation, important clues you can look for is that the calcification. They can have periarticular calcification. There is a described entity called normocalcemic multicannular primary hyperparathyroidism. This was there in our patient. She had scan negative persistent hyperparathyroidism, and hearing loss was disturbed, and pseudoxanthoma elasticum is one classical skin manifestation of ENPP mutation, and enthesopathy. So there are many overlapping features with XLH. So in adult, if you find enthesopathy or ossification of posterior longitudinal ligament, you still need to consider the conditions like autosomal recessive hypocytemic rickets like ENPP1. So ectopic calcification is why happens because it's deficiency of PPA. PPA is an essential inhibitor of calcification, so it leads to ectopic aberrant calcification. This is another patient. She actually presented with an insufficiency fracture of the intertrochanteric area, which needed a DHS and on the left side prophylactic pinning. And she was found to have low phosphorus and marginally elevated FGF23, just 151. 150 was the cutoff of FGF23. And she presented in 2017, underwent multiple gallium scans from different centers, all were negative. And she had, you can see that dental significant dental malformation. What are these dental malformation? It's interesting thing that I came to know only recently, and I thought it's probably a manifestation of hyposystemic osteomalacia, the poor dentition and other things. And you can see that recently she was underwent for on follow-up. She was replaced with phosphorus. She improved. She was asymptomatic, and she was frequently lost to follow because she was staying in Malaysia. And then she stopped the medication and now come with a severe pain. She doesn't have a fracture. You can see that there is a cortical beak with a thick cortex that you classically see in a bisphosphonate-induced severe suppression of bone turnover, SSBT kind of thing in this patient. And she came with that pseudo-fracture and severe pain and limitation. And again, recently, 2 weeks back, she underwent surgery to correct the difficulty. So this patient, 38-year-old lady, dental malformation. This is in 2017. This happened in 2024. Multiple pathological fracture, bone pain, FGF23 mediated hyposystemic osteomalacia with a negative Galen-Dottner pair. Actually, she underwent a genetic evaluation, and what we found was that she had a FAM28 gene mutation. So this is one interesting finding. FAM28 gene mutation first described from Calcutta, from your group. So this is one interesting finding. I will come to that case because I also came to know that 2 days back because I am researching on this literature on this particular thing. But interestingly, our patient doesn't have nephrocalcinosis. This is a condition associated with amelogenesis imperfecta, renal enamel renal syndrome. So you will find nephrocalcinosis, amelogenesis imperfecta. What you see in this image is amelogenesis imperfecta. She has a very high degree of amelogenesis, brown teeth, almost deformed teeth, and the dentist told that she need to replace all the teeth. They all malformed significantly. So interestingly, unlike the other case, this patient doesn't have nephrocalcinosis, and this is a new mutation, probably the first patient coming with a pathological fracture. And because your publication from Calcutta by Pata, Pratim Chakravarti and group, that girl had hypophosphatemia with high FGF23 and myopathy, no fractures. So that was the literature, no fractures, and she has nephrocalcinosis. And if you look at the mutation, it's a different mutation from our case. This was a different mutation. But FAM28 gene was never described in hypophosphatemia osteomalacia. That's the important point. It's the first one described from India. So this is probably a player in the post-translation activation of FGF23. Rain syndrome is caused by FAM20C mutation, and it's in the same family. So probably there is some signaling mediated by FAM20A for the FAM20C effect. So that is the reason by which they develop this FGF23 increased secretion. So that is the reason by which this patient developed hypophosphatemia of severe degree, and the mutations is the different side. So it's a genotype-phenotype differentiation is there. Now this is a third lady. She's an elderly lady. Again, hypophosphatic osteomalacia. Actually, she had a scan positivity. Gallium PET showed an abnormal uptake of FcVmax 10 in the calcaneal region. But the nuclear medicine physician already mentioned that it could be a calcific tendinous-related pseudo uptake. And generally, she underwent an excision of the lesion, but she had a persistent disease. So this is another issue. You get a false positive scan, excise but no PMT, and I am strongly suspecting actually a hypophosphatemic osteomalacia of genetic origin, probably autosomal dominant or some other mild heterozygous variant of autosomal recessive hypophosphatemia. But she is not very keen for genetic evaluation right now, so we are not evaluating this. So what are the clinical clues? So in this algorithm, we need to modify a bit, and when to check for the genetic mutation. Not all cases we need to check. If there is severe dental malformation, ossification of posterior longitudinal ligament, calcification, enthesitis, periarticular calcification, pseudoxanthomelastic, and nephrocalcinosis, arterial calcification. If this is present in your patient, always go for genetic evaluation first, then go for screening. So this is the important message from that. I think can I continue? Okay. So this is the one point. And now coming to the treatment part, the conventional treatment, whether lifelong treatment with the phosphate and calcitriol is the usual dictum in hypophosphatic osteomalacia, but the important adverse effects are diarrhea. It's not very common, but secondary hypoparathyroidism, increased FGF23 synthesis is one issue. So initially, you need to give calcitriol for at least 2 to 3 weeks, before initiating phosphate replacement in this patient and try to heal the rickets and osteomalacia, then initiate phosphate supplement. That's the recommendation. And conventional preparations like Julie solution, I have not used for 10 years, but now I am strongly considering to use it because of the financial implications. So AdFos is the one we often use. In the DM residency time, I used Excelite, which is again an option that time. But the Jolie solutions could be an important option because these treatments are lifelong, especially in a hereditary form. And most of the patient cannot afford the cost of therapy because phosphate supplements need on the higher side of replacement dose is needed, and calcitriol is expensive, so generally treatment is very expensive. So I am strongly considering to going back to the conventional treatment with the Jolie solution now. The burosumab is the newer update. We all know that because it's there but not available in India. It has got a half-life of around 16 to 19 days and blood level peaks by 7 to 11 days. So it definitely improves the phosphate homeostasis fracture and pseudofracture healing and patient-reported quality of outcome. And important points regarding burosumab is that calcitriol and phosphate treatment should be stopped 1 week prior to starting burosumab. And children dose is 0.8 milligram per kg every 2 weeks, while adult it's every 4 weeks. And highest dose is 90 milligram. And periodic measurement is needed. Unlike the usual scenario, when you're giving phosphate and calcitriol, you need to measure phosphorus 1 to 2 hours after phosphorus supplementation. When you're giving burosumab, you need to measure peak phosphate 1 to 2 weeks after the last injection, trough phosphate 4 weeks after the last injection of burosumab. And it can clearly heal. It definitely works, but it may not cure the dental issues. So that is one point. Actually, dental issues are increased in burosumab group in a trial, larger RCT. So probably the dental issues are not due to FGF23. That already we discussed. DMP1 as well as the other mutation I mentioned, FARM20 and FARM20C, all has dental issues. So this, even if you are giving FGF23 inhibition, you may not be able to cure the dental issues with your treatment. So reality check, it's not available. It's extremely costly in US, $160,000 per annum. Probably there, many cannot afford it, and it can lead to fever, injections. And restless leg syndrome is one important adverse event recently mentioned with this particular treatment. But many of my patients even afford the conventional therapy with the usual supplements. I am going to change my prescription to the Jolie solution now. So in conclusion, approach to hypophosphatemic MPD is often complex in endocrine practice. Many pathophysical mechanisms are still evolving, and we still don't know many things about the FGF23 mechanism. There are a lot of players, and probably FARM20 mutation-related hypophosphatemia is described first from a Pathik group from Calcutta, and we have a pathological fracture disease now from Kerala. So this is the first time some described mutation. So this also has some role in the bone metabolism and hypophosphatemia and FGF23 metabolism. So pediatric and adult patients present with different challenges I already mentioned. Genetic evaluation versus functional imaging. Most important thing will be to avoid unnecessary imaging. Look for clinical clues for genetic syndromes. I already mentioned many of the clinical clues, so you can go for genetics because at least in our part, genetics is cheaper than gallium PET nowadays. So burosumab often a dream for us, and we might need to go back to the conventional preparation. Even from AdFos-like preparation, I am probably going to go back to Julie's solution because it's very terrible for many of our unfortunate patients to go for long-term treatment, and it's very expensive. With that, I conclude. Thank you. Thank you.
Thanks for this excellent eye-opening session, sir. So, is there any questions from the floor? No, if there is no question, then we can move on to the, thank you, sir. Then we can move on to our next topic on challenges in transgender hormone therapy. For that, I would like to call upon stage Professor Devmallu Shandan, sir, from KBC Medical College, Kolkata.
Today I will be substituting for Professor Dr. Anirban Majumdar, who has, because of personal reasons, couldn't make it today. He's out of country. So, challenges with regards to transgender hormone therapy. So first we look into the diagnostic changes in the terminology. From the first terminology is gender identity disorder, which was a psychiatric diagnosis and a little bit demeaning. There was then the dysphoria, which was universal dysphoria, but something which is not present in all transgender subjects. So they have now removed it from the ICD mental and behavioral disorders, and not all subjects have dysphoria. And again, the diagnosis has to be confirmed by a mental health professional. And it has to be persistent, well-documented dysphoria, which requires an informed consent after the age of majority has been attained. Very important, mental health concerns doesn't mean that one cannot undergo hormone therapy. It must be, however, well controlled. And also in subjects, we see a lot of subjects having HIV, hepatitis B and C, where we shouldn't be denying therapy because of these underlying issues, provided they are well controlled as well. Very important, the natural history of diseases. They start at the age of 7 years, but majority are desisters, that is 85%. Only if there is persistence of gender dysphoria, even in adolescence, do you need medical intervention. And if we see again, we have seen the age of onset even in our population of gender dysphoria around 9 years, but their presentation is pretty late, probably because only 10% of subjects have family support. Again, if you see, there's a huge substance abuse as well as anxiety and major depression and suicidal ideas, as we have seen also in our population. And even the average age of suicide is around 16 years. Very important, and however, something which is encouraging is that after treatment, especially after gender affirmative hormone therapy, there is a significant improvement in psychological outcomes as well. Now, if we see that there is a huge amount of loss to follow up, this is something when we treat, we see every day a significant proportion of subjects do not come back for follow up. And that is the reason why a lot of these subjects undergo unplanned, ill-timed surgery by medically unqualified subjects. Again, something which is very challenging for most of the physicians, though it's decreasing over the recent years. Again, when we are talking about treating in puberty or early puberty, generally GnRH is recommended only after Tanner stage 2. Sometimes it is required even in late post-pubertal period, Tanner stage 4 or 5. And that, however, improves the height outcome, the breast development, as well as the voice and jaw changes. But there are certain issues as well, because there are less tissues for future surgical operations. The risks of pubertal suppression with GnRH includes effect of bone density, but it has been seen over 2 years, there is no change in the Z score. Again, compromised fertility is an important concern that has to be discussed, because the age is still minor, that discussion is still not very valid. And again, there are issues with regards to brain development. But the benefits are also there with regards to pubertal suppression, like gender exploration, cosmetic outcomes are also better. Fertility counseling is very important. We require further research, especially in this population, with regards to the impact of gender affirmative therapy on fertility outcomes. There are now options of sperm cryopreservation as well as testicular tissue cryopreservation, but again, they may be mentally traumatic for the patients to undergo. Similarly, in trans male, there is now development, even in our country, the option of oocyte cryopreservation, but it may be somewhat mentally distressing as well. So now the options have significantly improved with fertility preservation, and several of our patients undergo fertility preservation options as well. With regards to standard of therapy, as you can see, there is feminizing therapy is oral estradiol mainly, plus minus anti-androgens and GnRH, and for masculinizing, it's basically testosterone intramuscular, either in terms of esters or undecanoate or gels as well. The changes take over 2 years, but there are no hormonal RCTs comparing different regimes. And again, the efficacy in terms of facial, body hair, and muscle mass is not that great. The risks especially are important, especially with regards to thromboembolic disease in estrogen therapy and with testosterone erythrocytosis. Again, concern with regards to hepatic impairment with estrogen use, one should stop estrogen. Worsening insulin resistance may be a factor, especially the bone mineral density and osteoporosis may be an issue, especially if there is subtherapeutic hormonal replacement as well. Absolute contraindication where we should be stopping gender affirmative hormone therapy with estrogen is venous thrombotic events, estrogen sensitive neoplasm, and end stage chronic liver disease. Whereas with testosterone, it's CAD, pregnancy, and polycythemia as well. And again, obstructive sleep apnea. With estrogen therapy, VTE, thromboembolism, is an important risk, which is highest in the first year, but it's still low in our population. And it's more common, especially those who are obese and who have tobacco abuse as well. And also route of therapy, especially with ethinyl estradiol, there is higher risk as well. Transdermal preparations or parenteral preparations are better, especially valerate and 17-beta estradiol are associated with lower risk, and their levels can be monitored compared to conjugated estrogen. Even parenteral estradiol are even safer, just like transdermal. And again, with GnRH therapy, there is lower dose requirement. However, most patients prefer anti-androgens because of cost of therapy. We had also reported recently in WPATH meeting, which is next week, where we see that with GnRH or orchidectomy, there is a significant lower dose and they were more effective with regards to achievement of target hormonal level compared to combination with anti-androgens. And the dose requirement of estrogen was also lower, which you can see very well. It's average 6 milligram with anti-androgens, whereas it's about 3 to 4 milligrams with GnRH therapy. Again, with transdermal, you can see it's required, it's recommended, especially if there is a history of VT or the age is more than 45 years. As you can see, the dose requirement with transdermal is about 2 to 5 milligrams per week, whereas with injectable estrogen, it's pretty low, less than 5 you can achieve the optimum dose, whereas with oral, you would require about 4 milligrams per day to achieve target estrogen levels. Now, this recent paper in endocrine practice showed that compared to guidelines, actually the dose requirement is much lower with estrogen injectable preparation. It can be given subcutaneously as well. It is available in our country as well. With regards to breast development, the maximum development occurs within the first 6 months. However, the estrogen level doesn't predict breast development. Progesterones have not been evaluated well. There are certain risks associated, especially increased weight gain and lipid changes. Micronized progesterone may be better. There is one paper with regards to better breast development and lower testosterone, but higher mood swings with medroxyprogesterone acetate. Again, there can be increased risk of hyperprolactinemia and even pituitary lactotrop growth, and that has been accentuated with cyproterone. So if we avoid cyproterone and have used lower dose of estrogen, we can avoid this high rise in prolactin levels as well. Now, with female to male therapy, it can be injectable or undecanoate, or it can be gels, and they can easily suppress the menstruation as well. Most prefer the estrogen, testosterone esters because of the cost. About 20% prefer the gels, and about 20% would prefer the undecanoate 3-monthly injections as well. But if menstruation suppression becomes a problem, we need to switch from the gels to the injectable, which are more efficacious, and probably give it more frequently as well. Erythrocytosis is an important issue, and that has to be monitored. About 10% can have erythrocytosis, which can lead to thromboembolic events. This is higher in smokers, in patients who have chronic lung disease, who have higher BMI, and longer-acting testosterone undecanoate have higher risk associated with erythrocytosis. Transdermal, again, preparations may be beneficial. One can switch if their hematocrit goes above 50%. We had also reported this central venous sinus thrombosis with use of testosterone undecanoate as well. Now, with regards to low dose, we have reported, we would be presenting this next week as well, with regards to subcutaneous route of testosterone therapy, because the intramuscular therapy may be painful and the levels may have a seesaw level. So the better and more stable levels are achieved with low dose subcutaneous therapy, and it has been found to be effective as well. With regards to body composition, use of testosterone achieves an intermediate body composition between cisgender and the desired transgender. So that's important. So body composition changes. The insulin sensitivity is no different when with use of testosterone, but with use of estrogen, there is higher insulin resistance as well. And that can lead to increased risk of diabetes. And with the in trans women, so there is higher risk of ischemic heart disease, stroke, and VTE. But the lipids are worse in trans male, as well as the blood pressure is higher in trans male as well. So the higher risk of cardiovascular events are seen generally in trans women with estrogen compared to trans men. Again, this was a long-term review with regards to safety of gender affirmative hormone therapy, and what was seen, the commonest side effect was increase in prolactin with estrogen and erythrocytosis in men with testosterone therapy. But overall, it was considered safe. However, there is lack of long-term mortality data, cardiovascular risk, and cerebrovascular risk. So this study has been extended beyond 10 years as well. I was a reviewer of this paper, and this is very important long-term data reassuring the safety of gender affirmative hormone therapy. So this is a recent paper in Diabetologia 2024 which assesses and which suggests that screening for CVD risk with waist circumference, weight, blood pressure assessments should be done yearly. The lipids, the A1C, the hematocrit has to be assessed, especially in patients at least once in a year. Lifestyle modification is also suggested. In patients who have moderate risk, obvious lifestyle modifications have to be implemented, but patients who have hypertension, dyslipidemia, diabetes, we need to have a close watch with regards to cardiovascular events, and we need to have statins and other cardiovascular measures have to be implemented as well. With regards to choice of treatment to minimize cardiovascular risk, there is no RCT to suggest superiority of one formulation of testosterone over other. Again, with regards to route and formulation of estrogen, again, there is no data with regards to superiority of one over the other. However, ethinyl estradiol and conjugated estrogen should be avoided because they are associated with higher risk. We are now no longer using this with regards to gender affirmative hormone therapy. Generally, estradiol valerate is being used. Transdermal estrogen is preferred, especially after the age of 45 and in subjects who have had a prior history of venous thromboembolism. Again, there is no quality evidence with regards to cardiovascular safety of anti-androgens. Spironolactone may have a better CV outcome, whereas cyproterone has somewhat of a negative cardiovascular outcome data. With regards to bone health, gender affirmative hormone therapy generally preserves bone health. It's patients who are after having gonadectomy, who are not on hormone therapy, who are at a significant higher risk of osteoporosis, something which we commonly see in the Hijra population as well. And again, one should not be recommending routine BMD. A normal LH especially may be an indicator of adequacy of sex steroid replacement, especially subjects who are hypogonad, either post-operative or GnRH therapy without any hormone replacement therapy. They have a higher risk of bone loss, especially those who are at a lower doses, inadequate doses. They have a higher risk of osteoporotic fractures or a family history of fracture. They should be screened with a BMD at baseline and at 3 years. Those who are at a low risk, we can consider screening at regular time, that is at 60 years and every 6 years. Now, with regards to FRAX, what should be the sex assigned? How should we measure FRAX with sex assigned at birth or the affirmed gender? Generally, we need to assess the risk using both male and female calculators and using the intermediate value, because that is what is required, because once they are transitioning, we used to need to assess fracs with both male and female calculators as well. Hormone therapy and cancer especially is an important issue, especially in transgender males. We need to screen for cervical tissue if it is present, especially with subareolar annual breast examination if the mastectomy has been done. If no mastectomy, one should go for routine recommended mammograms. Uterine cancer again is not uncommon, one needs to have a surveillance for that. Ovarian cancer has also been reported but has been rare. However, this risk is eliminated once TH-BSO has been done. With transgender females, again, breast cancer screening as per guidelines. Prostate is something which is still there. So we need to have prostate cancer screening. The risk may be lower. Again, after the age of 50 years, one need to have an annual digital rectal examination as well as PSA assessment as well. With regards to long-term care, again, maximum feminizing and masculinizing therapy, the maintenance dose should be assessed. The lower dose should be preferred, especially with aging and lifestyle changes. And we need to lower dose and use preparations which are associated with lower CV risk. We need to revisit the dose, and with aging, we need to go for safer formulations. And with regards to long-term testosterone, again, they are associated with minimum cardiovascular CV risk, but probably we need to go for a lower dose, and probably the transdermal preparations may be preferred because of lower risk of rise in hematocrit. We have had several patients who are opting after the age of 45 for initiation or for continuation. We need to assess the cardiovascular risk and again use low dose estrogen and transdermal estrogen preparations. With regards to testosterone, again, transdermal preparations and lower doses would again be preferred. And with regards to post-operative or perioperative care, we need to optimize the risk. Especially with estrogen, we need to stop 4 weeks prior to surgery and again till the patients are ambulatory. Transdermal preparations may be allowed if the patients are severely dysphoric. We need to re-evaluate and stop. Post-operatively, we need to stop GnRH and spironolactone, and estrogen dose requirement may be reduced after orchidectomy. Again, in female to male testosterone, once you stop it, there is chances of reversal of masculinizing features as in return of menses, but generally testosterone therapy can be continued perioperatively as well. So in summary, hormone therapy, we need to assess the eligibility criteria. We need to monitor, especially for the adverse effects, the changes which are coming in, we need to reassure. And again, the risk of suicidal behavior is quite common. And with gender affirmative hormone therapy, however, there is decrease in suicidal and depression ideas. Before embarking on hormone therapy, we need to inform clearly with regards to adverse effects, the expected time course, and the irreversibility of certain changes, especially with regards to fertility preservation. We need to be upfront. We need to go for prior counseling before going for gender affirmative hormone therapy, because that's a medical legal issue as well. And also give the option of fertility preservation as well. Monitoring for complications, especially when patients are on gender affirmative hormone therapy, is very important, especially with regards to cardiovascular risk, bone health, and cancer risk. That's very important long term, especially in women, especially those who are male to female. We need to monitor with estrogen therapy. We need to monitor for venous thromboembolism, though the risk is lower in our population. And in the higher risk, we may consider using transdermal preparations. For female to male, probably use of testosterone, especially lower doses and transdermal, may be useful. And discontinuation of gender affirmative therapy prior to surgery and restarting post-operatively with modified doses may be advisable. So it's a challenge, and probably the guidelines are also developing, and we need to be updated as well. Thank you very much. Thank you for a patient hearing.
Thank you, sir. Thank you, sir, for your excellent deliberation. And the response from the hall shows it all. But as customary, is there any questions from the floor, please? If there is none, probably the
Well, again, this is mainly with estrogen. With regards to monitoring for liver function tests, the testosterone has no risk, and that has been removed by the Endocrine Society of US, that there is no risk, additional risk of with testosterone therapy and liver dysfunction. It's mainly with estrogen where there can be transaminitis and the metabolism can be reduced. And there we need to use the transdermal preparations.
Thank you, sir. So any other questions? So if there is none, then thank you, sir.
Thank you.
For your excellent deliberation. For now, we would like to call upon stage our own Professor Pradeep Mukhopadhyay, sir, Head, Department of Endocrinology of IPGMR Kolkata. Sir will be talking on some statistical jargon, like p-value. Is it a problem or is it a pleasure? Let's find out.
Good afternoon. I am really thankful to all those who are still here to listen to me. And as you all know, this talk is an odd one out in the midst of so many endocrine lectures by eloquent speakers from all over the country. Anyway, Dr. Parthopratim Chakraborty has entrusted me to do this job, hence I am trying to do my job as much as I can. As you all know, p-value, you understand that p-value is the most influential and the most ubiquitous statistical tool which is used in the biomedical research. But at the same time, it is said that it is most frequently misunderstood, misinterpreted, and miscalculated index. So before going to the subject, I have left this slide intentionally black with regards to the current situation. Now, the thing is that this is my disclaimer. I'm not a biostatistician, and I thought that you can have an opportunity to have a nap over the next 20 to 25 minutes. So I am entering my subject. So those who are particularly from the postdoctoral trainees, can you identify this person? Anyone? You may not be. There is some similarity with the insulin discoverer, and he is also contemporary to that insulin discoverer. I am not mentioning his name. This person is basically Ronald Fisher. He is basically the father of P, and the discovery of P is almost about 100 years. The P was first stated in Statistical Journal in 1925, so almost similar to the time when insulin was discovered. And actually, Ronald Fisher was a British biostatistician, and he is regarded as the father of modern statistics and biomedical research and experimental design. And he actually described the p-value in his article, which was published in Journal of Statistical Education in a British statistical journal. So as you all know, literacy. What is literacy? You all know that literacy is basically the ability to read, to write, to speak, to listen effectively and efficiently so that we can communicate to the world. And literacy is about 80% and maybe 110, 30% as you see in the picture. So going by the other thing, there is another term, statistical literacy. So what is that? Is this a jargon created by me? Not at all. For the last 10 to 15 years, the statistical literacy is a term which is very, very frequently used. And there is a very good definition of statistical literacy. This is basically the ability to interpret the data or the data summary and conclusion with respect to the context. Context means you understand the comparison, who are the comparator groups, what are the designs of the study, what are the confounding factors, the assembly of the statistics, and the other things by which the results are presented, the randomness, whether you understand the statistical significance, what does it mean, what is the chance phenomenon that can lead to this similar type of results, and finally you understand the errors and bias involved in the study. So these are the things you can see in the diagram also. The statistical literacy has several components, some knowledge components and some dispositional components. Now, what is all about? I'm trying to go through a skit which is used in the American Statistical Journal, and this is basically to criticize the human stupidity. What is all about? Why do so many colleges and graduate schools still teach us P 0.05? The answer is very simple, because that's still what the scientific community and journal editors use. So the question comes next, why do so many people still use 0.05? The answer is again very simple, because that's what they are taught in the school. So this is a circular story. And this is a thing that was published in the journal American Statistician and in 2016. So that is the all about P. This is taught, that's why we use because we are taught. Now, what is the correct statement about P less than 0.05? I can spend 30 seconds for this. You just have your answers first. If you want to deliver your answer, it's okay. Otherwise, keep it with you. I will discuss it later on. I am just reading it out. P less than 0.05 means probability that the null hypothesis is correct is only less than 5%. The second option is probability that the alternative hypothesis is correct in more than 95% situation. Probability that the null hypothesis is wrong for all practical purpose. Fourth is, if you repeat the experiment in about 95% of cases, you will get that the alternative hypothesis is correct. If you repeat the experiment, you will get in less than 5% cases that the null hypothesis is wrong. A non-significant difference means there is no difference between the groups. And maybe all are true. And maybe you are not very sure what is the actual answer. So I am not discussing. You will get your answer through my next slides. So first of all, I have to discuss where from the magic number 0.05 came. Is it merely a rule of thumb or a mutually agreed upon value within the statistical community? No, it's absolutely not that. This was elegantly described by Stephen Eckert through a conceptual experiment which was published in Journal of Statistical Education. This may be a busy slide, but I request you, particularly the residents, to go through this very nicely. The hypothetical experiment was like this: buy 2 decks of similar cards and create a modified deck that contains all red cards. So 52 cards are now red, which is with you. Now present the student with a game which is based on the color of the red cards drawn. As an example, say the first student who can draw a black card will get a $10 of rupees. So everybody will get excited. That's a new game. Randomly, the students are picked upon one by one, and then have them select a card, showing the card to the class. Put the card back to your deck. This is very important. Otherwise, if someone draws a similar card, then they will think that the deck is probably rigged. After 3 cards drawn, student will get increasingly excited, thinking that they might be the winner. But they are not still suspicious of anything. One by one, they continue to draw only red cards, 4 cards in a row, 5 cards, and at this point, you will hear some grumbling. Is the deck rigged? If the deck was fair, it is very unlikely that we would get 5 red cards in a row. Now, that is all about the experiment. Now, what is the take-home message from this Stephen Eckart's experiment? Investigate the probability of things. If the deck were fair, which means the probability of having a red card or a black card would be 50%, which means P is equal to 0.05. So probability of getting 4 cards in a row will be half into half into half into half, which is almost equivalent to 0.0625, means 6.25%. And probability of getting 5 cards in a row will be only 0.0315, which means 3.15%. At this point, students will definitely argue whether the deck is fair or not. That is, they reject the hypothesis that the deck is fair. So the null hypothesis of equal probability of getting a red versus black is rejected after 5 draws. The rounded off value between 0.0625 and 0.0315 is about 0.05. That is the cutoff to reject the null hypothesis that probably the null hypothesis is not correct or null hypothesis has something wrong in it. But it does not affirm that the null hypothesis is wrong or not. You can do similar experiments by using a coin that was used in the movie Sholay. Both were head, and finally at the last part of the movie you find that both the sides were the head, and what happened you all know. So to make it more clear, let us flip a coin 4 times. Suppose we get 4 heads. So what is the probability of such an event? Is 0.125. So does it indicate that there is a probability of 12.5% that the coin is fair? The coin is absolutely fair, but you got it. But the probability is only 12.5%. And you may have some knowledge in all of your family, there are certain members 1 or 2 generations back that there are 9 daughters in a row. So what was the expectation? There were a couple were expecting that they might have a male baby in the next point. So in a row, 9 daughters, the probability is only 0.0001%. So does it mean the chance of having a male baby in the subsequent pregnancy is less than 1%? It's always 50%. So null hypothesis is always, in these situations, true. But whether you are accepting this or not, whether that is in agreement with your statistical finding, that is the main question. That's why where the concept of p-value comes. So the real essence of that p-value is the probability of the observed result. What I have shown in the Stephen Eckert's experiment, that was the probability of the observed results to get 5 red curves in a row. So p-value is the probability of the observed results given the assumption of the null hypothesis that is true. And actually the value indicates whether the null effect is consistent with the observed value. I think you got it. So whether the null hypothesis or the null effect is consistent with your observed value, that is what you are saying. That is not the fact that you are saying that the null hypothesis is true or null hypothesis is wrong. You have assumed that the null hypothesis is true. So something what you have assumed, you cannot say this is wrong. The whole thing of p-value is based on the fact, on your assumption that the null hypothesis is true. You are not going to test whether the null hypothesis is true or not. So what does the p-value indicate? P-value is the probability whether the null hypothesis is rejected or not. And it does not measure whether the null hypothesis is true or false, since it is calculated assuming that the null is true, and it does not tell something that is already you have taken as right or wrong. The next conclusion is that p-value never tells you anything about the magnitude of effect. Say for example, I am comparing 2 drugs. One drug has reduced the blood pressure compared to another drug by only 1 millimeter of mercury, and statistically it is very, very significant, or not 1. So with this very high degree of significance, but only 1 millimeter of mercury reduction in blood pressure, does it mean anything? So the magnitude of effect is not reflected in the p-value. The strength of evidence, you may have got the p-value less than 0.05, but the strength of evidence comes from what? It comes from the design of the study. What were the inclusion and the exclusion criteria? How stringent was those criteria? Was there any publication bias? Because most of the time, the negative studies were not published. Finally, what statistics you have done? Were there any confounders? Have you adjusted for those confounders? Were you allowed to adjust your values with those confounders? These are all the things which actually determines the strength of evidence, and p-value has nothing to do it. So p-value is less than 0.05, so everything is done. It's not like that. At the same time, the replication, p-value has a very poor replicability. If you do it with a sample size of 30%, you will get a p-value. But with the same question, if you increase the sample size, the p-value may be more significant, maybe more non-significant. So p-value is absolutely non-replicable. That is one of the another major challenge with using p-value. P-value, when significant, does not suggest whether the alternate hypothesis is true. It has nothing to do with the alternate hypothesis. You are not doing anything with the alternate hypothesis. P-value only tests whether null hypothesis is to be accepted or rejected. Finally, p-value of 0.05 does not mean that there is a 5% chance that the null hypothesis is true. And it does not imply that there is a 95% or greater chance that the null hypothesis is incorrect. It merely means whether a null effect is statistically consistent with the observed results. So a low p-value indicates that the observed data do not match with the null hypothesis of your assumption. So be alert. before thinking of p-values, you should assess the science, develop your hypothesis first. If the study was not well designed, the results in most of the situation will not be informative at all. It does not matter what your p-value is. So first of all, you have to review your assumptions of the analysis. You have to choose and make that you have not violated any assumptions. And if you have violated the assumptions, p-value is of no use practically. P-value will not tell the researchers how likely it is that the medicine is working or not working probably. So it will not tell whether the original hypothesis is true or false. So as I was discussing in my previous slides, there are two panels. In the left side, you can see that there are two studies. In both the studies, you can see the percentage benefit is 10% in both the studies. But in the left side, the study shows that is only non-significant benefit. But in the right side, it shows that there is a very high degree of significance. And this was only done by increasing the sample sizes only. Whereas in the right side of the panel, the similar type of experiments were done, and both the studies have similar degree of statistical significance. But you can see how much the percentage benefit or treatment estimate varies. So p-value is not everything that is given by your statistics. Now, it is very frequently said that when you get p-value less than 0.01, your data is more robust than when you get the p-value less than 0.05. Obviously, p-value less than 0.01 is statistically more significant. That means you reject your null effect more strongly with respect to your observed data. But it does not signify that your experimental findings related to alternate hypotheses are more robust when p is less than 0.01 as compared to p less than 0.05. Now, problems with multiple tests. It is very frequently said, and as of now everybody probably knows, that it increases actually the type 1 error or false positivity, and hence the significance level must be adjusted. I again want to tell it through a story. Suppose one of my students I have asked him to go through a chapter, and the thing is that I will assess him by asking him, say, 4 questions. And I have given you that if you can answer 2 questions out of the 4 questions, I will think that you have gone through the chapter nicely. And you failed. So you have requested me to take another test. And on the second time, on a second set of questions, you again failed. Third time, and another set of 4 questions, you again failed. So if I repeat the experiments continuously, there is a chance that can come that you are able to answer the questions. So on repeated testing, that increases the false positivity in a situation where the fact is that you have not gone through the chapter. So it means on the repeated testing, false positivity rate increases, and in that situation, if I want to know whether you have really gone through the chapter, if I want to do another test, what I have to do? I have to give you another set of questions with increased number, maybe 10 questions, and I have told you that this time not 50%, you have to answer at least 75% or more, which means I have increased the significance level, which means I have reduced the alpha error level from 0.05 to say maybe 0.01. So on repeated testing, using the same value is not allowed. It just increases the false positivity rate, and this is very, very frequently done in most of the journals that we read. So I could not tempt myself from showing this slide. This is a journal published under the leadership of Dr. Sujoy Ghosh, and where we have compared the clinical parameters and the different other parameters between DKD and NDKD, and this was published in BMG Open. And I do not know whether you can see here, I have highlighted it blue, and it is written over there that we have taken at least 30 variables. So we have taken a significance level of less than p, less than 0.001, and only those parameters which were taken a significance level of less than 0.001 were actually significant or different between the groups. So next, coming to the subgroup analysis. P-value less than 0.05 does not carry any good news. Even if this is a pre-specified or pre-hoc, the sample size was not calculated for the same purpose. Suppose a drug was found to be beneficial in a group of, say, 3,000 patients. Now you want to know whether the benefit is same for males versus females. So you have separated the males versus females, but you have not measured your sample size based on your sex, so you cannot use it. Otherwise, this is absolutely unpowered. So for subgroup analysis, a p-value of less than 0.05 does not carry any significance. You can go and see in the text, in the journals, that when subgroup analysis are done, p-value are not given, only the confidence interval are given, and only another thing is given, whether there is any interaction between the p-value, which means actually whether there is any interaction between the male sex versus female sex to have the result. So whenever you do some subgroup analysis, you cannot use that thing like that up, because that is not powered enough. You have not calculated your sample size. You cannot use p less than 0.05. So next is difference between p-value and alpha error. Alpha error is the thing which you set before you have gone to the experiment. And alpha error is basically the false positivity error which you have determined before the thing. So suppose you are doing an experiment on cancer research. In that situation, you should not take a 5% margin of error. You should take a margin of error of 1%. But in other situations, 0.05 or 5% error is okay, and you can calculate the sample size based on that. But p-value is the posterior probability. You have done the study, now you are calculating whether your p-value is conforming to the alpha error or not. So basically, p-value and alpha error are same thing. One of them is used before your study is done, and p-value is that thing which you have calculated after you have gathered your result. So be happy if you have a p more than 0.05 in certain situation. So for example, normality testing. For continuous data analysis, whether the sample size is not large, one must check the data for normality before applying parametric tests. There are several parametric tests, Sapir-Whorf, Kolmogorov. Here the null hypothesis is that the normally distributed data. This is your null hypothesis. So the test was done. If p is more than 0.05, that means your null hypothesis is not rejected. So null hypothesis is accepted. So your data is normally distributed. The same thing as I have already mentioned in the subgroup analysis, p-value for interaction. If there is any interaction, that means p will come less than 0.05. If there is no interaction, it will come as more than 0.05. And similarly, another example, homoscedasticity test, which is known as the comparing the variability, the ST of two groups which you are comparing, and that is done by F test. And in F test, if the standard deviations of these two groups are grossly varying, then you cannot use the test of significance by using the unpaired t-test or other tests. Now, p-hacking, this is also very important. This is also known as data dredging or data fishing or harking, is an exploitation of your data analysis to discover the patterns which is presented as statistically significant, which in reality is not truly present, and there is no underlying effect. Can I take another 5 minutes? So these are the methods by which the p-hacking is done. You can see here, you can hack your data by several methods, by repeating your experiment, by increasing your number of samples, by converting the data by some adjustment, and there are many other ways. These are only to get until you get a statistically significant result. So before doing any test, before doing any statistical application, you must know what are the assumptions of the test. I have given here the assumptions for t-test. The data must be continuous. There must be independence of the data. There should not be any significant outliers. The data should be normally distributed, and the data must be homoscedastic, which means there is no variation in the standard deviation. Unless these assumptions are met, the p-value use is basically not met. A hierarchy of tests in RCTs. In almost all situations, RCT is done to test only one hypothesis. With event-driven trials, probably a single outcome may take a long time to reach adequate number of outcomes with huge cost. Hence the concept of 3-point mesh in CBOT trial as primary outcome, which is powered after sample size calculation. So you obviously understand that the secondary outcomes are not actually powered, and secondary outcomes, if at all powered, you don't have the permission to use the same degree of significance. You have to check it by using much more stringent p-value for testing all those things. So secondary outcomes may be powered by virtue of other things, but if at all they are powered, you are not allowed to use the p-value less than 0.05. So this is an hierarchical test, and you all know declare TIMI where the primary outcomes were not met. So subsequent all other reports were exploratory in that study. In any RCTs, unless the primary outcome is met through the statistical significance that you have pre-specified, you are bound to know that almost all of your results, even if they show statistical significance, are absolutely exploratory, which means you have to do another RCT that is to explore that hypothesis that this might be the phenomenon. So p-value versus now p-value less than 0.000 by a software. Never report like this. This is only a তাহলে কি করব? আর একটাই স্লাইড আছে। এটা কি ইনজুরি টাইম দিবি তো? ও 2 মিনিট। So, thank you. Very frequently you can see when you use different statistical software that p-value is given as 0.00. Never report like this, though there are several journals, they give the significance level as 0.000. This is only a truncated but not a rounded representation. And you can see in the last line, a p-value of 0.0009 would be truncated to 0.000, but would be rounded to 0.001. So recall the probability of observing certain results from your sample or the results of the more extreme and assuming that the null hypothesis is true. Now, can you construct an artificial example where the probability is indeed 0? Yes, you can construct. But in that situation, the sample size will be very, very large, which is not practically possible. So always follow journal's guideline to use the p-values, how to use it in the journal, and always use as per recommendation of the journal that you are sending your articles. So how to present your p-value in the study? So I've given some examples. The drug A reduced fasting blood sugar more significantly in steroid-induced hyperglycemia as compared to B. Mean reduction is 22 plus minus 14 versus 17. And then you mention the p-value. Not just the p-value is less than 0.05. And you must mention the statistical tests that you have applied in the methodology and the result section. In the abstract, you can omit the SD. And there are other examples also. I'm not going in details of this. So I request all of you to go through these journals, a dirty dozen, which are about 12 misconceptions about the p-value. And finally, the first slide again. So you can now understand that none of the above statements were practically true. So with that, I stop. Thanks for your tolerance, but your silence do not prove whether you have enjoyed.
Thank you, sir.
Thank you.
Sir, that's an indeed, and a great presentation. So, any questions? I know that there are bound to be a number of questions, but time is limited. So, any questions from the hall? So, every delegates are requested to proceed to Hall A. There is Subhash Mukherjee Hall. And after the scientific symposium, we have a quiz from 8 p.m. to 8:30 p.m.
We have audience interaction with the faculty as well as a quiz for audience with attractive prizes. So everyone be there in Hall, Subhash Mukherjee Hall.